often, and it's quite difficult macroscopically to distinguish between tumoral and inflammatory infiltration when we don't find an easy gland effect. So why is it important to push the limit of venous? Air0 is one of the most important factors for survival, as shown in this meta-analysis from the group of Verdecke. The second, neoadjuvant treatment, which is more and more frequent also in tumoral. So the limiting factor for resectability is the possibility for reconstruction. And we have very codified way to reconstruct structure, wedge resection, anastomosis, and graft in position. When we look at materials and types of graft for wedge resection, autologous materials should be preferred as falciform ligament, parietal peritoneum, gynoid fascia, or autologous vein. And for the grafting preposition, also vein like iliac, renal vein, internal jugular, or femoral iliac, good size for construction, and should be preferred. When we have large resection, we don't have to forget some maneuvers that can help us to gain length, as the cattle brush maneuver, liver mobilization, or mesocolon section are described to gain length and to avoid interposition, which has a higher risk of thrombosis, and so have to have a better surgical outcomes. When the splenic confluence has to be resected, splenic management, we can just leave the splenic vein ligated. It is described, and we have several ways of drainage that can take in charge. But actually, up to 60% of patients can develop segmental portal hypertension. So splenic vein resection is recommended, even if lateral circulation can be preserved. And a direct connection to the mesenterico portal axis is feasible, but we really have to pay attention to avoid tension or torsion. Sometimes the length will be not enough. So a splenorenal shunt can be easily performed, or a connection with the inferior vein. And this is the best way to avoid complications later. Looking at patency, we have mentioned that autologous material has the best outcome. We can see that up to 80% of prosthetic grafts. And actually, I didn't find in literature any clear recommendation for anticoagulation or antiaggregation in the postoperative period. In larger series, the global morbidity and mortality is similar with Venox resection standard procedure, but if we look better at what kind of reconstruction is performed, segmental resection or graft interposition brings a higher morbidity and a higher risk of thrombosis. Venous resection is also associated with a higher R1 rate, and this is probably more related to the biology of the disease more than the local anatomical position. As we can see, local recurrence is not really different if we perform a tangential or segmental resection. So it is probably related more to a aggressive disease that involves also the mesopancreas and micrometastasis. So this relates to a significant worse outcome in resection with venous, in pancreatic resection with venous reconstruction. I bring the example of the Dutch group, where majority of patients underwent also adjuvant treatment. But what I found interesting is that only 40% of patients actually received the neoadjuvant. This could be maybe a point of discussion later. And if we look specifically to the venous invasion, actually this is found in about 100% of cases, and is the real invasion of the vein that is in fact a worse outcome. This is our experience. We have a case load of about 80 cases here to surgeons, and since the last 5 years, we performed 155 pancreatic resections, 62 repos for pancreatic head cancer. We perform venous resection and reconstruction in more than 60% of patients with primary closure, patch confection, and end-to-end anastomosis as preferred reconstruction with a patency of a little bit more than 80%. If you look at those patients, the neoadjuvant treatment was performed in more than 60% in the venous resection group. And actually, we firmly believe in the benefits of neoadjuvant treatment. So during the time, more and more people are proposed to a neoadjuvant treatment, even if they are classified as formally resectable tumors. The postoperative surgical outcome is very similar. We don't have a difference in morbidity, very low percentage of fistula, and didn't avoid the access to another treatment. Cavernoma management can be very challenging. So different types of shunts have been described, and one of the masters of these kind of actions. And we present the case of a patient that had a complete occlusion of the mesenteric conference. It's a 77-year-old. He also had a thrombus distal to the was not tumoral, that was seen on a PET CT scan. He underwent a neoadjuvant treatment with gemcitabine with no toxicity, and at restaging, we found no progression. So actually, we went to resection with a temporary mesenteric bypass, as described by Professor Bachelier, and this could lead us to safe resection. And the reconstruction was performed with a graft of a superficial femoral vein, which in our experience is very easy and accessible with a very good caliber and not more morbidity for the patient in the postoperative period. So this patient did very well. This is the postoperative CT scan. Is now under anticoagulation also because of jugular thrombosis and very compressive stocks with no claudication. And actually, he's still on adjuvant chemotherapy. So our take-home message is venous resection is something that is well codified in literature, and it doesn't bring any morbidity, supplementary morbidity in the postoperative period. Of course, an accurate preoperative planning is, and actually, I think that the promotion of a neoadjuvant treatment also for patients classified as resectable can be discussed. A step-up approach can be considered, and then tangential or end-to-end reconstruction whenever possible. Falciform, ligament, rotas, fascia are very good patches that can be used easily found in the abdomen. Otherwise, autologous vein must be preferred. And the temporary mesenteric bypass in cavernoma is something to consider in the case of a complete occlusion with circular collateral circulation. This was a real game changer for us in our experience. Thank you.
Any question? You want to discuss it? The room. Any question? Okay.
Thank you for the presentation, good experience. Several comments. First, the lateral resection, tangential resection, I think, without and stop to do that because this kind of technique is discovered during the operation, it's not planned before. Or we have to consider the, for us, it is the first step of the locally advanced operating plans. For the situation with involvement of the vein, when we to assess that part of course, we send to the oncology. The neoadjuvant chemotherapy. Because now, when the patient is fit for this, but so with the imaging now, we are able to predict the venous a day or involvement. So it is not a good technique with supposing with the decrease of the survival has been proved several publications. So I think we have to avoid this discover and, and stop this technique. I think at the beginning, start to do the venous resection, you are a little bit anxious and afraid for this huge anatomic dissection you need for doing that. And you have the consequence is to put the prosthetic graft or venous graft or venous graft. But as described by Nakao, Nakao is a very old surgeon now from Japan, and we learned a lot of Japanese technique. When you mobilize all the mesentery, you don't need, you can resect 15 centimeters of the venous axis, mesenteric vein and portal vein, without need of any graft. So, and you show that when you do end-to-end anastomosis without grafts, you decrease the rate of the thrombotic rate. So it is my comment. Thank you for doing that. I think we have to learn every day when you do this kind of surgery. You learn every day. You can teach to the others.
Thank you for the comments. To answer your first comment, actually, I completely agree. We have a policy for neoadjuvant treatment for all patients now. So every patient is assessed by oncologist, and upfront resectable actually at the moment is just for patients that don't tolerate neoadjuvant chemotherapy, and they have a resectable status. Of course, the preoperative planning has to be very accurate, and I think we have all the technology to have a complete vision of the vascular status in the preoperative period. In our experience, actually, we tend not to try, when we find like a lateral little contact with the tumor, we try not to dissect it, to do wet resection. So it didn't bring any supplementary morbidity in our experience. So actually, for us, it's a safe way to avoid maybe a airway resection and not insist in a dissection that it doesn't come easily. But I completely agree for the neoadjuvant treatment that is very important, and it will take more and more place in the current practice.
Yeah, Alessandra, only a small technical point. It is not possible, instead of the shunt between vertic vein and the portal vein, to put a stent inside. It is not a thrombus, it is a compression. I mean, the vertic vein is compressed by the tumor. And in some case, in Paul Rouge, we pass a metallic stent. I think in some case we did that 1 week before the operation by a small incision to have a jejunal vein and to pass the stent, a metallic stent, expandable, and the portal hypertension disappear totally. What do you think?
Maybe it can be considered for segmental short occlusion. That could be a solution. For this case in particular, the occlusion was quite long, so we didn't consider this option. Actually, putting a stent can, if it's very long, can bring some difficulties in the reconstruction. But probably if the occlusion is very short and segmental, that can be considered as an option.
Philippe, what do you think?
Yes, good idea, but.
You did it,
But.
but what?
No, I think if you put a stent, you propose, as you can do that preoperatively.
Yes.
That's the case. It's an option. When you dissect the root of the mesenteric and the portal axis, I think it is not very easy with a stent. And stenting may induce some inflammation around in this area. And if you put this stent, it means the tumor is surrounding all the venous axis. So there is also suspicion mainly of arterial contact. If there is arterial contact, you have to be prepared to resect the artery, to do disvestment as you want. And in this situation, the problem is not the venous stenosis. The problem is the resection, reconstruction, dissection of the arteries. So you need time. If you need time, I think the best way for us is to put the venovenous shunt, mesenteric shunt, during the operation so that you suppress the portal hypertension. You don't care about the tumoral area. Focus on the dissection of the arteries. It's, for us, the simplest way to do this kind of operation.
Speaking of time, I want to discuss about the maximum time you can clamp the mesenteric vein, because you need first to dissect, then to take off all the specimen and to reconstruct. And how long do you accept as clamping and put or not a shunt?
Because actually the best way is to leave the venous contact as the last part of the
Yes.
dissection, so that you spare time. And I think maybe I'm not as quick as Professor Bachelier, but I think you can tolerate up to 20-30 minutes of clamping. And if you think it will take longer, you can perform a clamping of the mesenteric artery, just not to get too much congestion. And the bowel can tolerate that.
No, yeah. When you are there,
There is many conditions different. So we put the stent, mesenteric portal stent, only when there is a total occlusion or subtotal occlusion of the venous axis. With the stent, we don't care the venous during all the operation, because we focus, as I said, on the shunt. Alias, mesenteric portal. If there is no occlusion of the vein, stenosis, you don't need stent.
Effetto grotto pescatori.
at the end of the fixation when
Yes.
everything is free.
Everything is free, but you have to resect, then reconstruct. So 30 minutes.
If you close the survey,
One hour.
But usually it's for the long.
It is maximum.
I noticed that if you clamp, even when there is no portal hypertension, when you clamp more than 30 minutes, you have congestion and you clamp the artery too.
Yes, sure. You have to do that, but yeah, at least the means. And when you are used to do this reconstruction, it takes 15.
Yeah. Agreed. When it's easy, it's 15 minutes, 20 minutes. Yeah. If
Thing
it's
is-
not, it's longer.
For us, the bypass, not the shunt, the bypass was a game changer. I mean, it's not too difficult to do it. And immediately the
Mhm.
pressure goes away
Of
and
course.
your pressure goes away too. Moving after you've done all the reconstruction. I wanted to know about, I think, has everybody abandoned the tangential reconstruction? I mean, I honestly think that if you have a big vein and on the other side, free margin, a patch of round ligament is an easy procedure, and we are very liberal with it. Huh? Because I mean, in pancreatic cancer, you are it all plays mainly on the posterior side, the R1, and you have sort of half of the portal vein and the mesenteric vein free. Appreciation.
You don't have
that
a
you are
frozen,
free.
you don't
I
have a
don't-
frozen section I.
Yes, but pardon?
You don't provide us.
No, but we
perform
meet
frozen.
all the time.
All right. On the patch that you
Yeah.
remove.
Yeah, always.
So we do it.
You do end-to-end. No, you just.
The splenic vein,
Splenic vein is yes, it's very interesting. What about the left gastric vein? That, okay. And you do more splenorenal shunts or your reimplantation of the splenic vein? What's your recommendation?
for the
We reimplant if it's possible.
similar conditions.
When you have to resect the vein, very often you resect more than 3 centimeters in transversal dimension, so that you resect the terminal part of the splenic vein for 3 centimeters. If you do that, with the combination of the resection of the confluence, you are not able to do an anatomic reconstruction. Very often it is like that. It is very seldom to do the anatomical reconstruction. Only when, if you decide not to do tangential resection, you resect the confluence, you can keep all the length of the splenic vein, so that you can do an anatomic reconstruction. In the other case, you have to reimplant the splenic vein. We do that systematically just to avoid hypertension in the upper left quadrant. So it's very important if you want to keep alive your patient for 10 years. If 6 months, it's no need, but 10 years is better. And what we can do, you are different options. The best and the easiest way is to implant the splenic vein into the renal vein, left renal vein. It's just because you do that immediately after cutting the vein. And you don't care for the rest of the operation, you don't care of the vein. The other option is to implant when it is possible, when you have a big inferior mesenteric vein, You cut the inferior mesenteric vein and you do an end-to-end anastomosis between the splenic vein and the inferior mesenteric vein. I think it's better because you keep the flow into the intestinal area and you increase or you maintain the inflow portal, the portal inflow. If you do a splenorenal shunt, anastomosis, it is not the same.
Thank you very much.
Good morning. Just want to have a thought for my mentor, Daniel Jacques, who passed away last December. He was an exceptional guy. And he was in love with Asia. And during his stay in Asia in the 1970s, he met Kuntatung is in the center, and Daniel Jacques is on your right. So he passed away, and probably his soul is floating over the Mekong River now, just to the south of him. Now, arteriorization during pancreatectomy, it is not a new technique because it has been described by Faulkner more than 50 years ago. The results were not very good and nobody was convinced of this technique. But now we have chemotherapy, we have new strategy, we have neoadjuvant chemotherapy, and with this treatment, we can discuss for some selected patients the indication of surgery, include, not adjuvant, include in the strategy. So there was some pioneer. I belong to these pioneers, and 20 years ago, we jumped out the box, as said, Guido. Guido is not here. And some stay in the box, but I invite this guy who, because the box is still open, to jump out and reach the community that described now guidelines for the treatment, surgical treatment, but associated with chemotherapy, guidelines of treatment of locally advanced pancreatic cancer. In the more and more series that has been published and that will be published in the next future, there is a mainly left pancreatic resection as Appleby procedure, with or without, we can discuss about that, arterial reconstruction, as you can see here. But the most challenging is the resection and reconstruction of the SMA. We did, and there is several procedures. The simplest is to perform end-to-end anastomosis between the thumb and the distal thumb. You can interpose the saphenous graft, autologous saphenous graft. Very important, we can discuss about the need of autologous. And a difficult procedure is to reconstruct the branches into the root of the plant. In the pictures in the middle. So we standardize this technique. Professor Adeo calls that technique. It has been published. And it is thanks to this shunt, not stent, shunt, this portal shunt, we were able to do this procedure. But I didn't invent. Is coming from the Japanese experience. Nakao describes venovenous shunt in 1990. It is very old. We never were able, we were never able to import this shunt because of a CE label. So that is the reason we developed this shunt using prosthetic graft. But what we learned doing this arteriorization as a pioneer is success. It's very important that the success of arteriorization reconstruction, or SMA especially, depends on the quality of the associated venous resection. It means sometimes before to put the mesenteric port pass, we have to reconstruct branches of SM veins, jejunal vein, ileocholic vein. And you have to reconstruct before to implant the shunt, because the end of the operation, if you remove the shunt, there is this tissue are very fragile. And you are in the emergency, you have clamped the SMA, and you have two branches to put into the remaining portal vein. It's too difficult. So the advice is to, when you implant the shunt at the beginning of the operation, you reconstruct immediately the branches of the vein into the root of the mesentery, and you implant your angioplasty into the shunt. It's better, in your opinion. So you can do everything. You can use autologous vein. In this patient, we used heterologous vein because we needed tissue. And if you can see very well, there was 4 branches, not artery, it was vein. So we published our previous results in 2020 with a series of 1 patient. And we had surprised to see patients surviving at 5 years. But the median survival was not so good. 30 months was not sufficient. But what was important, we didn't kill the patient. And more than that, we have patients with a good quality of life. You can see on these pictures, different date of operation. They can survive, but in good condition. So now it has been admitted by all the surgical community. Now, when chemotherapy done as palliative treatment or as neoadjuvant treatment, when there is results, responder patient, you are allowed to discuss pancreatic resection. So, you know, the theory has presented a picture, and we decide to see if there is a difference of short and long-term post-op outcome in function of the type of artery resection. So we have almost now 300 patients, and we decided to do this study only on 278 patients, just to have time to evaluate, to assess the stock. So we describe 4 types of arterial resection. First, resection without reconstruction. 10% of our patients was at the beginning of our experience. End-to-end reconstruction, graft interposition, and multiple arterial resection and reconstruction. And this reconstruction was a resection interested hepatic artery, celiac trunk, or others, and there were some variation. You can see here the results with the patient characteristic and the can see this patient received in 20% of the case FOLFIRINOX. And the mortality is 4%. With half of this patient, in half of the patient, the cause of mortality was vascular complication. Mortality, and when we see the different type of resection or reconstruction, as you can see, SMA, hepatic artery celiac trunk, there is no difference in terms of mortality, morbidity, and survival. But survival increase in our theory now. And if we do the classification in function of the type of arterial resection, you can see there is also no statistical difference. There is a little bit more morbidity and mortality in case of complex multiple arterial resection. So you can see the overall survival now increased to 20 months with 5 years survival of 74%. So it is better. If we compare the survival between the different arterial resection, you can see there is no difference, statistical difference. One point is very important. The major morbidity in left pancreatectomy is the morbidity induced by the pancreatic fistula. And we have deaths about complication, pancreatic fistula. We have no pancreatic fistula when we perform duodenopancreatectomy. Of course, total duodenal, but also Whipple. So we try to isolate risk factors for mortality, morbidity, diabetes before operation, multivisceral resection associated with the pancreatic resection, massive transfusion related to the extent of the resection, and pancreatic fistula. We try also to isolate risk factor for the survival, and we isolated only 2 when it was possible with a high level of CA99 before operation, a good decrease, significant decrease of CA99 during chemotherapy is a good indicator of survival. And the size of the tumor is correlated to the T stage. So I can conclude we increase with this strategy because the surgeon is not we are the main factor for this strategy, of course, but the disease is treated not by the surgeon, but by the oncologist. And if we compare the patient with microscopic disease, residual macroscopic disease, the result won't be very nice. So we have to select more the patient with other things than clinical criteria or imaging criteria. So maybe in the future, but we can, with observing the results of the chemotherapy, the patient, and with that we can increase the survival, which remain now, which is very acceptable. The type of arterial resection is not doesn't influence the outcome, but what we can say, the results depend on the complexity of the resection. Maybe there is an option, as I told Kato yesterday, to do total removing with cooling of the specimen. Maybe we have to try, but in pancreatic cancer, I am a little bit reluctant because when you put all the mesentery, the tumor, and everything occurs into a bath with water, and you mix everything, for pancreatic cancer, I think I worried about the results in terms of survival and working. So the complexity is risk factors for the postoperative course. And what is important to select this patient is the decrease of the CA19-9 and also the size of the tumor you can appreciate preoperatively with the imaging. Thank you very much for your attention.
Thank you. Very impressive. Also analyzing the long-term outcome of these patients. Questions from the floor? Yeah.
Thank you for the nice talk. Just have a question about arterial disease before surgery. If you have stenosis of the celiac trunk or disease correlated to diabetes, maybe, do you show worse outcome with arterial resection and reconstruction if there is calcification in the artery or not? Did you show that or see that, or you don't propose surgery to people with arterial disease, calcification of the vessels? Thank you.
Yeah. Good question, thank you. I think for this patient, we have to select the patient. It's very important to select because they need to be fit for the operation. It's a long operation, especially when we resect the SMA. 10 hours. We start with 15 hours, and now the mean time is 9 to 10 hours. We cannot decrease more. When we resect SMA, hepatic artery or Appleby procedure is about 7 hours. When we do reconstruction, because we systematically reconstruct the hepatic artery, not the celiac trunk, because we resect celiac trunk and hepatic artery, and we reconstruct hepatic artery. If there is a right replaced hepatic artery, we resect the celiac trunk and hepatic artery without reconstruction. For this special condition, we can operate everybody. But for the other one, if there is arterial disease, like big atheromatosis, we have to think about what can happen. Very often, we have to face a lot of patients with coronary stent, with anticoagulation, pathological factor, a lot of risk factor independent of the pancreatic disease. So there is, it is the job of the anesthesiologist to see if this patient is fit or not, but also our job. And if there is a disease of the artery, you can have patient with a lot of atheromatosis in the coronary trunk, in the aorta, and the iliac arteries. But very often there is no atheromatosis on the digestive arteries. Very often for this patient. If there is occlusion, imagine there is occlusion of the celiac trunk by atheromatosis, and occlusion or sub-occlusion of the SMA. If the patient is 40-year-old, I think it's not a good candidate. Obviously, if it is 80-year-old, stop. You know what I mean. So I think it is a global evaluation, not only by this conformation of the artery, but what I insist for that, I said before, you have to decide the operation before the operation. We have imaging, do the plan of the operation, we do exactly what we have cut, and we do a drawing, and we cut at the same place as you imagine. There is no surprise. This surprise is the discovery of subcapsular metastasis in the liver and peritoneal, residual peritoneal deposit.
Thank you very much. We have 2 questions, 3, 4, 5, 6, 7. The order is Laurent Chiche first, and then Daniel Cherki.
Thank you very much. Very beautiful work. I want to, you showed that pancreatic fistula is a prognostic factor of morbidity. So you didn't say you, in what condition you are doing a total pancreatectomy, because our concern when we do this type of reconstruction is to have a fistula and well, cerebral aneurysm. So don't you think that it is safer to do a total pancreatectomy when you are doing those very difficult reconstruction? This is my first question. And my second one is about Appleby. I don't understand why you reconstruct the hepatic artery always, because when there is a gastroduodenal artery, the liver doesn't suffer.
Yeah.
I will start with the second question.
As you like.
It's too easy to answer because different step. First, we, as everyone, we try to embolize the celiac trunk and the hepatic artery before doing an Appleby. We did, I think, twice or 3 times. We were not convinced. Second answer is you are aware of this big study of the North European country with 18% of death after Appleby procedure. And for this patient, in the big majority of cases, they didn't reconstruct hepatic artery. What happened? In this patient, fragile patient, you imagine there is a good flow from the gastroduodenal artery. But if you remember well, in 1953, when the procedure was described by Appleby, he describes that for about gastric cancer involving the. And now Appleby is for the pancreatic surgeon only devoted to a pancreatic resection. So that if you keep only the gastroduodenal flow, you have to keep in mind there is a division of the flow, first for the stomach and the liver. And the stomach needs a lot of blood. And what happens if you don't care, you have not enough flow, and there is a necrosis. So why? 1 week, 2 weeks, necrosis of the high part of the stomach with a perforation, and this patient died from peritonitis. I answer. So we systematically reconstruct. We also have a medis team to check the flow in the arteries, but I think we have to be systematic. We resect an artery, it's very, after resection, we have a big space to reconstruct. And it is a question of training also for arteries. If you don't need this reconstruction, the nature will answer to your question. Yes, you will get a thrombosis if the flow is not sufficient in the reconstructed artery, or if there is a big flow in the gastroduodenal artery. With a different flow, you will get an obstruction of your reconstruction without any consequence. First question. First question was how we decide to do total pancreatectomy. I am reluctant to do total pancreatectomy because the quality of life after pancreatectomy, the total pancreatectomy is very difficult for the patients. They receive chemotherapy, they have total pancreatectomy. If they were diabetic before, they're completely diabetic. And if you had to add another chemotherapy after adjuvant chemotherapy, even it is like, it is very difficult for the patient. So we try not to do, but in some conditions, with a big tumor in the middle of the pancreas, you have to do. We do, I remember 17% of our pancreatic resection are total pancreatectomy, but only due to the position of the tumor and the involvement. But it is a very good question because looking at the results, we have a big rate of pancreatic, big for us. Don't remember exactly 8%. And this complication is very serious and lead to the death of the patient with a pseudoaneurysm, a perforation, and so it occurred when, at the same time, we were the celiac trunk and the hepatic artery with also the vein. And what I can say now, after learning of this complication, I think extend the left pancreatic resection to the right, the vein, is not a good solution. Even if you keep the gastroduodenal artery. I think what you need to resect the vein, not only for the small invasion of the left side, but circular involvement of the vein. You have to stop and do a total pancreatic. This is my conclusion.
Thank you. We had plenty of questions, but we're running late, so I take one question from Antonio. Yes.
Thank you, Philippe. Very impressive results. My first question is about when we plan to perform arterial resection, it's important to avoid radiotherapy. In your theory, there is no neoadjuvant radiotherapy. It's an important point. The second point, how long the best duration of neoadjuvant treatment before the surgery, and do you see any impact of the duration of the chemotherapy in your short-term and long-term results?
Radiotherapy. In this series, there is, I don't remember, some patient, we were referred from other center, I think less than 10 patients. 6, I don't remember exactly. And they came because they had no treatment for months. After 6 cycles of FOLFIRINOX radiotherapy, closure radiotherapy. And the surgeon and the oncologist say, okay, bye-bye, go home. Okay, the patient was in a search of a treatment, so he came back. There was no recurrent, no growth of the tumor, so we decided to operate. But there was complication because the tissue after radiotherapy was not the same. And if you want to attempt arterial reconstruction, it's very difficult with complication. Only on the arterial reconstruction, but creating fistula. Pancreas is very sensitive to radiotherapy. Get fistula, especially from left. The one question was the number cycle. Good question. Everybody asks this question right now. In France, you decided, I say you because I didn't agree ago. And they decided to do 6 cycles. Not enough. You can see now the results are here. It's evidence. We started 12 because we sell X by 12. No, I'm joking. No, our oncologists say, okay, 12 cycle. Okay. Want to start with cycle? And we try with 12. 12, that is a little bit too much because patients are very tired after 10. So, and we look in our results, we have the feeling the cutoff is 9. I don't know. Probably the next study in the European community will answer this question. I don't know exactly. But what I can say, after 4 cycles, some patients respond very well. If we continue, they are not so good before operation because they don't tolerate the chemotherapy. I think these patients should respond, probably. We have to prove that. And sometimes, after 12 cycles, there is no respite. But the patient, I don't have an answer.
There was one last question from several. Diarrheas after this reconstruction.
Sorry.
Diarrheas.
But it is motrice diarrhea. Motrice, it means it is not infectious. It is just reflex. They eat, they have diarrhea. They don't eat, they don't have diarrhea. Motricity of the small intestine, not the colon. It's very important to know that. If you treat with loperamide, loperamide induces paralysis of the colon. You increase the diarrhea of loperamide. Why? Because you don't suppress and you suppress the motility of the colon. So that there is a big colon with a lot of stool inside. With infection, you add infection to the motrice diarrhea. So you increase the problem. So what I said, we have 3 to 5 diarrhea only during the day. Because diarrhea is in the fever. It's very simple, like the duck. You've seen the duck in a farm. You don't eat during the diet, you don't have sleep. So it's this phenomenon for 3 to 6 months. They have to tolerate. They are advised, nothing to do, only education. Motricity of the sphincter. And no drug.
Right. Thank you very much. We move on to Pietro Deo. Thank you.
Hermans, dear colleague, thank you for this kind invitation. I will talk about some data about R1 resection after those type of extensive pancreatectomy and long intensive FOLFIRINOX induction based chemotherapy. When we were treating patients with upfront resectable pancreatic cancer, everybody knows that when you get an R1 resection, this impact the prognosis. Those are patients not receiving any form of neoadjuvant chemotherapy. In these patients, the question is, maybe there is a technically, from a technical point of view, is an insufficiency of surgery. This is a clearly flow of surgery. But we already also know that when we changed our definition of R1 resection, we get so many R1 resection. It's a kind of millimeter wall, meaning when you go far at 2 millimeters, the rate of R1 resection is about 70%, which is quite disappointing for surgeons. Now we know that neoadjuvant chemotherapy will be the future, is already the present, and every kind of patients that has a pancreatic cancer should pass for this step. There is a place for surgery in borderline, in locally advanced, and also in oligometastatic disease, and place for polymetastatic disease. But what is the value, clinical value of R1 resection after having patients with so long chemotherapy and extensive resection? Some groups from Germany say there is no really an impact, and meaning that when patients get chemotherapy before surgery, it will be cleared and there is no prognostic value. Other papers say that still after neoadjuvant chemotherapy, R1 resection means something. Patients maybe have less good prognosis. To answer this question, we reviewed our series patients undergoing surgery, extensive pancreatectomy after induction FOLFIRINOX-based chemotherapy. From 2010, when we started, to December 2014, we only selected patients having intensive preoperative chemotherapy by FOLFIRINOX, excluding patients having resection for oligometastatic patients, based chemotherapy, other kind of chemotherapy. The primary endpoints were on overall survival, and secondary endpoints were prognostic factor for survival. All the definition are very well known. Just one thing, we consider borderline tumors, patients with abutment of the arterial axis and locally advanced with the encasement, and we used the R1 1 millimeter rule with multi-inking into the operative room by surgeons. When we consider a specimen, we have the arterial margin, the venous margin, the mobilization posterior margin, the pancreatic one, the resected vessels, meaning the edges of resected vessel, artery and vein, the bile duct, digestive margins. We have a cohort of 220 patients. The majority of the patients had, of course, neoadjuvant chemotherapy, 100%. There were 5 patients having neoadjuvant radiotherapy, which were referred from other institution for a second opinion. The median number of FOLFIRINOX cycle before 11th, the majority of the patients have locally advanced disease. When we stratify the patients or by number of preoperative chemotherapy cycles, the majority, also in the last part of the study, half of the patients had completed the 12 preoperative cycles. In our cohort, when we see the response, the median CI-99 before surgery was 200, which dropped to 30 before surgery. And we can say like half of our patients show normalization of CI-99 under neoadjuvant chemotherapy, while 28, small number, had normal CI-99 before and after. Tumor size at imaging shrinked from 4 centimeters to 3 centimeters. Regarding the type of resection, we had the majority of pancreatic duodenectomy, almost all patients venous resection, and 64 had arterial resection. Most of these patients were presented just before. There were half of patients had celiac trunk resection. Some patients had the double arterial resection, 30 perioperative shunt. We recorded 10 the postoperative death at 90 days. Half of population showed some form of morbidity, major morbidity in 20% of our patients, leading to reoperation in 10%. When we consider all this margin, we had 1/3 after this kind of operation that showed on the operative specimen an R1 resection. The most involved margin was the periarterial margin. Some patients had also the perivenous margin and 13 on the edges of resected margin. When we consider the number of margin involved, the majority had only 1 margin, and very few patients showed 3 or 4 margins, which is quite important that in this series, after so extensive chemotherapy, almost 30% of patients didn't have any lymph node involvement. Regarding the resected vessels, 60 showed a venous invasion and 40 arterial wall invasion. This was the overall survival, which is quite good because it's 30 months after surgery with a 5-year survival of 33%. When we look at patients with R1 resection, R0 resection, we can say that still after neoadjuvant chemotherapy, R1 is poor prognosis with 10% survival at 4 years compared with R0, which showed 44% survival. The survival according to the number of margin involvement, of course, as far as you can, as much as you have margin involvement, you have poor long-term survival. Survival according to type of margin involved, we can say like pancreatic margin does well. There is really no impact on survival, but when you have the venous margin, which is invaded, you have really poor 5-year survival. When we look at the prognostic factor in this series, we could say, we could see like preoperative normalization, CI-99 under preoperative chemotherapy is really a strong prognostic factor. Margin status is a really prognostic factor, and no lymph node residual invasion is also a prognostic factor. When we stratify this cohort in 2 groups with 3 or prognostic factor or all the other population, you can say like patients having an R0 resection, no lymph node involvement with the preoperative normalization of CI-99 have a 50% survival at 5 years. The group is 40 patients in this series. When we compare the R1 with R0 resection, those are quite similar population, but there is some granularity that we should say. Those patients in R1 resection less commonly show the preoperative normalization on CI99. Also, they have larger tumor on preoperative imaging. They have more venous invasion, arterial invasion, more lymph node ratio invasions. There are seldom R1, and despite the fact that they have more adjuvant chemotherapy, they survived less. Then we can say that multimodal treatment of borderline and locally advanced disease, employing FOLFIRINOX, extensive preoperative chemotherapy, and extended pancreatectomy with vascular resection, achieves 30 months median survival with a 5-year survival in these selected patients of 33. R1 resection still is a prognostic factor for survival, along with absent lymph node involvement and normalization of CI99. R1 is important, but not number of margin significant. It is associated with the decreased overall survival despite more adjuvant chemotherapy. And maybe these patients are patients, R1 is no more a kind of surgical deficiency. It's just the reflection of less responsive to preoperative chemotherapy. Of course, we have limitation single center study. We could not stratify really patients according adjuvant chemotherapy because of the long period. This was also a retrospective study. Then we can conclude that R1 resection still occur in 1/3 of patients treated by intensive preoperative FOLFIRINOX and extended pancreatectomy. R1 resection is identify a category of patients that have a limited response to preoperative chemotherapy with decreased overall and disease-free survival, and which is in need of better tailored perioperative treatment.
Thank you, Pedro. Very nice talk. So the R1 resection after neoadjuvant treatment is a consequence of a non-response to chemotherapy. You agree?
Yes.
Yes. And in this case, and you showed that this patient had no less normalization of CA99. So do you think that after neoadjuvant treatment, induction treatment, in a patient with borderline localized tumor, if CA99 is not normalized, do you think that it's important, you need to operate this patient, or it's better to move to another treatment as gemcitabine based, because in France, most of the patients receive FOLFIRINOX treatment to see if you can have response before surgery. Because it's the only way patient to try to select better the patient with no response to induction treatment.
Thank you for your question. Now analyzing retrospectively, maybe you are right. We have only one thing in pancreatic cancer is CI99. And when patients, you know, the difference is really is small. We are talking about 50 versus 60%. But still there are patients that did not normalize CI99 before surgery and are R0. Then we should see if there is really a cutoff, because I did not identify a cutoff. Maybe I will do that later. Meaning if there is a threshold CI99, because the population is divided in two groups, normalized versus non-normalized, but maybe there is a cutoff like 200 or something like that can correlate with the switch the treatment. Of course, as MD Anderson showed before, patients having high CI99 before or increasing CI99 just before, those are bad candidates for surgery. But I will take your question for the paper, but it's a good question. Maybe we should switch, but we should find a threshold to select. better patients.
My second question is about the DNA, because with ancillary study of Panache 01 by Lilian Schwartz, you showed that ctDNA could be a predictive factor of response. And do you think it's important to perform this type of measure before surgery? If and if ctDNA is not normal, to not perform the surgery?
Yeah.
To study that.
Yeah, that's the question. Thank you. That's a really good question. This it's always about the future, how select best patients for huge operation. And then I think ctDNA and also maybe the keys. There are other things like transcriptomics or whatever you want that really can identify best patients for surgery. Is the way to go. And you showed that in the ancillary study of Panache. I think it's a good question that the chemosensitivity of patients and the way to detect the circulant cells or whatever you want should be integrated in 10 years. We will do only these things. We saw yesterday with Monsieur Boutet for colorectal liver mets. I think in pancreatic cancer will come in some periods.
Sometimes my pathologist is telling me I'm R0, but R1 on a node. Do we know whether this has an effect on survival?
You mean like in your pathologic report is R1 because of capsule rupture of lymph node into a retroportal lamina. This is quite usual for pathology. I have no data about that. We have some patients, we are R1, but the clinical impression that I have, those are quite resectable patients. There is no impact on survival, but we have few patients like that. I cannot answer to your question.
We have one last question, 1 minute. Yeah, two. No thanks.
Okay. Just a question about the possible use of radiotherapy in an adjuvant setting. In other biliary disease, cancer biliary disease could be a role in this kind of treatment. What do you think? Of course, we agree that we exclude the radiotherapy when we have a need of vascular arterial resection. What do you think?
I was looking at that because in paper, there is no place for adjuvant radiotherapy actually in France. But I was looking at that I have no space to put the slides in the paper is this. There is no differences in kind of type of recurrences according R1, R0. Patients having R1 resection have no more local recurrences. So when these patients recur, have a generalized disease, then again, this is not a kind of surgical clearance. This is just a question of the response to preoperative chemotherapy. There is no surgery because we are resecting both venous and arterial. There is no more space into the patient. It's really a kind of no response to preoperative treatment R1, in my opinion.
R1 can be difficult to everybody else as well because they can.
Yeah.
Very last.
Yeah, but that was related to the previous question. What are the profile of your recurrence actually? Meaning that do you have recurrence because you don't have enough systemic control, or do you have recurrence because of R1? And that's the point.
Again, those are quite different population. Those patients with R1, they have shorter disease-free survival and shorter overall survival. They recur generalized recurrence. We have few local recurrences that we could treat by whatever treatment. These patients develop locally diffuse metastatic disease, peritoneal spreading. The best patients that we kept so long, there are patients with the lungs, with mets in the lungs, but everybody has the same. Then those patients do well, but do better. But all the other, they have a generalized recurrences.
Good morning, everyone. Thank you for letting me show you some of our cases in solid pseudopapillary tumors in Peru. So without further delay, we will start saying that SPN is not as sensitive, neither a radiation therapy sensitive tumor. So there's no standard place for neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy. Thus, surgery becomes the only choice that we can offer as oncologists or our surgeons. But then we might face some cases where we have locally advanced disease, where we should pose the question if there's a need for vascular resection or other extended resections, including multivisceral resections. So in the center where I come from, pancreatic adenocarcinoma is the third cause of pancreatic surgery. It's not so frequent. But we have first cause is ampullary carcinoma, solid pseudopapillary neoplasm is the second one. And this confronts us to different scenarios of patients. So to have a little idea, we are a cancer center where we get across the country with diagnosis of cancer. So in this case series, this small case series, we will delve into 12 cases where we had SPNs from the head, body or tail, or we were confronted to big tumors that replaced the entire gland. So how we will define a complex case? So I pulled this paper from the Heidelberg group where patients who needed vascular resection or beyond that multivisceral resections were considered complex. So this was related to the amount of postoperative, uneventful postoperative cases with complications or mortality. So this is how we will define throughout this presentation. But also, it's not a matter of only technique because we have to know that patients that we operate might have other comorbidities. I know that in high-income countries, coronary disease, obesity, COPD might pose a different challenge. But in our institution, most of our patients have chronic kidney disease. So we published this paper in which we demonstrated that patients that had a lower glomerular filtration rate had higher chances of severe morbidity. So this is one of the things that even though we might have young patients, there might be a slight dysfunction of the kidneys and so on. It doesn't mean that we do not search for other morbidities, but this is something that we have to look up for, because even though the patient might be young, this does not mean they might not have morbidities. So in these patients that we had, most of them, as you know, were female patients, young, overweighted, you know, and three of them you can see that had a chronic disease without control. And you can also, by your experience, I am pretty sure, is that you have faced high-risk pancreas or intermediate-risk pancreas, which happens to our group. It's most of the time is what we have to face. Mesopancreas level in this scenario is not only to achieve margins, it's also to achieve resectabilities. This is why sometimes we have abutment of the SMA, so we had to go further to achieve resection. So this is one of our patients. This is a 19-year-old woman that she was referred to our center for palliative care just for that, but we had to make, I mean, this is a 19-year-old, this is a girl, and the chances for survival without surgery are zero. So then we had to perform an MDT session, you know, not because of a matter of a heart, but we thought that we could offer the patient another solution, and this was by means of surgery. So we took the patient to the OR, and as you can see, there's a severe portal necrosis, and also caput medusae along of the abdominal cavity. So we had to, fortunately, we had a very comprehensive team, and also we could design preparatively the type of surgery that we were about to do. And so in this case, we did. Professor Bachiller, Professor Adio, the Strasbourg technique now. We did this mesenterical portal shunt, which is a very reproducible technique and allowed us to treat more patients. In the recent cases, this is what we did. And you might see it a little bit longer than usual, this shunt, but it's because of the huge size of the tumor. So this is the specimen, and we perform also a subtotal colectomy because this huge tumor was very adherent to the mass. So the cases that we present we had to treat. 5 of them underwent multivisceral resection, 10 of them vascular resection. The type of venous reconstruction, as you can see, most of them are type 3, type 4, some other atypicals, but most of the cases you can see were complex resections. And the length of the median resection was 3 centimeters, but we could get as high as 7 or 8 centimeters, which are not most of the cases. But we prefer to do type 3. We had to do sometimes type 4. This is not our usual practice. Most of our cases, if you would look at our cases in total, type 3 would be the mostly used. But in these cases, since these are big tumors, we have to interpose a graft, either autologous graft or a PTFE graft, which is not our usual practice. This is a left-sided pancreas, SPN, from the body of the pancreas, but with extension to the liver. So in this case, we had to remove the celiac trunk also because it was infiltrated, and we could assure with ultrasound probes that there was a good flow with a modified Appleby procedure. And we had to interpose a graft because we needed to resect 8 centimeters of the SMV and the portal vein. And 2 years later, this is still patent. But we also found that there was gastric necrosis, so we have to complete the resection with total gastrectomy for sure. And well, you can see the median size of these tumors is almost 14 centimeters. We had cases with 25 centimeters. Despite having standard lymphadenectomy, none of our cases have lymph node invasion, but you can see we had to face high estimated blood loss. So in the recent cases that we are applying the portal mesenteric shunt, we are lowering these numbers, but you can see this is still high, but we expect to in the future to lower this with this technique. And complications, yes, there are. These are challenging cases. We had hypovolemic shock, thrombosis of the grafts, especially when we use the dogma graft with the falciform ligament. That patient that I showed you earlier that was considered unresectable, she had a chronic kidney disease, as I told you, and she underwent renal failure. But after 90 days of this postoperative care, intensive postoperative care, she stayed very long with us. She recovered, and now she's going under control. And notably, we had no mortality during this 90-day follow-up period with these patients. So I might conclude saying that SPN is rare, but can be surgically complex. There's the need of good planning and MDT support, which is key. Please take into consideration that either young patients do better, these comorbidities still matter, and we must, as surgeon, be prepared to perform multivisceral resections. And for patients with SPN, surgery is currently the only curative pathway, so we must make it count. Thank you.
Very much. Congratulations for your excellent work. You're talking about a pathology that is rare. It's been misunderstood for a long time, only diagnosed in 1959. It was thought to be benign, but it's all considered as a low malignancy, only 10% highly. And as you mentioned, surgery is the only option and is justified to do it even in the presence of metastasis. And you've done extreme surgery in it, which I congratulate you again for that, including multivisceral and vascular reconstruction. And it's been advised to do surgery even if there is metastasis, and they have good prognosis even if there is capsular invasion. And they have gone wrong. So thank you very much for your work. And
Thank you, Professor. That's right. Thank you.
A question from the floor? No.
I have a question.
Research. Thank you.
Nice talk. I would like to know about the recurrence. Yeah, because some of the patients have liver metastasis.
Thank you. That's a very important question. The recurrence is low, but there's one thing that there's a space to improve. As I told you before, we are referral center, so many times our patients go back to their local hospital. So we might say that we can follow them. We can follow them and through the national registry, and we can get the information if they are still alive or not. We from time to time we call them and check if they are okay. But I might say from our data that we have a very low recurrence, less than 10%, but this is a problem with, centers like where I work, that we might have some patients that are still at their, that have came back to their hometown. So, but when we see the recurrence patterns of these patients, yes, liver is the first organ, and we had, for example, 2 cases in which they came, not this one, not these ones. These are very recently. This is undergoing a more complex cases during the last years, but we had patients in the liver, and well, they underwent surgery. Some other didn't because of late healthcare um, achievement, and well, this is the point. But in these patients, these are very recent cases, less than 5 years, that trying to push the boundaries to deliver better outcomes for them. Mhm. Yes, sir.
Yes, thank you. Congratulations on performing exceptional surgery in challenging cases. I'm wondering, as you come back from European training with these advanced ideas, how much time did you need to organize the extra resources in your hospital? And did you have challenges with administration and resource?
Yes, thank you. That's a very, very important question. Thank you for addressing this. Professor Bismuth admitted me in 2018, and most of the vascular surgery that I've learned at Paul Bruce, it was from Professor Cherki. So both of them imprinted this this idea in me. If you come back without improving and pushing boundaries, then much of the fruit of this hard work wouldn't be seen. So once I came back, I talked to my professor, and we gained a new team, younger people. We accrued a young anesthesiologist. Then, fortunately, these chiefs that were my professors at back home in Peru, they now became chiefs of the hospital. So they now implemented ICUs and dedicated only to surgery and so on. So we are accruing young talent to do that. But we had to demonstrate first that we could do vascular resection without severe mortality, without severe morbidity and low mortality. This was the first challenge to do. And we started with pancreatic cancer. We started with pancreatic cancer, and then with our results, we were discussing, and then we said, okay, we can go on to more complex surgery. So this is what we did. So, well, I'm very thankful. I always thank my mentors because of that. I can deliver now better results to poor patients, which is, the matter of fact, the most of the population that we treat, we treat poor patients.
I agree, Jean. I think I will emphasize on the point that Ramiro is one of the young surgeons that came among the compagnons from a country who have no large experience in this kind of HPB disease. And by training, he succeeds to implant the technique he learned among the compagnons, Daniel Cherky and others. And this is an example. The compagnon is bringing to the large community of young surgeons, not with a large enthusiasm. He left his family to stay 1 year alone in the disease is Mary. And he succeeded. He showed today, yesterday also, beautiful example of what he did. Thank you.
Thank you, sir.
We move on to the next speaker, who is
Okay, so thank you very much for giving me the opportunity to present one of our recent works today, which is the establishing of novel benchmarks for robotic Whipple. So benchmarking, as you all know, is a validated tool for quality improvement, mainly from business and manufacturing, but has now more recently also been applied to surgery. And up to this day, these reference values or benchmarks have been established for multiple procedures, including also robotic distal pancreatectomy or open Whipple surgery. However, benchmarks for robotic Whipple are still lacking. And in this recently published Paris Consensus, which many of you have also been part of, the experts and jury identified the establishing of robotic Whipple benchmarks as an unmet need and a top research priority. So we aim to fill that void. How did we do this? We followed a validated benchmarking methodology that meant first expert centers. These, in our case, that performed at least 15 robotic Whipples per year, had a prospective database in place, conducted research in the field, and the centers had to have completed the learning curve of at least 40 cases. If the centers had not completed the learning curve, we removed initial 40 cases per center. We then defined a low risk or benchmark cohort, and we wanted to also be able to directly compare this to the open Whipple benchmarks and used the same criteria. So those were the benign and upfront resectable malignant cases without neoadjuvant therapy or arterial resection, patients with an ASA score of less than 3 and a BMI between 18.5 and 35 without major comorbidities and no history of major abdominal surgery. Now, in these low risk or benchmark patients treated at these expert centers, we then derived the cutoff values for relevant outcome parameters. How do we do this? In general, we first calculate the median of any given outcome. In this exemplary case, the 6-month CCI per center. We then aggregate the medians and we calculate the 75th percentile, which then the benchmark cutoff for the best achievable outcome within these reference centers. Anything or any value beyond the cutoff, in this case CCI 40, that means the value is outside benchmark. Anything below, it's within benchmark. So what does that mean for robotic Whipple? And we identified 12 benchmark centers, 418 patients or cases qualified or fulfilled the benchmarking criteria. And here on the left column, you'll see the newly established benchmark cutoffs for robotic Whipple compared to the already published open Whipple benchmarks on the right. Sorry for this. The operative time benchmark was approximately 1 hour longer compared to the benchmark for open Whipple, a known caveat from robotic surgery. We've seen that already in the past days. So that's not really surprising, but we also clearly see the advantages of minimally invasive surgery and specifically also the robot in, well, 10-fold decreased blood transfusion rate with a low conversion rate as well. We look at pancreas-specific morbidity, one of the issues or concerns reported in the past. We see comparable benchmarks for robotic and open Whipple, also for overall morbidity, a comparable benchmark for CCI with lower benchmark for major complications. Now, this substantiates the role and the advantages of minimally invasive surgery also in these complex procedures, and specifically also robotic surgery, and somewhat underlines its safety. Now, if we compare these benchmarks, newly established benchmarks, to recently the highest level data that we have available in robotic Whipple, we can clearly see that here the Heidelberg group or the Europa trial reported values or results outside the newly established benchmarks with increased conversion rates, blood transfusion rates, and pancreas-specific morbidity, but also an increased overall morbidity. Those results are most likely attributed to that institutional learning curve, also established, acknowledged by the authors, and the exploratory nature of the trial. And if we look at another RCT, also published in 2024, comparing robotic to open Whipple in the Chinese setting, and 3 high volume centers, you can clearly see that those results after the learning curve are within the benchmark cutoffs. Now, it's important to note that when interpreting these results, that the minimum follow-up pancreatic surgery to fully capture complications has been reported in the past to be at least 6 months. In these trials, neither of these trials covered this period, so it's likely that the morbidity that reported in these trials is likely a bit higher after an additional 3 months of follow-up. Now we then look more into the index complication of Whipple surgery, pancreatic fistula, and in our multivariable analysis, which you unfortunately cannot see here, we looked at the benchmark and non-benchmark cases, so the entire cohort of a bit more than 1,000 cases, and we identified basically that the same risk factors and predictors of pancreatic fistula also hold true in robotic surgery. Independent risk factors were mainly so the main independent risk factors were small duct diameter, indication other than ductal adenocarcinoma, and also anticoagulation prior to surgery. Then, as we've looked somewhat at safety and fistula rates, we also wanted to address the question of logical adequacy of robotic Whipple, and one of the concerns also raised in the Europa trial. And we can clearly answer the question of whether robotic Whipple is oncologically adequate with yes. The benchmarks for our zero resection rates and lymph nodes harvested are beyond the benchmarks of robotic Whipple surgery. And we then again looked in the entire cohort at independent risk factors, and and found that venous resection and not meeting benchmark criteria as the most important and independent risk factors for.
Never mind, we have to repeat the slide.
Yeah, we go slide down. Okay. So sorry about this either. So we also looked at, well, that good oncological resection is of course nice, but it only means something if it also helps patients. It translates into long-term survival for patients. And we looked at our marker low risk ductal adenocarcinoma subgroup of only upfront resectable ductal adenocarcinoma, no positive disease in 65%. And we've seen a median overall survival of 34 months. Of course, benchmarking studies are not designed as oncological studies, so they have some limitations mainly related to no long-term follow-up and no stratification for tumor stages and perioperative treatments. But here we observed a median follow-up of 2 years at least, and then a minimum follow-up of at least 1 year. So we think that this is robust enough to somewhat conclude that these short-term outcomes also translate into favorable long-term oncological outcomes. So I'm coming to my conclusion. With the findings from this benchmark study, we can conclude or we demonstrated that robotic Whipple is somewhat comparable to open Whipple and safe. It offers the minimally the advantages of minimally invasive surgery and specifically robotic surgery with its more complex subgroup and shows reduced low conversion rates. We could also demonstrate that robotic Whipple is pathologically adequate in ductal adenocarcinoma, but as for any procedure and surgical procedure, patient selection remains key for optimal outcome. Thank you very much.
Congrats for your nice presentation. I had some concern about this use of this benchmark in this disease, because when we talk about Whipple procedure, we are talking about different surgeries. We talk about the procedures, gastroduodenopancreatectomy, but another way, we are talking about duodenopancreatectomy with resection of mesopancreas, and also duodenopancreatectomy with different degrees of lymphadenectomy. And also, we are talking about different diseases with different prognosis, since the neuroendocrine tumor, papillary tumor, and ductal tumors with different prognosis and different treatments. So I ask you, my first question is, is fair. Compare different variety of disease with just one concept, Whipple disease. If so, you are not comparing orange with apple. This is what do you think about that? I want you to comment this. Yes.
So thank you very much for your question, and very important one. If I understand you correctly, you were asking me whether we should be more granular and establish benchmarks for each individual subgroups that we just pooled here. I think it's a fair question. Now we wanted it to be comparable to the open Whipple benchmark, which is the same in the past as well. The idea is, and the core concept in this was really to set a quality benchmark or a quality reference that people or centers and surgeons can aspire to. But I completely agree with you. We probably have to be more granular to have that a more granular approach and reflect more also real world practice.
Do you think that a learning curve impact those results and the patient selection that, of course, he has done at the beginning of the practice in robotics?
So patient selection is certainly an important factor. We try to at least address somewhat or account for a learning curve and by removing the first 40 patients in centers that had not completed the learning curve before. But of course, we try to first identify centers that were beyond the learning curve. That's the first point. But of course, that's still ongoing. So there is some learning curve bias still in there probably. But we typically, and that's part of the benchmarking methodology, selected the low risk patients, right? So that is per definition a patient selection right here. Of course, there is probably some not accounted for patient selection in the, because it's a retrospective study, we could not really account for and specifically address the exclusion criteria of these patients. It's not prospective. So to some degree, there is some patient selection there not accounted for, of course.
Question about radicality. I was puzzled if I saw well the robot 98% R0 and open 60. I don't understand that. Can you explain? Can you elaborate a little bit on that?
Well, I think here again, I think that touches already the point as well that you mentioned before. It's certainly patient selection bias in there as well. So the benchmark open, we've already identified those cases, but it's probably even robotic group. But then again, probably is somewhat reflective of the meticulous dissection of the robot, the lymphadenectomy and so on. So,
but that's concerning because mostly it's posterior. And what does the robot better than if you do it open? Because, well, there can be some difference, but I cannot explain this huge difference.
There have been some data that not necessarily fistulas or more applying in robotic surgery, but the consequence of a fistula may be higher with more bleeding and so on. Do you have any data on that?
No, we have not more granular data on this. So we have the bleeding rates, obviously, but those are comparable. Fistula rates, no, don't have further data.
Yes. Well, congratulations on your nice presentation. And I would like a reflection. What's your thought about recent papers speaking about venous resection and the recall of type 2 resection with patches? And this seems like they are trying, well, the data shows in these studies that the outcomes in survival are the same. But this more points towards more easy robotic resection. So what are your thoughts on this?
So maybe just to put this again into context here, so the benchmarking is really about selecting the easy cases, right? It's not about and to create a reference for these easy cases so that centers looking at their own cases that reflect the benchmark criteria can compare to and have a quality reference and see whether corrective measures or improvement measures are necessary to see whether there's a problem somewhere in the technique, in the learning curve, to somewhat account for this. So we did not really look at these more advanced cases and vascular resection cases. So cannot answer this with our study.
Can I go back for a moment to Mark Bemelman's question? Are you sure your case matching is appropriate? Because my principal hypothesis would be that the open cases were probably larger tumors with, and that the robotic cases in the initial experience are selected for most feasible. Isn't that the most reasonable explanation?
Yes, I agree. We weren't able to match, did not match for these factors. We also did not have a direct comparison to the open Whipple benchmark. So it's really, we don't have two cores that we compared. So we looked at one core, we didn't match, we applied the same benchmark criteria, but of course there is some selection bias in there, and most likely explaining also this difference to some degree.
Question?
Thank you very much.
Thank you.
Media to gain a little bit more time in a quarter of an hour. And
It's my drug dealer. Every day.
¿Cómo se va a decir cuando la casa porque la casa ¿Cómo se va? ¿Ya? También no. Bien hidratado. Good hydration. Everything is good. Yeah, great. Okay.
Você gosta?
Sì, era stato sempre quello carico.
Yeah, I think we could transplant oncology. And I think it's interesting to read something that has been written by Starzl in 1967, and it is the second page of his book, Experience in Hepatic Transplantation. And he said the operation of liver replacement, in brackets orthotopic organ transplantation, was considered as designed to treat primary secondary hepatic malignancies which could not be treated with conventional techniques of subtotal liver resection. And as you know, it has always been a problem to keep alive the indication for cancer in liver transplantation because many pathologists consider patients with a cancer not the same sickness, disease, and those. We in Brussels always favored transplantation for cancer. It's always been more than 40% of our transplant indications. And we introduced, therefore, in 2015 in the literature, the wording transplant oncology, which is now, of course, used in all meetings. I don't have to tell you, Glenn is standing in front of me, but one of the main drivers of these transplant oncology, really transplant oncology, is Vincenzo Mazzaferro, long-standing friend since we met in Pittsburgh more than 40 years ago. So Vincenzo, you will surely learn us again new lessons in this new passion.
Thank you very much. It's a true honor for me to be here today in front of you, in front of such a distinguished audience, in front of all of us. I will start saying that by definition, I think that after so many years in discussing liver transplantation for cancer, we can say that liver transplantation has an intrinsic competitive advantage over any other treatment in terms of completeness of a tumor finding to the liver. And after the long pioneering and implementation phases, it has gained a recognition as the best curative treatment in HCC. Recent data, these are recent data from UNOS, considering about 25,000 patients transplanted in the US, and you can see that the median survival after transplantation in patients with liver cancer within Milan criteria is the median survival is 13 years. So, and it is projected that for the next decade, the median survival will be over 15 years. Now, of course, there are also patients beyond Milan criteria, but they were mainly downstage to Milan with the downstaging treatment, and I will go in on that in a minute. So, for ACC has opened a field with a very high learning attitude but at the same time, a very limited, limited resources. So there is a difference still between the possibility of this procedure and the actual possibility to apply. So until we will have an unlimited resource of organ like this one using xenotransplant, we are forced to implement restriction. And we are forced to implement restrictions that are called selection criteria for offering liver transplant to those patients who may benefit the most from operation. One of the, I would say, intriguing condition of the competitive advantage I just said of transplant oncology is the fact that liver transplantation has a delta, a persistent delta of advantage over, for example, resection. And this depends on tumor load. Obviously, as the tumor load increases, the efficacy of surgery, any surgery, transplant and resection decreases. But this delta of efficacy is still in favor of transplant, and the decrement of efficacy that is observed with increased tumor burden is much reduced in transplant with respect to liver resection. There are other forms of advantage of liver transplantation applied not only to primary but also to metastatic cancer. You have here the result of the TransMet trial on colorectal mets. Again, liver transplant confer a highly significant survival advantage over other treatment, although, as you know, the progression-free survival remains more or less similar to patient on non-transplanted patient. But the point is that cancer progression after transplant is different from cancer progression after chemo. And this is really intriguing because what we can say, looking at this result, is that transplantation induces a modification of the natural history of cancer, of colorectal liver cancer mets, and abolish the conventional value of progression-free survival. Progression-free survival in oncology, medical oncology, means failure, and failure means change of therapy. But progression in this context of after transplantation is not related to survival, and it therefore is not a surrogate of survival anymore. What we can say is that, in other words, the futility, the risk of futility of transplantation occurs later with respect to other therapies. And we don't know exactly why, because if you compare the result of similar or nearly similar tumor burden removed with resection and transplant for different indications, not only for ACC, but also for cholangio, for colorectal met, for neuroendocrine, you can see the superiority of transplantation is maintained. So that means it is not related to the disease, to the biology, to radicality. It means that, in my opinion, is related to transplant itself. This must be a condition related to transplantation. Advantage is not other than the transplant itself. There are obviously borderline indication in which liver transplant can be achieved with the downstaging. Here you have different demonstration. In ACC, we have evidence derived from randomized controlled trials showing that after transplant, in patients who achieve a very good downstaging, if you transplant the patient, you have a significant advantage in survival and regression and progression-free survival with respect to patient remaining in a setting. And also in intrahepatic cholangiocarcinoma, as we just heard yesterday, the result of this procedure of transplantation in cholangio very much improved when specific protocol focus on response after multiple therapy and on stability response for enough time were implemented. And in fact, you have the result of a 10-year survival of patients successfully downstage within Milan criteria in the US. You can see here with the orange curve, that there is a significant advantage of tumor downstaging and consequently to downstaging policy in organ allocation in large numbers. All this has been incorporated more or less in the very recent guidelines. This is the recent European Clinical Practice Guideline, the European Association Study of the Liver. With respect to transplantation, you can see that bridging and downstaging of tumor extension are recommended in mainly most of the candidates. Having the response to therapy, the control of the disease, the most important cornerstone to apply our decisions. The picture has been changed, has been truly revolutionized with immunotherapy. The immunotherapy in the immunotherapy setting in advanced ACC, we move the outcome of this patient from a disease control rate of 10%, a survival less than 20%, to a control rate of about 3 patients out of 4, long-term survival in 1/3 of the patient. So because of this, we have an increased number of patients like this receiving immunotherapy. There are patients with unresectable, not transplantable recurrence with alpha fetoprotein sky high at 50,000 or so, failing local regional therapy. They were treated as a rescue therapy with immunotherapy and had a extremely important downstaging. And you can, put this patient on the metro ticket board, and you can see the shift in the stage migration of this patient. That at that point could be a good transplant candidate. If we compare the result of this kind of patient in our experience, receiving immunotherapy and with or without local regional therapies, with patients who in the previous trial received downstaging only with local regional treatment, there is a clear difference here. This is in fact, you can see that the position, the condition, the tumor burden from which the patient started and were considered for transplant as much more expanded. And in fact, this is most probably the more credible expansion of criteria for liver transplantation in ACC since long time. In recent review, this has been reviewed in retrospective. There are 90 patient retrospective review. This is one of the recent collection, and telling us that the median washout period with immunotherapy of about 3 months seems to be safe, associated to less incidence of rejection. Even if rejection occur, in 80% of the cases, this patient can be treated with medical therapy. We also have the evidence that older patient and the longer washout period, the lower is the incidence of post-transplant rejection, which was the main concern in this kind of patient. Moving to prospective condition, this is our prospective study. An increasing number of patients are referred for this condition. Here you have, with respect to transplantation, which is the vertical line, 16 patients prospectively collected in our center receiving chemotherapy as a rescue treatment after many other treatments in the past. And you can see, quite interesting, that half of these patients, they are signed here, had a portal vein thrombosis at inception. And you can see that is only one recurrence out of 16 in this very advanced patient converted to transplant. As I said, there are important signs there that should be discussed. For example, presence of portal vein thrombosis. Here we have, I said, 50% of our patients had a portal vein thrombosis, but 7 out of 8 has a complete response, complete disappearance of the thrombosis, and the VP4, the single VP4 was reduced after immunotherapy to a VP2 with the alpha fetoprotein less than 100. So within some criteria that are acceptable for liver transplantation. Interestingly, for example, we have this condition related to rejection. We had 4 patients who had a severe rejection out of 16, so 25% of our patients suffered severe rejection. They were all treated, as I said, with steroid bolus. But what is interesting is that if you go back and look at the lymphocyte population, see that there are significantly at the pre-transplant, the day of transplantation, in this population who had a rejection, is the purple line, with respect to patients who did not suffer rejection. So in a way, although these are just 4 patients, if this result can be confirmed in larger series, we may predict the possibility of severe rejection in patients undergoing transplant after immunotherapy, just measuring this T cell pool population. And there are also some interesting data coming out from this experience. For example, these are in the area where the tumor was, in the area of pathological tumor response, the nodule were surrounded this TLS, which is a tertiary lymphocyte structure, which are kind of similar to lymph node, to neo-lymph nodes, germinal center-like collection of T and B cells proliferating around dendritic cell. And this is an expression of a severe, extremely interesting immunological reaction, killing the tumor cells around the remnant of the tumor nodule. What we have seen in measuring the immunity of this patient undergoing transplant after immunotherapy is very interesting. It's a kind of sequence of events that we need to investigate more. So we see that at the beginning, you have a spike here of what is called innate immunity. Innate immunity is let's say, basic immunity that we all have, and is made of non-specialized cells, neutrophils, monocytes, etc. This spikes then is followed by a loop of natural killers. And what is interesting is that this innate immunity has an effect of training on what is let's say, the most sophisticated adaptive immunity made of memory cells on T cells. And you can see that here, after a year after transplant, the numbers of very specialized T cell is called TEMRA lymphocytes, terminal effector memory cells, are 30-fold higher with respect to transplant in patients who were transplanted after immunotherapy treatment. So in a way, this it tells us that this kind of immunity is much more potentiated by the transplant itself. And what is interesting is these cells are very important in allograft rejection, but are also very important in anti-tumor control. So this allowed the hypothesis of the effect of liver transplant itself potentiating over time the anti-tumor effect. And this, in fact, could be the missing piece of the puzzle of transplant oncology that may explain the fact that why transplant oncology is working on top of other factors. We have been studying for many years the tumor. We elaborate on transplant criteria. We study patients, the comorbidities importance. We study immunosuppression, the minimization of immunosuppression after transplant. But we didn't put so much attention until now to the graft. The fact that the graft itself may work as a trainer for immunity. And this may explain the result I just showed you before of transplant oncology with a positive effect on several different forms of cancer. The last part of presentation, the concept I like to deliver is the fact that now with even this area of immuno related component, the management of ACC, but not only of ACC, but also of many other cancer indication is becoming very complicated, very difficult decision making. And the decision making in this perspective, I think, is like you have here some of the factors that you have to consider at any time when you take any decision on this kind of patient. But nowadays, this kind of decision making is much like driving a car in a very crowded city with the assistance of a navigator. So you have a starting point, you have a diagnosis, you have an endpoint, you need to cure the patient, and then you have to navigate with your treatments and have to choose the best trajectory. And the best trajectory is chosen according to the traffic condition, the variables ahead, car accident, you may have your independent choices, the purpose, you are in a hurry. There are many conditions that are taken into consideration when you decide a trajectory to go from a diagnosis to cure. But when changes occur with respect to the planned trajectory, as you know, a car navigator stops working for a while, for a second, and a message pops up from the screen, and the navigator tells you, wait, please, map reloading. And this indicates some kind of adjustment of the trajectory according to the change that has occurred. So the reloading of all the variables according to the plan that you have, but also to the condition in which you are at the time of your decision. This helps me to stress the difference between what is called treatment algorithm. The treatment algorithm is an organized journey. It's a series of choices that you make according to predefined scheme. Here you have a couple of the most popular one on ACC. But this treatment algorithm is much different from a treatment strategy, which is a journey in which the choices are made on the actual condition of that particular condition according to the probability that you reach the final destination independent of what you have in terms of patient, in terms of condition, in terms of resources, etc. So the endpoints remain the survival, but I mean, it's at the end, it's an endpoint. What is in between can differ in many, many conditions. Now, this is the car navigator. I have some investigation on this, but the car navigator follow an algorithm, a mathematical algorithm, a path that is called the best first search idea. It's kind of very complex things. It seems easy, but it's not. It's made of several notches of this region that have different weight. But this can be done also in deciding medical decision. And this can be applied because it's already applied in telecommunication, automation, robotic, large-scale integration shift, etc. So there are trajectories that can be designed and held according to point changes rather than final endpoint. This is just to show you that this can be done, is another trajectory that can be developed, and hopefully we may discuss this in the future meeting. So to conclude, to sum up, I think that my conclusion is that liver transplantation is a procedure that has an inherent competitive persistent advantage over other cancer treatment. There is a big limitation, which is the not availability, the low availability of resources, and so the need to select our patient. The superiority of transplantation across the indication is something that is fascinating and should be explored in detail. It probably do not depend only on biology of the tumors. Nowadays, the most important criteria driving the selection of patient is the downstaging, the conversion of patient within transplantability criteria, and the response to treatment seems to be the driving force for the near future in selecting this patient. And to think about the future, to advance the field, we need novel approaches, probably in immunomanipulation, integration, and also in decision-making. Thank you very much for your.
Vincenzo and produce Olivier Soufan with the discussion.
Thank you very much, Vincenzo. It was a brilliant talk on a very exciting topic. I have two questions. The first one, there was a slide, very exciting at the end of your talk. Considering the number of information we need and we have in this cancer setting, I mean, some clinical data, biological, radiomics, the genetics, especially for colorectal liver metastasis and so on, and the response to treatment. The decision-making is very difficult, obviously. So as you showed in your figure on global positioning system, the GPS, don't you think that, and probably to readjust on a regular basis, there are maybe some tools that can use, such the large language models, which are especially suited for that kind of to manage so many parameters, so many information, and to help for patient selection. And my second question is regarding the transplantation itself. Besides the hope in the future for xenotransplantation, we expect, and we see that there are an expansion of indication, transplant oncology, so we need more liver graft. And my question is to ask the European transplant surgeon you are, don't you think it could be timely and fair to probably restart some program of living donor liver transplantation for oncologic indications in Europe?
Okay, so for the first part, I have not enough knowledge to predict if artificial intelligence may help or not. I don't know. Artificial intelligence is trained exactly like the immunity. I mean, it's trained by what you learn, what you teach to the intelligence will results. What I think is that what we are trying to do with mathematicians and statistical and computer science is to adjust the machine to the human way of thinking. So when I don't know, maybe it happened to all of you, when in front of a decision, you put in your head a lot of information and try to have a hierarchic condition in which this is more important than that, et cetera, et cetera. And so I don't like a machine that tells me what to do according to what, I mean, maybe the statistic, the probability, et cetera, but according to the present condition. Exactly like in the car navigator, at every crossroad, you look at left and right and see, and then go. Something like that, that is a process. It's not something that you define at the beginning and you find the end. I don't know if this can be done, but there are already a lot of research in medical application of this technology. Living donation. We don't do living. Personally think that living donation is a fantastic opportunity, but it will not solve the problem in general. I think that I think it's important that someone will push a lot and have a very good program for that, even in Europe. Why not? But according to the numbers, according to what we have, I think that the solution is in some other place. As a surgeon, of course, we can do living donation to increase the number, but we will not solve the problem. This is my personal idea.
Thank you, Mr. Bisman. Thank you, Dr. Mazapé, not only for your lecture today, but also for your continuous work in this field. You said liver transplantation is better than liver resection in the treatment of potential carcinoma. Of course, I agree with you. And I think the main reason is the way we do the ablation of the tumor. When we say liver transplantation in HCC, it is not the correct word. Correct word is total hepatectomy.
Yes.
But the total hepatectomy is the treatment. Liver transplantation is, of course, the complement. What it means compared to resection, that we did the most complete resection. There is no R1 when we do total hepatectomy. You remove all the tumor. If there is recurrence, it comes from outside the liver. That means it is sure that there was some tumor outside of the liver to come in the graft. Of course, there is no tumor in the graft. And this is my question. We know that it could be lymph node. It could be in the roots of the mesenteric vein, there are emboli, persistent that come in the graft. But there is some way to improve what could be the residual tumor outside of the liver, which is the cause of the recurrence. By which way? And the second question I ask you for, it is very interesting, but you speak about the own immunity of the graft. How to improve it? This is a very important point. And my question is about the machine. Do you think that machine perfusion may improve the graft in a way that it is in better condition to confront the new insemination of the remnant tumor, some parts in the body, in the graft?
Thank you for the question, obviously. Very important questions. With this, I will start with the second one. The machine perfusion creates a better microenvironment in the graft and probably reduce the engraftment in the new liver of some circulating metastatic cells. Agree, fully agree. But it needs to be demonstrated. There are trials going on, and we'll see. It makes sense. But according to this perspective, the one I just showed you, you put a 1 kilo lymph node, which is, let's imagine the liver like the largest lymph node of our body. You put 1 kilo lymph node into a patient, and then there is a delivery of, Dr. Stadel and you, in the past show all this discussion about chimerism and about the transfer of immunocompetence from the donor to the recipient. That was focused on tolerance. But if you look at in the mirror, which is the tumor growth, what we can see here is that through a transplant, you put in the recipient a possible training force, very strong training force, according to the data, potentiating the anti-tumor recipient immunocompetence. So this means that if you put the liver in the machine, you probably reduce this capacity. So you may increase the, let's say, increase the probability to have a metastasis in the graft, but you may decrease the immunocompetence that has been promoted by the I don't know. Obviously, I don't know. But this has to be demonstrated because, and I come to the first question, it's not a matter of of superiority of transplant and resection, because you correctly said it's just a total hepatectomy versus partial hepatectomy. But is the fact that you put a different, completely different environment in the patient, and it's reproducible. If you have a 5 centimeter tumor, 6 centimeter tumor, 25 centimeter tumor and you transplant versus resection, in general, if you take 100, 200, 300 patients like that, in general, there is a tendency to have a transplant result better than resection result. And this is for ACC, for neuroendocrine, for liver met, they show it, you show in France, etc. So must be something which is not related to the tumor. It's something that is what we did. I mean, in colorectal cancer, I was very with the TransMet trial, because the natural history of liver metastasis after transplant, just the natural history, not saying better or worse or whatever, but the natural history is different. And why? Probably because there is a different immunological control in the recipient that has to do with the fact that he was transplanted. So I have no answer, but I think that we should invest in this because let's say, we can imagine some kind of immunomodulation, this kind of patient, to check whether or not we should go in a direction of the machine or in some, let's say, advanced ACC, let's avoid the machine to increase his immunocompetency. It depends. Depends. Again, map reloading.
John? And then Daniel Shah.
Thank you, Vincenzo. Fantastic talk, and it's always a great pleasure to listen to you. Part of the reason why the patients may be doing better, that bit of slide there, the TEMRA cells that you were talking about, that's very exciting data. Specific immunocompetent cells after you do the transplantation. You said it's part of the immunotherapy and complemented or potentiated transplantation.
Yes.
And that might be part of the explanation overall why.
Yes. Yes.
But I was going to ask you, did you measure these TEMRA cells in patients who have the immunotherapy but don't undergo transplantation?
Yeah.
You'll get that. So.
Yes. Yes. And there is a huge difference. Patient who had a let's say, similar response to immunotherapy versus those who had immunotherapy plus transplant. It's more or less the trial they did with the metastatic. So immunotherapy plus transplant versus immunotherapy alone. This is not a random. This is just you have 10 patients, they may be older, they are not treatable for transplant, so but they have a good response. So, and there are a big, very, very significant difference. The point is, we don't know if those TEMRA cells are anti-tumor. So you measure the TEMRA cells, so you measure the T cells which are competent, but they can have a rejection, for example. So another possibility is that this patient, since they have a potentiated immunity, in 3 years' time, they will all end up with chronic rejection. Who knows? It may be possible. But they are the same cells. What is amazing is that we have the same mechanism. So they are the same cell that they need to know whether they have to fight the graft or whether they have to fight the tumor. They are the same line of immunological condition. And so it's a very intriguing area.
Thank you, Vincenzo, as always. It's all about immunology and it's contradictory objectives here.
Yes.
We have been working on tolerance and reducing immunosuppression. Now we want to induce immunostimulation, and we want to find the right balance between anti-tumor and no rejection. So there have been early data showing bad rejections in patients receiving immunotherapy.
Yes.
And we have seen the data from Sinai, and some of your data as well. And now the washout time is 3 months. At least that's the message. Do you, and also this induced immunostimulation, both with the immunotherapy and also with the graft, as you're showing now. We don't know, and you just said that if these cells are more anti-tumor or anti-graft, and so we're playing a game here. So my question is, do you think it's ready for prime time to say you can go for immunotherapy for 3 months and then transplant safely the patient? You think this is a safe message at the moment? And now we're also working on double immunotherapy. What do you think of that? But
Well,
first question is.
I don't know. I don't know. I don't know. I would like to know your opinion and the opinion of all of you. What I can say that in our experience, we obviously have no priority patient, so we have no specific priority to decide when the patient would be transplanted. So, I mean, there are patients who had the last immunotherapy a week before, and
Go ahead.
a patient 5 months before. So, in average waiting time was 60 days, 57 point something in our experience. So, but I don't know. What I think is we should do this very carefully.
Did you lose patient to rejection?
We have 4 rejection out.
No, but did you have patients dying?
No, no.
Or did you have to retransplant patients?
No.
Rejection.
No, we had a, okay. We had a retransplant for surgical complication.
Okay,
Because these are not easy patient to treat, but they had received a lot of other treatment, but not for immunological.
And I'd like to, so living related donor is the way to schedule the transplant from the last day of immunotherapy.
We try to start retrospective, maybe.
Can I suggest the next step for you is T-cell subset analysis
Yes.
to distinguish
Yes.
among the CD8 population?
Yes. It's called TCR, tumor cell receptor. It's a very, very detailed things to see.
Questions. The next is Thomas Atto, and then we will go for the second talk. Thank you.
Okay. All right. So last comment. So I really appreciate your thinking all the time, even starting with Milan criteria, even up to now. Listening to your talk, I think there might be some more from the donor cell rather than the recipient side. The reason why I'm saying that, we did a lot of tolerance induction trial in our center in the non-human primate model. The one thing that we learned is that there's a lot of donor cell chimerism happening post-liver transplant. It's not just little, it's a lot of cells when the donor comes in. So maybe those donor cells who are not seeing the tumor, to see the tumor as a first site, they may have a better adoptive immunity maybe developed by the donor cell. There are some clinical trial happen, the proposed by Hiroshima, Dr. Oden in Hiroshima, to infuse donor-derived natural killer cell. But a natural killer cell is not, like you said, an untrained cell. So maybe it's not working too well. They did it in Miami, they did it in Stanford about this natural killer cell infusion post-liver transplant for cadaveric organ transplant, which may not work. But I think we do think maybe train donor cells, like, vaccinate the donor prior to giving the organ. I mean, something like that could work in that context. I just want to know your.
No, I fully agree. I think the experiment that were made in the past, they were not selective at all. I mean, you just put a lot of cells doing, some immunopotentiation, but you don't know in detail. Now with the technology we have, we can select, and we can also, pursue some perspective, like you said. I mean, we can do in advance, maybe avoid transplant because of fantastic immuno results. I don't know. Yeah, of course.
I think we can go on the whole day to discuss but I think personally, most of the questions can only be resolved by living donor liver transplantation. And we must change our minds. We must do like in Asia. we must do living donor liver transplantation. And then you can treat your patients as in all oncology. Like Danielle said, you program and you can do research, everything. But of course, it's a fascinating field of medicine, gold mine for research. Thank you very much. So we stay in the field, and next speaker is our friend Christoph Sienewicz. Will address the problem of liver transplantation for liver metastasis. And as he is now working in, I think, the biggest transplant center in Europe, surely tell us something about this new field in the.
Thank you very much for this kind introduction. My colleague, your compagnon, first of all, I would like to thank Professor Bismuth and the scientific committee for giving me the opportunity to share our experience on this topic. Professor Vincenzo Maffera already mentioned the wonderful idea of transplant oncology. I dare remind you that it was introduced in the late 2019 by HPB and Gonzalo. They defined and showed the principles of transplant oncology, highlighted the changing landscape of malignancies by interpreting this concept. First, Professor Mazzaferro showed us the extremely wide horizon in brilliant lecture of the transplant oncology, and for that, that's for us so interesting. In one of the papers, I found the timeline of the development starting from 1996 of the Mazzaferro's criteria. But coming back to the topic, data in literature from the current attempt to liver transplantation for colorectal metastasis appeared in 2013 by the group of Norwegian transplantologists from Oslo. Of course, through these 12 years, a lot of improved, all that thanks to progress in genetics, in diagnosis, in technical, surgical skills, and artificial intelligence, I have no doubt. In his wonderful paper published 2 years ago in Cancers, a group of Vincenzo Mazzaferro showed the value of the liver transplantation in the treatment of hepatic unresectable metastasis, and additionally showed the risk factors which are associated with the worst outcome in this group of patients, underlying the disease extent, the already mentioned molecular biomarkers, the features of the primary tumor, and the data regarding liver metastases themselves. I found a quite interesting article putting a question, liver transplantation, metastatic colorectal cancer. Are we ready for it? I think that we are ready. However, the liver transplantation, as one of the scientists told, is a victim of its own success. There is no sufficient organ supply while the indications are constantly widening. So due to the donor liver scarcity, the transplantologists are forced to use the alternative sources of grafts, as you see here, extended criteria, DCD, live donor split, rapid concept, and by the definition, the results may be worse when compared to the traditional DBD or DCD or even graft. The breakthrough in the topic of liver transplantation for colorectal metastasis took place a year ago at the ASCO annual meeting, where the companion, René Adam, presented the results of already mentioned by Professor Mazzaferro transplant trial that proved the great advantage of the liver transplantation and chemotherapy when compared to the chemotherapy in very selected group of patients, 57% of 5 years survival when compared to 13, of course, it's that much convincing. Yeah, a few months later, in the Lancet, published the results of the Transmed trial, proving the applicability of this technique for the clinical purposes. Of course, there is no rose without the thorns. Olivier Subran published quite recently, last year, in Annals of Surgery, the important paper in which he concluded that the growing imbalance between the offer of liver grafts and the demand for these patients, there's a kind of a liver gap, and we first of all have to face this gap. Coming back to our experience, we are entering this area, transplantation for the patients with unresectable colorectal metastasis, try to find the best group of patients that will benefit from this mode, the way. Among more than 3,000 liver transplants we have performed since the beginning of our program in 1989, we have selected quite recently, only we found 11 patients in which the transplantation was performed for unresectable colorectal metastasis. I try to show you the clinical data and the outcomes, especially in terms of overall cancer-specific and recurrence-free survival. Our clinical and radiological criteria, of course, the first one was radical R0 primary tumor resection. We excluded the patients with extrahepatic metastasis and local recurrence. We exclude the patients with the direct attachment to the important venous structures and hilar structures in the liver. We excluded the patients with undifferentiated adenocarcinoma and signet cell cancer. Of course, the extensive lymph node invasion was a relative exclusion. However, we accepted the group of patients with previous metastasectomies or after local regional treatment. PET exclusion criteria were a high metabolic tumor volume and tumor glycolysis, and the bad ECOG status was also exclusion in our group of patients. For molecular criteria, we took into consideration the gene mutations of the primary and metastatic tumor. We excluded the BRAF mutation, excluded relatively all the RAS mutations, and the exclusion deal with the high microsatellite instability and the DNA mismatch with genes. RAS mutation with the TP53 mutation and the APC mutation were, in our settings, unfavorable prognostic factor. However, we are not excluded those patients. Another criteria were biological assessment of the metastasis. We look at the complete response for the chemotherapy. Of course, in modern settings, take into consideration the Chan criteria, MD Anderson, otherwise known criteria. the patients should undergo minimum 6 cycles of chemotherapy, then minimum 1 year observation from the diagnosis to the listing. Of course, at the evidence of the cancer progression, we excluded those patients. This carcinoembryonic antigen was monitored through the entire process of qualification and listing. This is our data. You see the majority of our patients have the primary location at the left column. However, they will have one right and the rectum primary localization. The majority will have had the synchronous metastasis. And following the data, our first transplantation took place 7 years ago. However, the structured program was started 2 years ago. As you see here, during monitoring of carcinoembryonic antigen at the time of transplant, we found that only 3 patients with elevated concentration, and unfortunately, those patients occurred in the relatively short time. Median time of the chemotherapy in our cohort was more than a year, but in contrary, we have quite short time of listing from listing to the transplant. Our median follow-up is more than 30 months, and you see it varies from 51 to almost 0. This patient with 0 follow-up time was a case that we observed the primary non-function and the death of this patient. For the recurrence, the main locations were lung, liver, and peritoneum. I draw your attention to those 3 patients with the recurrence given the high concentration of carcinoembryonic antigen. These are the overall survival, 61% in almost 5-year observation, 74% in cancer-specific survival, and only 38% of the survival recurrence-free in this group of patients. Just to complete follow-up, we use the immunosuppression MCO-based. We do not perform the routine chemotherapy after the transplant. As you see, the recurrence was quite common in lungs and liver, as previously shown. However, radical surgical treatment of new location, like in lungs, was not excluded. Of course, we did it if possible. So, in summary, ladies and gentlemen, for the patients with unresectable colorectal metastasis, the liver transplant will be a fascinating therapeutic option, giving the chance for the long-term survival, but in very carefully selected group of patients. As we all know, temporarily the evidence is limited. The possibilities of transplant will significantly widen, gain experience and knowledge about the risk factors, selection criteria, and results. We need to increase the donor pool, as I already told. The recipients assessment, we recommend the test of time, which might be the surrogate of the tumor biology, close multidisciplinary cooperation during the entire diagnostic process. And for the future, as beautifully displayed, Professor Mazzaferro, we need new biomarkers, genomics, the information about the ctDNA, and we have to take into our thinking, the way of thinking, the recent and contemporary achievements in the transplant oncology, the immunotherapy. Thank you very much for your kind attention.
Thank you very much, Christoph. I suppose there are questions. Okay. So we have.
Congratulations, Professor. Very good presentation, very good data. We see that we really have very restricted criteria. We have less than 1% of your patients that is submitted to transplantation. And my question goes to that direction. If we look to the history, when we started liver transplantation for HCC, we started proposing for only large lesions, and the results was very bad. We waited more than 10 years until Professor Bismuth in 93 or Professor Massafero in 96 to change the idea to do transplantation for small lesions. My question is, do you think we may go this towards that direction in the future to propose liver transplantation for minor lesions to change the liver and maybe diminish the recurrence?
Thank you. That's a very inspiring question, I have to say. Of course, we cannot predict the development, which are directions in the transplant oncology will be proposed in the nearest future. I have to say that the tumor biology is the absolutely crucial and principal direction. Like Blake Cady, who told that the biology, the tumor biology is the king, all the other features are only the attendants. So, in my opinion, at the beginning, we will reserve the liver transplantation only for unresectable metastasis, but having more organs better to the livers. Unfortunately, they are not growing on the trees so far. Maybe it will be the better solution, as the basic oncological principle is that we have to remove the entire. But we need much more evidence and much study in this particular topic.
Thank you. I may make a comment. Selection is, of course, extremely important. I've seen together now with René Adam, I think, from 200 patients with this indication and speaking about transplantation. If you look at your patients, 3 patients had a rapid recurrence with peritoneal metastasis, and they died, but they had all, at moment of transplantation, a high CA level. So if the CA level is not normalized or almost normalized, it's a bad indication. So these patients can be avoided. So when we do it, we must really be strict and keep the selection. Another lesson that we learned also is, I've seen, if I remember on the slide, that the delay transplantation was, I think, 1 year stability after chemotherapy. We learned also it's much too long. There are patients who lose their chance to be transplanted if the waiting time is more than 3 to 4 months. And I think Laurent Chiche had some bad experience, I think, with patients on the list. And these at that moment of transplantation, for instance, peritoneal metastasis. So the protocol has really been followed. Otherwise, every bad result is contradictory and counterproductive to develop the programs. And I repeat what I said many times already, it has nothing to do anymore with the pathology. It is transplantation for difficult oncologic patients. And this is the danger of this program now.
I absolutely agree and appreciate your comment, Jan. But as I titled, it's the kind of initial experience in a quite small group of patients, and I used to call it kind of a learning curve. So we are gaining experience, and of course, having this data will never qualify, never list the patients with the high CA concentration. However, I guess and I believe that soon we will have more precise biomarkers used in those patients.
Just one question. Thank you very much, Christophe. But in your center, because it's the largest center and I know it, for your transplant meeting for these patients, do you set up the protocol and is it the same protocol for the oncologist or not? What type of chemo? How do you follow? Because I didn't hear in your slides what do you do?
Thank you. I will give those data, but for the interest of time, our master, 5 minutes. I'm sorry, passing this time of the lecture. But of course, we have our oncologists. Some of them are very enthusiastic. I used to call them the transplant oncologists because they are very eagerly discussing with us the chemotherapy, not only for the colorectal candidates, metastasis candidate, but for cholangiocarcinoma patients or
Particularly this group you decided on, because
yes,
that's the
absolutely.
Very good. Thank you very much, Christophe. I appreciate it. Paul Jaimon from New York for his talk about the factor explaining the growth of liver transplant in the US.
Yeah, thank you for the privilege of speaking. This is not a very scientific talk. I got the idea. I was asked to write a editorial about a paper suggesting that split liver transplantation was greatly affected by a change in allocation policy in 2020. But in fact, when I started looking at this, I realized that there was a huge change in the amount of liver transplantation. And I will show you what happened. I think it's pretty remarkable. It's multifactorial. And but anyway, let's take a look. So to start with, in 2015, the total number of deceased donors in the United States was under 10,000. And last year it was almost 17,000. That's now 50 per million deceased donors. So that's a 87% growth in a decade compared to a flat period of deceased donation prior to that. Living donors increased less, and this is kidneys and livers, of course. And deceased donors that donated livers was 12,000, which was also a big jump in the decade. Liver donors doubled, but you see, this is still a very small fraction of the total donor pool. We discussed this earlier. So in 2024, we did 11,000 deceased donors in the nation, which was a 60% jump. And of course, the same number, one living donor was discarded. Now, there is still some probability for growth in theory, because we continue to discard 1,300 livers each year. These are livers that were recovered for transplantation, but not used. So a few thoughts here. There's a change in demand. Olivier talked about the liver gap. We can look at that. There's a change in the organ supply, which is dramatic, I think. And there are outcomes and center behavior having to do with organ acceptance and so forth, and risk aversion. So if you look at the wait list over, this is just the 3 years. This is all UNOS data, or I should say OPTN data, slightly different. The liver demand is relatively stable now. You see 13,000 new patients added, not much different from year to year. We're at, in a sense, steady state on the demand side, but we continue to remove more patients, meaning they leave the wait list. Now, what happens? In 2021, 8,000 people left the wait list because of deceased donor transplant, 400, 500 for living. And you see, so, but still, 1,100 died, and then another 1,000 were too sick. So this is, still almost 20% of the removals were for death. Last year, we don't have 24 here, but last year, an extra almost 1,500 patients were transplanted, but the number removed for death is decreased, and the number too sick is also decreased. So maybe we're making a little progress in managing the demand. Now, we talked about the distribution of the weight. So the alcohol-related liver cirrhosis is the most important contributor to the wait list. Now, you see hepatitis C disappearing. HCC is relatively stable, maybe a little bit of growth. And the other transplant oncology diagnosis that we talk about so much are not even detectable in the national wait list data. So this may come as a source of demand, but so far it's very small. The deceased donation, this is over a decade or so, has gone up primarily in the 3 older age groups, and most importantly in the above 55. So the extraction of potential donors for liver transplantation is coming by growing use of older donors. Now, the other thing that's growing, and this is just 23 data, but it's even more now, the DCDs, as of course in Europe, in UK in particular, the DCDs are growing rapidly in the US. And so that's a big source of the increased number of donors on the wait list. Now, an important change just about 2 years old now is the rapid proliferation of the use of machine preservation for deceased donation. And you see the Arizona Center has this Mayo Clinic has been the biggest user of machine preservation. They're doing so many cases. And you see, of their first 320 or so, the great majority were DCDs. Now, DCDs have been adopted early by a number of groups, but the use of machine preservation, which has become nearly routine for deceased DCDs, as well as marginal DBDs, is becoming widespread. I don't have national data for this, but anecdotally, we know from some very prominent centers, Wash U with Will Chapman and Charlie Miller in Cleveland, the great majority of these marginal livers are being subjected to machine preservation. Now, this is a very important option, which Tom Cato has been trying very hard to get us to implement, but there are still many barriers, and there is great differential in the application implementation of normothermic regional perfusion, which is a form of total body preservation, which seems to be associated with the very best results for donation after cardiac death. So certain areas of the US are using it a lot, and other areas are using it very little for a variety of reasons that we can discuss in the conversation at the end. This has been noted in several series. There's, we think, essentially no cholangiopathy associated with NRP, in contrast to standard machine preservation, where the telangiopathy rate remains somewhere about 5 to 8% in DCDs. Now, as far as living donors, this is a small fraction of the total transplant population, but I would say in the United States, we consistently see the right lobe is the dominant transplant, 80, 90%, which has to do with something we'll talk about this afternoon regarding small for size syndrome and the risk of graft failure associated with small grafts. So there's very little innovation taking place in North America with living donor liver transplant beyond what is known to be highly successful and effective. I don't have all the years for this, but the increase in transplant numbers has been accomplished without a penalty in graft survival. So the graft survivals are about the same as they have been for the past decades, somewhere about close to 90%, short-term, approximate 90% at 1 year with decrements that are expected. Now, a couple of comments about preservation in the US. There are 2 systems that are FDA approved, widely used. In fact, a lot of teams now, well over 50% of all donors are being pumped. Very expensive proposition, but as you figured out, money in healthcare in the US doesn't matter. It's a big corrupt business, and we're all profiting from it. So don't worry about cost much. Transmedics is a great system. It's very well validated scientifically and clinically, and it provides full service. So you get the phone call, you call Transmedics, the liver shows up whenever, and everybody gets to sleep, and you start the recipient. Full service recovery, much more expensive, of course. They cannulate in the field, which in theory is better for DCDs, but in fact, the interval from a recovery to cannulation can be up to 2 hours. So the benefits of normal thermic regional perfusion, where you have immediate protection of the organ, does not happen even with machine preservation. And of course, it's very expensive. Organox is the Peter Friend's product, also a very beautiful system, but it is not provided with organ recovery service, which means your own team has to put it in. The advantage, though, is you do have control. You can't use Transmedics for back to base, but it means that you get a phone call about a marginal liver anywhere, send it, and then our team will put it on the machine. We have the impression we have more complications with Organox, but the differences are small. And it is about 1/3 of the price. So to the extent that price matters, Organox is more favorable. So if we just kind of look at the hierarchy of the technology, the thing that is holding NRP back, at least in our region and in many regions, is there is still controversy about the ethics of the brain death issues. The risk of reanimation of a dead person is of great concern to some ethics, and our own hospital has prevented us from moving forward. We're allowed to use other people's recoveries, but we're not using this NRP at this point. So, but now the other thing about NRP, you have to send it out into the field with perfusion and so forth. There are now companies that provide this full service. So it's very intriguing, and it's very important. NRP can also be combined. You can't have prolonged storage with NRP. So you can either put the liver in right away, just like a standard DC, standard transplant, or else you have to recover it and then put it on the machine for later use logistically. I talked about the machines. We've certainly increased our aggressiveness, all of us around the country, in terms of marginal livers. they call it machine courage. So you can horrible donors and put them on a pump and see how they function. We learned the bad hard way that you take a horrible liver, you put it on the machine, it expires and clears lactate. It doesn't always work. So we've had to become a little less aggressive with our machine. As I alluded to before, in DCD, biliary injury is not eliminated by machine preservation, so you have to be cautious about that. But certainly it has permitted more aggressive donor selection. Now, the other important logistic advantage of having machine preservation is if you have a hepatectomy, or if you have a recipient who might be contraindication, might be discovered during the dissection. Put it on the machine, you call the next patient, you have 12, 18 hours to get this. This is a huge logistic advantage. And the other important thing, which is not completely widespread, is in here you can convert the patient from a nighttime job to a daytime job. The problem is that all the other surgeons and the hospitals expect us to work at night and do not want to give us more OR time to work in the daytime. So this is a logistic conflict which is not fully resolved. The graft evaluation of the organ on the machine remains imperfect, but we're very optimistic. It's all kinds of work coming from around the world. So the causative factors have to do with public policy and increased donation. The federal government has gotten very interested in the performance of donation organization at what's called OPO, a procurement organization form. The technology we've talked about. Now, the published criticism of centers with poor outcomes has been a source of risk aversion, we call this, among centers. And that has been relaxed a little bit to encourage more transplantation. So both public policy for donation and outcomes assessment have led to this growth. And finally, most of us who are transplant surgeons are innately aggressive and want to do more. And so this is the other part of it. And we've been able to do more while preserving outcomes. So in conclusion, remarkable growth in a decade, a national movement driven by public policy interventions. And we know there's medical evolution of indications, which will continue. And finally, the surgical evolution of technology. Thank you.
Thank you, John, for a very nice presentation. And John Isaac is our discussant.
Yeah, thank you, John. It's a happy story. I mean, it's good to have a happy story. But what occurred to me is, centers, jurisdictions that start their transplant journey with disease donor transplantation tend to stick with that rather than live donors. And you can see the development of live donors in the UK. You had a period where it went, but it's very static. And on the other hand, in Asia, where they started their transplant programs with live donors, the vast majority are done live donors. They have trouble increasing the disease donors. And younger said we must be doing more transplantation, go down the pathway of live donor. It's not one or the other. I think probably have to increase both. You actually have not seen the demand yet, as you mentioned, for the cancers. So both have to be developed. So my first question, I like your opinion on this. The growth in DCD, you alluded to the UK, 20% of transplants are DCD. And part of it is working hand in hand with the gatekeepers, I call them, of DCD. These are the intensivists. And when you get better results, you can go to the intensivists and speak to them, say, look at our results for DCD. And that has a potentiating effect. They would go out and say, we're on board with DCD. And that comes from NRP, and that comes from, for DBD, it comes from NMP. We're getting the better results using those two technologies. So the first comment, first opinion I'd like from you is do you think that showing better results with the technology is going to encourage that sort of process where you are going to get more referrals for DCD especially?
The problem that we have is that the motivations of the community that cares for potential donors are completely unrelated to the motivations of the transplant community. We can call on their altruism, like you do all these extra work to generate donors, and that's a good thing, and more people can be saved. Haven't had so much success in convincing that the donor doctor, or I should say the end stage brain injury community to be motivated for things that are good for transplant. The thing that has moved the needle is the organ recovery infrastructure, you know, the OPOs and so forth, and federal oversight and regulation to drive that forward. But I think we need to do a better job communicating the benefits of DCD to the whole community. It's definitely changing fast, but not enough.
Thank you. The second comment was on those, the companies, Transmedics especially, have such a slick, organized system. I basically call them, they have a team of surgeons intrinsic to the company, who'll go out with them, get the graft and bring it back. So what about training? Because transplant surgeons, there's a rite of passage, you know, to do the donor operation. Every fellow gets trained by another fellow, and it's part of your journey in transplantation to do that donation and go out, you know, and do these cases. Is as a problem going forward?
Well, so that's really a big issue. And we're living in a time of transition when organ recovery is becoming a professional specialty within transplantation. And it's better. It's better to have professionals. And most of the very big centers, we certainly did this. We have a faculty member now whose main focus is organ recovery and optimization of fusion system. And many centers have this. And organ recovery surgeons are also being hired by the organ procurement organizations, not associated with the transplant center. So what does that do to training? Our fellows used to graduate with 100 to 150 deceased donor recoveries at the end of 2 years. It's too much. Each organ recovery is 12 hours of time away from the hospital all night long in airplanes and so forth. It's not a particularly healthy form of training. So the fellows now do less travel. Dr. Cato has instituted, we recover all the distant donors come from Transmedics. We don't like to, or we don't need to send our teams out so much. It's safer, it's healthier for the things, and they still get plenty of experience. But it's a professionalism within transplantation.
There are several questions. I'm going to make a prediction. You have to be short, but I will first make a comment, if you don't mind, about the machine, because I agree, Transmedic is well known, but it's very expensive. And I agree with the comment also, because it's a separate team who does the retrieval and when you deliver. I believe that in the future, as you said, you will have a sort of factory lab where they will take care of the organs, and it's coming in. However, what is your opinion? Because I don't think that I will see that in the future. You will have several papers from different perfusion machine, but you will never have a comparative between the machine. Exactly. So we will never know. There's still a competition of that.
Yeah.
However, what I wanted to say is about the training. I agree that it's less tiring and it's good for the fellow not to do that. However, but if you can imagine a surgeon doing that all the time, it is not also viable. Should do both a bit of retrieval and transplantation for the benefit of the
Yeah, maybe,
patient.
maybe. I think though there's a phenotype of person who likes the freedom of recovery. It's a subspecialty that selects a different type of person.
John.
Yes.
One question. Thank you for your overview. Historically, I will focus on just on split liver transplant. Historically, there was a difference between Europe and USA in percentage of split transplant. We were running about 5%, versus 0.5% in USA. So actually, I didn't see data on split liver transplant. What killed finally this procedure is the story of machine perfusion, the DCDs, the public policies, the difficulty in organizing, collaboration between 2 or 3 centers. I suppose that this procedure is definitely death in USA, or I'm wrong.
Well, no, I would say we're still at about 2.5% of split livers, most of which are in the context of a large organ being offered to a child. So the centers that do a lot of children do a lot of split livers, and no one else has a lot of interest in split livers. And all the efforts we have made extending living donor technology to right and left splits for 2 adults is still a very tiny.
Mainly pediatric.
Yeah, it's just too much trouble, to be honest with you. I mean,
Last remark. Yeah, go.
Little question about the education, because what you told already, in the old days, we always went at night for the procurement. In the Netherlands, it has changed now. So we have, first, you have to be certified. So it's not that everybody can do the prélèvement to get it. And secondly, there is a team. So that means there are surgeons, there's anesthesiologists, there are nurses. So they go as a team and they just need an operating room. They don't need personnel. So they're completely independent, which makes that they can, if there is one operating room empty, they can go in the day, then the night you put it on the machine, and the day after you can transplant. What's your vision? Is that?
Yeah, that. So the very best results in the US have taken place in regions that have recovery centers completely independent from the hospitals, because the hospitals lose money if a deceased donor is occupying one of their ORs. So the hospitals, that's why they happen at night. So this sort of logistics is very, very necessary. Dr. Rong, who recently trained with us, she knows a lot about recoveries.
Thank you, Dr. Mon. I have 2 questions. First question is, as you know, we are the biggest center in Montreal, but I don't feel we're doing enough still, and we'd like to expand. Since I came back from Colombia, we've been trying to use more marginal grafts and pushing our boundaries, but I wanted to ask you, what are your advice on balancing volume growth and quality outcomes? Because our staffing, hepatologists and ICU staff are used to a certain outcome with maybe better grafts or more conservative grafts. And now we're trying to expand our, offer. So do you have advice on that?
Yeah, Canada is very different. I mean, it's a great country. And the money available to do a lot of stuff is less. And Quebec is particularly that way. So there's not a financial incentive to do more in Quebec that exists in the US. Now, the Toronto Center is one of the biggest centers in North America, and they are aggressive. They use marginal donors, and they use a lot of living donors. So they might be the best place to look as far how to extend the successes in Ontario to Quebec. The other thing, and I don't have the data as well as I do in the US, but deceased donation is much lower in Canada than in general than it is in the US. So if you're going to grow the volume, you need to be more aggressive in donor selection. You have to bring your team along. You're a magnificent surgeon. You'll have great outcomes, even if you increase donor risk.
Thank you very much.
Okay, thank you very much. We have to go on. So if I understood well, the next presentation will be done by.
So I don't think we are late and Dr. Lothar is putting off kindly presentation of next year. Transportation engaging persons is a theme that will be just.
Thank you. In that case, I'm glad to present Yann Leroux, who is going to speak about acute transplantation and some other about the subject.
Thank you very much, Ina. So when I come to Switzerland, is of course always from a bit particular because it's a different homeland. And this time is even a little bit more particular because the meeting is organized by Pietro Magno, and many of the young people do not know, but Pietro is the spiritual son of my very best friend for more than 30 years, Gilles Martin. So I cannot give this lecture being in Switzerland without saying about this. So 30 years ago, more than 30 years ago, when I was very young, I got a grant from an association that is very, very high rated by Donald Trump, is the NATO. And curiously, I got this grant for two inexisting fields in surgery and medicine. It was liver surgery and liver transplantation. So I speak about 82. And I tried the use of this grant, just can imagine very unusual, to go to the Mecca of liver surgery. It was in Paris with Professor Bismuth. And afterwards to the Mecca of liver transplantation, which was of course in Pittsburgh, led by Starzl. And when I came in Paris, the first person I encountered was Gilles Martin. And Gilles Martin, he impressed me because he was an extremely intelligent surgeon, a very analytical surgeon. I don't know why, maybe we had some trust showed to the outside, but Gilles and became the first foreign doctors who became responsible for a ward in Paul Brousse. Maybe you don't remember it anymore. And Gilles got Paré, and I got Fernel. The two were together, so we met each other every day. And we had same ideas about learning everything about this organ that is in the right upper quadrant of our body. And finally, we became friends and even more friends. And then in the hospital, when everyone was out after 9 o'clock, Gilles and I, we studied all the charts of all the patients that were hospitalized every day from about 9 o'clock till 1 or 2 o'clock in the morning. And I think we at that time maybe the most beautiful iconography about hepatobiliary diseases and transplantation in the world. We were the best client of the Photoshop at the corner of the Paul Vaillant Couturier Street. We went there every day. We had pictures and slides from everything with all the comments, of course, from Professor Bismuth, with all the one-liners, such as postoperative problems could be resolved before and during. And every type of pathology had comments on the selected radio and X-rays, all in different colors. So all we were twins, intellectual twins. All the blue cards were for portal hypertension, all the yellow for the icteric patients, all the red one for vascular diseases of the liver, and so on and so on. So I left Pittsburgh. Gilles stayed on board. When he finished in Paris, he came to Pittsburgh. I took care of him. And then our ways went out of each other. I returned to Belgium, he returned to Switzerland. And when we saw each time, the last time, he said to me, when we do the first transplant in Geneva, you will be the first person I phone. So he was supported very well. I respected Professor of Surgery, Professor Roner, a good friend of Professor Bismuth. And so he was lucky to set up his program. I went back to Belgium. I got some, I must say, cold showers, despite the fact that Professor Bismuth came and I organized a symposium and I gave him a nice title from 1 to 8 segmentectomies. I don't know if you remember this. And despite the fact that Starzl came to Louvain, which is in fact now, after Cambridge and Oxford, the most important university in Europe, we were not able to do the transplantation program in Louvain because the highest shots of our hospital and faculty said to me that there was no place for experimental surgery in humans. And Gilles, in fact, he did a transplant in 87, and 87 is an important year because I decided to quit and I came to Switzerland, where I became chief of transplantation in the new department of surgery led by Blumgart. I don't call him Professor Blumgart. And in fact, at the time, Bismuth developed all Bismuth's program. Gilles Martin developed his program. But after the journée hépatobiliaire, I went to Professor Bismuth and I took with me my friend Francesco Meriggi, and I said to Professor Bismuth, why should we not make a group of people who have been trained in Paul Brousse? And this is then the Compagnon. And we had a very complicated administrative board. There was Professor Bismuth as a president. I was a secretary general for 28 years. And Meriggi was the adjunct secretary, and he was the master in the ceremonies for intronization of all the new members. You remember very well. At that time, we were in 87. And today, 38 years later, you multiply 38 by 3, we are under 12 members. So this is the history. I came down to Bern and I worked a lot with Gilles Martin, and we laid the ground for the transplantation in Switzerland. Nobody knows this, but at that time, Bern had done the first transplant. The program was stopped before I arrived. Gilles developed a transplant. In Lausanne, they had a good program led by a well-known person, Professor Gillet, who was known especially for transplantation in Echinococcus alveolaris. Basel wanted to transplant. In Zurich was a crisis. There was no surgeon anymore. I had even to do the procurements in the Zurich University Hospital. And also St. Gallen wanted to transplant. And finally, it was decided after many meetings, Gilles, me, and the network of hospitals in Switzerland, that transplantation could only be done in Geneva, in Bern, and in Zurich. And as a compensation, the heart and lung transplant program from Geneva went to Lausanne and the center. So this is the history. You see what is written on this, Gilles and I also, we saw rapidly that liver transplantation, it's not all about surgery. Surgery is the smallest part for me in the transplantation business, but it must of course be done well. And you can imagine when you have seen the title, some people in the room know how I think about transplantation. I have sometimes different views. They come true after 10 or 20 years, but they come true. And so I will give this lecture in honor of my good friend Gilles Martin, one of, I think, the most respected compagnons that we have. So I come to the topic. If we are confronted to a liver graft dysfunction, in the first month or 2 months, in pole position in the differential diagnosis is the T-cell mediated rejection. We can call it acute cellular rejection, but it should be called rejection. And the further we go from transplantation, you see that rejection is in fact not a problem, despite the fact that still many patients are treated unrightfully for so-called late rejections. And I want to remind, especially for the young people in the room, that acute rejection is not necessarily an early event, and chronic rejection is not necessarily a late event. So how does this work? If you look in the literature, there is a lot of confusion. And I like, in fact, that this presentation is in a session of oncology, because I think in oncology, the most important thing for me is to work on immunosuppression. And you see that there is a wide variability between centers in relation to the incidence of rejection, going from 10 to 15% still in the latest very good studies, that we have a very big variation to definition. What is a steroid-resistant rejection? Is this someone who does not respond to 5 grams of prednisone when he's almost killed? Or is it only after 1 gram of methylprednisone? So a lot of confusion. The treatment varies widely between all the centers, but there are some important observations that we should keep in mind. It's not from me, but of course from Professor Starzl. You can have a rejection if you use a very heavy immunosuppressive load or a very low, you can have a rejection. A rejection has been well documented, can spontaneously recover, but most importantly, a rejection episode can even be beneficial for the outcome. You see, these are 3 studies from renowned centers, the Mayo Clinic, the Birmingham Hospital, and the Royal Free, where you see that if you overcome a rejection, your outcome in the long run is better. So this is contradictory, but it is true. And if you think about this, for me, it is logical. You overcome a big problem, you are better afterwards. Now we know that the activity, if you transplant whatever organ, the maximum is during the 2 first weeks. And you see that after 1 month, the incidence of rejection is falling dramatically. So the problem is the biopsies. And we know that the BAM score is losing its power the more we go away from the date of transplantation. And we should not forget that patients who make a late rejection, most of the time is due either they are not monitored well, or they try to take out immunosuppression. Either it's done by the doctors or it is done by the patients themselves, which is called non-compliance. But you see still the incidence of rejection, even in the recent studies, goes from 30 to 15%. No, I in my life never participated to an industry-driven trial. I only work with investigator-owned studies. And you see that the diagnosis of rejection is based on the BAMF score. I worked a lot with Professor Demetris from Pittsburgh. He's the Pope of, I would say, transplant pathology. And BAMF score, it's a score developed in a nice city in Canada. It is a 3-tier score, and depending on the numbers that you get, you have low or you have a very severe rejection. Now, in many studies, randomized controlled trials, they look at biopsy-proven acute rejection, but it is, of course, evident that if you do a biopsy in every patient and you have a score above 6 or about 4, that the patients are treated even if their liver tests are normal. So in most randomized controlled trials, the conclusions for me have no big value. Now the clinical picture is even more unreliable because since that we use cyclosporin and surely tacrolimus, the clinical picture is in fact becoming inexistent. I have seen 14 years ago patients with 39.5 fever, which does not exist anymore. The radiologic picture is not reliable at all. And the biochemical picture is in fact, in contrast to what many think, is also not reliable, except for the bilirubin, who goes up during 2 or 3 days in a row. But again, the drawback of the clinical evolution, this is again a problem from the studies which have been set up by the industry. You have a combination of biopsy-proven acute rejection and clinical suspicion. But clinical suspicion has no value at all, as you can see. This is a study, very nice study done, where expert transplant hepatologists, they get the numbers of the patients and they have to tell if the patient has a rejection. First of all, you see there is no agreement with all these big hepatologists. And secondly, that the correlation of the clinical suspicion with the biopsy is almost inexisting. So if you treat patients for clinical rejection, most of the time you are wrong. So we did a study a long time ago. I don't like to present early results. There's no value for me in transplantation. We should look at the long run. So these patients have been followed for more than 10 years. They are all primary adult transplantations and they are all under minimal immunosuppression, all. And you see, if we would have all these patients have a systematic follow-up with protocol biopsies at the same time, a percutaneous cholangiography and so on. And you see, if we would look at the biopsies around day 7, where you have the highest allo reactivity, that we should in fact treat 80% of the patients for rejection. If we treat only the moderate or severe, it's still 1 out of 3 patients. So we divided in this study with our consecutive patients. We never exclude any study we did a patient. So if there's a insufficiency or is intubated, all the patients will study, because you must do reality studies, not select, and then say that the program. Now, some pathologists is different to make the distinction between band 5 and 6. So we cut off between 5 and 6. Why? Because in the first group of 264 patients, in fact, we had only to treat 4 patients for a suspicion of rejection. And what did we do? We correlated the histology with the biology. The histology of a patient has at the same moment BAM score of more than 6, and at the same moment, more than 2 of these 4 simple parameters, the dynamics of them, if they're important, then we speak about the clinical relevant rejection, and then we treat the patient. If he is rejecting, he gets maximally 1 gram of prednisone, and if he does not respond, we speak already about steroid-resistant rejection. We call this the 7-up score. Why did we choose these 4 parameters? The first one, you go back again to Starzl's book, 69, you see that if the bilirubin rises several days in a row, dynamics, you have killed many times with the rejection. Now, why did we choose eosinophil counts? Well, we know from the good literature that the eosinophil is the first announcer of a rejection. And he is also, as you can see here, the first announcer that your anti-rejection therapy works. I like always in my career to look transplanting the liver to the other organs that are transplanted in patients which have a normal liver. And if you go in these very good studies from Cambridge, if you look at heart, lung, and lung transplantation, you see that when you have an eosinophil count of more than 600, the probability that you have a severe rejection is very high. And this has been confirmed by Andy Burrock's Royal Free, which was, in my opinion, one of the best transplanted pathologists, together with Professor Benamou. They confirmed also, and they could not link rejection to any of the usual liver tests we use because there is too much overlapping. It's well known, there is no cutoff value. And the 4th parameter is a forgotten parameter. It's the dynamics of platelets. And again, when we go back in the book from Starzl, I did this now for many things I present, you see that there is always a thrombocyte fall early after transplantation. And this is, for instance, a curve made in what he called unmodified animals. So it are patients who get a liver transplant without immunosuppression. If they have immunosuppression or no immunosuppression, the platelets go down and they come up at day 5. And you see if there is a dysfunction and the bilirubin goes up, the platelets do not go up. Why is this? Well, again, if you go back, you see that you transplant the patient independently of what happened. You have always a nadir, and in the old literature, there are only 5 publications looking carefully at the evolution of thrombocytes after transplantation. This is one from Sydney. You see the platelets go down and they go up. If the patients go badly, they don't go up. This is a study from Groningen, it shows the same. This is a study from Zurich, it shows the same. And the exponent, the highest exponent of this is if you transplant patients in the context of ABO-incompatible transplantation or xenografting, the same phenomenon happens, but now not in days, but in some hours. So the nadir and the dynamics are important because you are independent of the day 0 platelets. You can transplant a patient with 15,000 platelets or 100,000 or 150,000 at transplantation. If you look at the dynamics from day 5 to 7, you don't have this problem. And we look carefully in all our patients. You see, we have 3 groups of patients. We usually work a lot with TAC monotherapy, but we prove that short-term steroids are not necessary and induction is not necessary. We have to, of course, do an investigator-driven study. And you see no patient get leuko or thrombopenic drugs from day 1 to 8. So patients only on immunosuppression. we have further transfusion from day 5 to 8 because we know very well from the Makuchi experience that if you blood, you have an immediate rise of bilirubin. And so you see, I call this a pure transplant model, and you look at the dynamics of your patients, and in all the patients, things happen between day 5 and 7, and you see again the platelets start to go up from day 5. Now, is this new? No, it's not new, but it has been forgotten. Professor Pichelmeier, in my opinion, one of the greatest surgeons in the Western world, already published in 1993 that if you have a rejection, you have a high expression of von Willebrand factor. Now, von Willebrand factor is known when you have the long strings, they agglutinate the thrombocyte sticks to the wall, and you have a thrombocytopenia. But the first group who really made the link between thrombocytopenia and rejection was the group from Miami. It's here, sitting in the room, maybe he has forgotten it, but they showed clearly that if you have a fall of platelets, you have a high incidence of rejection. And this has been confirmed in the Institute for Transplantation and Immunology in Kyoto by the Tanaka group, that acute rejection goes along with bad thrombocytopenia. So what is the reality? Here you see this very well. These are two patients from Brussels. They have both a severe rejection. The patient is bilirubin goes up, but if you look here, the platelets do not go down the black line. The eosinophils do not go up. The patient is not treated and he is doing well under monotherapy. In these patients, what I call a clinical relevant rejection, you see bilirubin gamma GT is going up. The platelets go down, the eosinophils goes up. The patient developed a steroid-resistant rejection. What does this mean in reality? That if you have diagnosed a severe rejection in 37% of the patients, when sticking to clinical histological correlation, you almost never treat a rejection, 3% of our patients. And you see that severe rejection is on. So in reality, the results is instead of 80 and 37%, we treat now 4.5% of patients. And you see that the rejection, 90% of them happen during the first. What is the performance of the score? This is also important. When we look only at the biology now, we see that this is a good surrogate for a biopsy. And this is, in my opinion, very important if we want to develop living organs of transplantation, in which we know that it is very dangerous to do an early biopsy. Another thing, and then I will end, it's important for evaluating clinical trials. In an investigator-driven study we did with induction, I look at the biopsies in the two groups. You see here, the green bar, you should conclude that the patients who have induction therapy do better, have less rejection. If we follow our idea of clinical relevant rejection, you see that there is no difference at all between patients who have induction and no induction. And what is the outcome? You see moderate, severe versus over the same. Patients which had the highest BAM score, they had the best survival. And you see on this curve for overall survival that if you treat patients with a severe or moderate rejection or you don't treat them, you have exactly the same results. So in conclusion, I think we should change our mind. The clinical histological correlation is really important in the setting of transplantation and especially in oncology, because if you bomb the patient, especially when you extend the indication, the recurrence is already going up. The bioscore is a good surrogate for a risky liver biopsy. And so the condition, not anymore of a T-cell mediated infection, but the clinical relevant one is that you will identify better the real incidence of relevant rejection, decide better which patient you have to treat, reduce the side effects, of course, of the therapeutic immunosuppression, because if you give a patient at day 5 grams of steroids, you can have more small gastrointestinal problems. And importantly, I said it already before, I never participate because of this in an industry-driven study. For me, almost all the conclusions of industry-driven studies have no value. So it is the only way to evaluate the real benefit of immunosuppression. Thank you very much.
Because I'm sure there will be several questions, so that's why we're saving time. The discussant is Pietro Maino.
That it is, Gary, the program is Emanuele Bantani.
From Pisa, who's joined this meeting, very experienced transplant center.
Thank you very much, Professor Leroux, for the nice presentation. I have only just a question. In the era of machine perfusion, that would seem that reduce the injury post-perfusion. Do you think that this in the future can change the immunosuppression strategies?
I don't think you have seen in the work we did, we concentrate on day 5. Why? When you transplant a patient, you know very well that all the ischemia reperfusion injury is repaired at day 5. Look at the factor 5, look at the biopsies. This is very clear. So that's the reason we don't look at 0 to 5, but that's not important. The dynamics is when it recovers, and platelets who go up are an indirect sign of also liver regeneration. So the importance is also, we have seen, we do not give platelets because platelets of rejection. And I think you must do transplantation without platelets. It's always been my opinion, but you must convince the anesthesiologist because the platelets are already immediately broken down. They make antibodies against HLA A, B, against everything. It is well proven. There are many publications, but nobody reads them. That's the problem. Many of these publications have been published 20 years ago. Nobody reads them, but it's very important. Also, no transfusion. Makuchi showed very well that you can let go a patient to 20 hematocrit without any problem. So that when we have a patient which is borderline, we transfuse eventually the evening when we do the biopsy at day 7, so that we have a clean biopsy telling something about a clinical histologic relationship.
Thank you. Thank you very much.
I have one question, if you don't mind, Jan. So, according to your presentation, do you think that we should change the band score? Because it seems that they are it's not so well scoring the degree of acute rejection, and we may miss. Second point is, what about what they've done for the kidney with the AI box to predict a perfect scoring? So that's my first question. And the second, according your trials that you've shown, it was mainly based with the tacrolimus-based regimen. But I have to say, when you look at the registry, the acute rate compared to 20, 25 years ago is lower compared to the other organs. So do you think that there was an impact with the new immunosuppressive regimen? And probably is how do you interact all these new parameters?
Okay, for the first question, a very good question. I am right at the moment involved in the revision of the band score with a whole group of especially North American, Canadian pathologists. We know that you cannot classify anymore after 2 months. You do a biopsy, you cannot say anymore, is this now band 6, 7, 8? So the paper is now under review to many experts and experienced people in transplantation, because the necroinflammatory infiltrate is going rapidly down after 1 month. But everything happens in the beginning. And probably what will come out is a completely modified band scoring, and maybe not a score anymore, but Jackie O'Leary is a very expert and Dimitris work on this. I'm also involved in this thing. So this is very important. In relation to immunosuppression, you know, I am a favor of monotherapy tacrolimus from day 0 with low dose, especially in the field of now transplant oncology. I never use I don't know what I do now in my center, but mTOR inhibition, I'm not a believer in it. I'm only a believer in it when the patient has a recurrence, but it does not show. But what is interesting to know, if we are in a session of transplant oncology, there is a very nice study that came out from the United States. I think it's Mayo Clinic in Cleveland and so on. And they compared patients transplanted, for instance, for HCC, using the retreat score, the risk evaluation for tumor recurrence after transplantation, or the ALT score, and you take exactly the same patients and you give them, for instance, induction, the recurrence rate goes up, doubles up. if you have a level of tacrolimus during the first 14 days of above 10, I think, you double almost the recoveries. So in the beginning, we must surely work on this.
Well, in that case, thank you very much, Jan. So I think that everybody's hungry, so it's lunchtime. Thank you for this brilliant.
Não, não, lá em comer em algum lugar. Exato. Pra recuperar. Bota no Google. No Google Translator para saber a pronúncia. Acho que é a parte mais difícil, né? Ah, com certeza. Será que eles não dão nem oportunidade para inglês? Sério? Às vezes você sai. Acha lugar para imprimir.
to welcome you, Roberto, to give your morphosite syndrome.
Thanks for your kind invitation here, also in front of this Parterre de Rennes et des Rois, and congrats for the excellent panel. I will give some insights about the morphosite syndrome, which is a very nice, complex clinical syndrome. Okay, so this is very manifestation of some kind of graft insufficiency caused by cholestasis, neuropathy. Syndrome is mainly occurring in partial graft, so large graft can be affected. The pathophysiology and the histological patterns are well known. And we can say today that there is a lot of evidence that portal hyperfusion combined to small grafts are the main factors leading to this syndrome. Then we have some reproducible surgical techniques proposed to improve hemodynamics, especially the balance between portal and arterial flow. And we have also some more evidence concerning pharmacological treatments which are today available. I think this small foot-size syndrome is a very old story. This is a famous paper from Bismuth group, which showed that the outcomes of small pediatric grafts into adults were a little bit more complicated than usually expected. And you can see that the increase of hepatic artery thrombosis, the retransplant rate, or also recipient death, about 30% were less than ideal situation. But nobody was thinking about this syndrome. And this is also a paper a few years later by Jean Aymon, who was describing these ischemic patterns, cholestasis in small grafts. But we had finally only the Kyoto group a few years later, which described different outcomes linked to the graft sites. You can see that the extra small grafts had more ascites, decreased the prodromal time, and also very early poor outcome.
Sorry, can you hear me? We need to share your presentation in Zoom. We did not see now. Okay, thank you.
I think we sorted it.
Good. So you can see here the overall incidence of small foot-size syndrome, which is roughly 10-12% in small graft, meaning a graft to body weight ratio less than 0.8. And also for larger grafts, about 7.9%. So this is not so frequent, but when it occurs, it could be a big problem because of high risk of graft loss. We had in the past different definitions. Finally, we went 2 or 3 years ago to a more shared opinion about the classification. So you can see the 3 levels, A, B, C, with the difference between day 7 and day 14 and mortality rates. This was a study from ILTS and International Transplant Group cooperation. As previously said, this syndrome is multifactorial because there are, first of all, clinical state, and so the clinical state is very important. We have graft factors. You can see here the volume, age, steatosis, ischemia reperfusion injury, which is also present in living donor transplant. We have also some technical issues, especially outflow. need for venoplasty or drainage of anteromedial sector in graft position for left livers is also very important. Then we have when the portal hyperfusion and splenomegaly and portal hypertension are present, we can have a altered or very altered hepatic artery buffer ratio which can predispose to vascular events. So histologically wise, this syndrome has been well characterized. So you have histological damages in the large animal models, in human models, so cholestasis, cell ballooning, disruption of the cell lines. And this is also our experience with shunted versus non-shunted graft. You can see how dramatic is the histological patterns in non-shunted small graft with portal hypertension. There is also a link between post-hepatectomy liver failure and histological damages. You can see here some results about histology and also graft and hypertrophy rate and regeneration. And this is also a nice picture showing that the volume is not always synonymous of function. You have here this ALPS model showing plus 51% regeneration, but less function as measured by mebrofenin scintigraphy. ALPS model is also very good to show the hemodynamic stress, which will definitely influence graft regeneration and function. And in this prospective study, we were also capable to show that people with less than 20 millimeter mercury pressure below 20 and the gradient below 15 had the best regeneration and function after ALPS. The problem of arterial to portal imbalance is well known. In liver transplantation, you can see how this imbalance is important in partial graft split liver transplantation. You can see that usually the portal to arterial ratio could be about 4 to 5, and in partial graft, this picture is dramatically increased. We know also that portal vein perfusion is not always correlated with portal vein pressure. This means that if you want to do some kind of hemodynamic evaluation, you should measure both. And when we are transplanting patients with portal hypertension, we are facing two situations. We can have hyperperfusion, but we can have also hypoperfusion. We know well-established and reproducible surgical technique to modify this imbalance, optimize the graft inflow. And we have also some pharmacological treatments. So one of the easier techniques is what we presented almost a quarter of a century ago, some times ago. You can see the splenic artery ligation, which was capable in most of the cases, improve the hepatic artery buffer ratio. You see here the decrease of portal vein flow, the increase of the hepatic artery flow. Then we were also proposing hemiportocaval shunt in very small graft, and this was capable to give a much more important reduction of the portal vein flow and improve the postoperative regeneration. This is the Ghent way to make this full hemodynamic assessment. It looks a little bit complicated, but finally is not so. So you can have here portal vein flow, hepatic artery flow, the gradients of the portocaval shunt, and even the pressure with this small probe, everything managed by one machine. We can also face, we have to face sometimes the problem of spontaneous port systemic shunt. And here is very important to have a real full hemodynamic pictures of the pressure and flows. So if we need to reduce portal vein flow or portal vein pressure, probably we should leave some of the shunt open or if we have hypoperfusion, we have to consider the closure of the shunt. So it's very important to know also before the situation, the splanchnic situation of these patients. And that's why we believe that tracking pressure and flow first will be important before deciding any kind of graft inframodulation. This is a recent, more or less recent to act to consider the graft to splenic volume ratio. This is a concept from one Japanese group, I guess, Fukuoka. So when a small graft is transplanted in a patient with very large spleen, they consider mandatory by default the splenectomy to decrease the risk of graft dysfunction. But I will focus, I think Jaimon will give more insights over the surgical therapies. I will give just a few slides on the drug and pharmacological therapy. This is a list of molecules which have been used, especially in animals models. All pre-known pentoxifylline are the two FDA drug, FDA approved, but not really checked in the transplant. They are capable to decrease ischemia, perfusion injury, and improve regeneration. The most important molecule are somatostatin and octreotide. This is, I guess, one of my last studies in Ghent, the trial about somatostatin. So somatostatin showed the very efficient mechanism to decrease the portal vein flow. Having also a safety. We can see the delta portal vein flow, the delta hepatic artery flow, and the delta of hepatic vein pressure gradient. So it's very efficient, it's safe. We don't know yet its role in decreasing ischemia perfusion injury. That's why we conceived the novel trial, which is just done, and we are waiting on this proteomic and metabolomic analysis. So beside the flow, it could be that this molecule can be of beneficial effect to the graft, because the liver has 5 receptors for somatostatin and only 3 for octreotide. And this is also the latest submitted data on the use of octreotide for transplant of left graft and even liver transplantation. Of course, this is the Riyadh Brewing series. You can see the picture 1A, the progressive use of octreotide. You see here the intentional use for graft below 0.8 of octreotide. This is a summary of complication according to CCI, which were not significant between graft below 0.8 or above 0.8. And you see here also the classification according to the new way, level ABC or grade ABC of the small fat size syndrome. No differences between the grafts. You see here again the efficiency of the octreotide in modulating the portal flow and hepatic artery flow. And you see also that the 5-year graft survival for left livers is absolutely sound. This is when we have a small fat size syndrome. We have to fully explore, rule out some techniques, problems. We have a problem with management of the patients. We have to optimize immunosuppression because the risk of sepsis is much higher. This is what we can do when we know we transplant a small graft into a patient with portal hypertension. We can eventually have additional therapies. I think the most difficult decision will be when retransplant the patient because of no progression, no improvement of the syndrome. So I go to the conclusions. This syndrome is rare and partial transplant, but may end in a complicated outcome. Portal hyperfusion plays a major role. However, many other factors are involved. Prevention is possible by avoiding unfavorable conditions whenever possible. We have different techniques available to mitigate it, but a full intraoperative hemodynamic assessment is recommended also by IFTS guidelines, actually. And the use of drugs can help in preventing it or mitigating it by further reducing the graft body weight ratio barrier in case of lack of better alternative. So if you can swap the donor, probably will be better, but this is not always a good situation. I want to thank again Pietro for his continuous supporting for our split groups. This is the last meeting in Ghent in 2018, where he was, I think, the principal teacher. And you can have here some fantastic picture from his anatomical lesson. Thank you, Pietro. Thank you, everybody.
Okay, we'll call on Lawrence, be the discussant.
Thank you for giving me the privilege to comment. It's a remarkable overview of this very, very complex syndrome, as you said in your introduction, and it is mainly in reduced graft. My first question is that exist in total graft transplantation? This is the first question. The second, that do you recommend always to measure operatively the portal pressure, because well during the transplantation there is a lot of hemodynamic changes because of the anesthesiologies, amine, etc. So is it really always reliable? And the last question is it really a small for size or a small for flow?
Okay, first question is if this syndrome occurs in larger graft. I think in true or full-size graft, unless you put a pediatric liver into big adult, is not really a small for size syndrome. You have some kind of early graft dysfunction with cholestasis, but probably this will not end unless some other factors as sepsis, to the patient death. So the risks are truly those related to implantation of graft in patients, sick patients, high MELDs, and portal hypertension. The second question, the reliability of measurements. Of course, you need stability, hemodynamic stability, because if this is not the case, your values will be altered. But again, the instability of the patient will not avoid, if is the case, portal to arterial ratio imbalance. So this difference will still remain. Portal vein pressure, we measure this, but always with portal vein flow and hepatic artery flow. And then we have we make a summary of all the measure, and in order, the more parameters you have, the best will be your final decision if you go ahead with some maneuvers or not. Your last question, sorry, I forgot.
About the name, is it small for size, always small for flow? Because the portal hypertension, as you showed, it depends on the portal hypertension. The same graft with a patient with low portal hypertension will not be exactly the same than with high. So do you, for example, recommend a splenectomy like it has been recommended with the large
yeah, I remember a few cases of splenectomy in full-size liver transplant. We published it in '99. because of intractable ascites. So the graft was functioning more or less, but the patient had ascites. With splenectomy, we fixed the immediate problem of ascites. Maybe this could be also done by splenic artery embolization, but this was at the time the experience. Small for flows, small for sites, I think it's rather a semantic question. I mean, the liver is small, so we'll have a less sinusoidal bed, will comply less flow, but there is some, some adaptation tolerance. So the quality of living donor graft is that they can adapt also respect to older livers, which reduce it capability to accommodate hyperflow. It's for sure more flow, and what is the risk or the risky situation, to my opinion, is the imbalance between portal and arterial, because relatively low arterial flow, even though if you don't have hepatic artery thrombosis, you will have some ischemic patterns for bile ducts, and so this per se will also give hyperbilirubinemia, so some kind of dysfunction, maybe with ascites also.
Thank you very much. Thank you.
Okay.
You go.
So that's a very nice presentation. Just one technical question. I see that sometimes one of your technical options to decrease the pressure is to use the portocaval shunts. So how do you manage this? When do you close it? Do you actually close it or not?
This is a very nice publication. I hide the slides because of time, because the person will say that 5 minutes. Okay. Intentional making a small portocaval shunt is RV saw in Delhi. So for very small graft below 0.7, most of the cases have a hemiportocaval shunt. 18% of these shunt are spontaneously closed after 3 to 6 months. Very few are still functioning after 5 years. This is a recent publication, but of course there is a spontaneous closure of some of them. And this experience was also characterized by 2 patients with sepsis, so they closed intentionally the shunt because of sepsis and graft dysfunction, but they lost the patient, unfortunately.
And do you use a synthetic graft or just?
He was using some Gore-Tex. We never use this, only so one of the portal branch, left or right, which is very nice.
Thank you very much, Roberto. One thing, you use belts and braces, splenic artery ligation and somatostatin, and the result is additional if you use both. It's not one or the other. You can use both ways to decrease the portal pressure. Second question, the hemodynamics can change when you close the abdomen. Because I didn't use flow meters, but I used Doppler ultrasound speed and the arterial wave, which changes when you do these measures. And in fact, the portal flow increases when you close the abdomen. What is your experience of that?
If you do just a splenic artery ligation, the network will be interrupted just for a couple of days because there will be immediately a network circulation. We saw this with angiography done for other reasons, which makes sense. Mother Nature is fantastic. But you have to consider the fact that the most important damages are occurring immediately after reperfusion. And this has been demonstrated years ago. I think the first study was coming from the Hong Kong group in Mises, showing that the transplantation of very small grafts after reperfusion without protective techniques displayed.
Yeah, the damage is early.
The fact that there are changes after abdomen closure, this is true, but anyhow, you will end the transplantation with the best situation you can hope that will remain. So if there is a problem during a transplant, also bismuth docet, you have to fix immediately.
Yeah.
So I think this is the way to do.
And last is a comment. I think that Laurent's proposal of small for flow is a good wording because it puts the accent on the hemodynamic of these patients, which is different. The large spleen or the small spleen in a patient of the same weight does not mean the same thing on the small graft. Le parole sono importanti.
Roberto. Thanks for your presentation. I have a question in after hepatectomy. My question is the damage reversible or not? What I mean is the damage coming from portal hyperflow and impairment in portal arterial buffer is reversible, because sometimes after an hepatectomy, you realize this kind of damage, not immediately after resection, but maybe after a week, when the patient comes jaundice and you have a quick increasing in bilirubin and ascites. So that time, is that possible to do something, or the damage is done and irreversible?
So the setting of extended hepatectomies, you mean, it's a big difference from the transplant, because in the transplant you have all other factors. You have a cold ischemia, warm ischemia, so ischemia reperfusion injury. And so these are true parenchyma at risk. I think a French study showed that the major hepatectomies had some postoperative dysfunction because of probably hemodynamic alteration. But in that case, although I think there were some mortality depicted, it's a study of Allard. I don't remember the center, maybe Lyon, I'm not sure. The setting remains different from the transplant. So possibility to improve after period of some kind of postoperative dysfunction, a liver failure, A or B, will for sure will remain, but the recuperation is much better. So this is reversible most of the cases.
Questions from the floor? So, Roberto, can I ask you, if you anticipate a small for flow, let's say, graft, even before you do implant, would you consider doing an outflow modulation, like putting a big skirt on left hepatic vein to get the maximum outflow? Is that something useful?
You consider left levers, I think you don't need to have
skirt,
cuff. No,
yeah, cuff.
You need to have a large opening on the cava, and the positioning is very important. If you are implanting right lobes, you need to have the anteromedial sector drained. Otherwise, you will reduce the graft. Anticipation, I think today, even because of very nice results from this Japanese group, there is a publication which will be soon online. If you have an alternative, so you know that you will put a small four-sides graft into a sick patient with a large spleen, I will have no doubts that probably this patient needs splenectomy, combined splenectomy during the transplantation.
If there are no questions, thank you very much.
Thank you so much.
So we're on the same topic, and pleasure in welcoming Jean Yamon, who's going to speak on flow modulation for small size.
Thank you once again for the privilege of speaking. I'm glad to follow Roberto because he really has, through a long 25 years of work, has really set the scientific foundation for the work we do. My talk is going to be a little more practical, perhaps, with a little less data, but I think the messages will be emerging pretty clearly. I just wanted to start with a personal story because when I left Paul Brousse in '85, I was probably the first main metastasis of this kind of thinking to this pioneer country. And you see, this is the old colonial maps drawn by Europeans of the American continent. And there was no need to understand, at least for the Europeans, the anatomy of the United States, because there wasn't any complex surgery taking place. This so this picture is typical of pictures that were already existing at Paul Brousse in '85. But anyway, so I brought this metastasis to the US. And when I got to Chicago, this is probably the Bible. So if the people are trying to teach the religion of hepatobiliary surgery, you need a Bible. And so this book was in the library at the University of Chicago in 1986. So I went to take it out, and it had never been taken out of the library for 20 years. Yeah, and fortunately, I was able to obtain it on permanent loan, so I still have it. So, but anyway. So my experience with a small for size started, well, in '90, because we mostly did babies and we had great results with babies. And then all of a sudden we started doing some bigger patients. This guy, who I had to retransplant him a few months ago, he's 43 now, but so they had the first small for size. I didn't know exactly what was going on, but like Roberto pointed out, and I guess the Paul Brousse with the small grafts, this is what was happening, and it led to trying to understand this paradox about the early ischemia, because it's starvation in the face of plenty. You get too much flow, it congests the sinusoids, disrupts the sinusoids. But there is, in fact, a healing process, but it's very slow. Maybe it takes 45 days, even 60 days. So both of these livers, this was a fatty liver to start with, fatty and too small. So that wasn't great. Later, it looks like this, but eventually it heals, and it's possible for these organs to heal completely. This is the paper we wrote in 98, that it was very small sample size, but we showed a significant relationship between graft size and function. And that was sort of the base. And in our introduction, we used the term small for size, I think for the first time, but we didn't fully understand it, and we were blocked because I couldn't imagine doing a right hepatectomy in a live donor at that time, whereas others saw that was the only solution. So here we are 35 years later, and this is kind of now not every day, but almost every day. We have this meeting now every week because we have so many cases. And surgical planning, which I think I learned best from Daniel Cherky when he came to work with us for a few years. There's a lot to it. This is a multifactorial equation, and we do the best we can to crystallize it into some operative strategy. So the donor age, very important. Young donors can do more. The anatomic complexity of the graft and the recipient, of course, but the graft, sometimes we have a nice big right lobe, but it's so, 3, 4 hepatic veins and so forth. Recipient factors, we'll talk about those. You already heard a little bit about this. The flow of a given recipient will vary a lot based on the portal hypertension and so forth. The baseline functional deficits of the recipient are critical. The high MELD recipient needs more graft function. And then, of course, the easiest thing to measure are the graft and remnant volumes, so forth. Now, the one reason why the relationship between graft size and function is more reproducible in living donor is because the living donor grafts are consistently healthy without other sources of injury that the deceased donor brings to the table. So that may be why we use the term for size, because the other variables are not present. But there are many recipient variables that, as you saw. So this is a surgical planning document which this is a patient that I think Tom Cato transplanted the recipient. So 59 kilo recipient, a bigger donor, so that's good, and a young donor. So but then we have detailed measurements of the graft, and we planned a left hepatectomy. But you see, so it's 38% of the volume. So the recipient is left with a 62% remnant. So that's not a problem at all for the donor, the donor remnant. Now, the estimated graft weight here varies quite a bit. And we'll talk about this because the estimates of graft volume are probably the biggest risk for having a graft that's too small if we make mistakes. So Fuji is our three-dimensional software. The MRI reported 561 grams for the graft. Very conservative. We removed 20% for liquid volume. The actual number is probably more like 11 or 12%, but we give ourselves a safety margin, and we'll talk about that a little later. So our estimated graft recipient weight ratio is 0.76 at the minimum and 0.96 at the maximum. Our anatomy is very simple because it's a left lobe graft, single portal, single artery. In the left lobes, we frequently have two arteries. I have to usually do them both. A big hepatic vein confluence and a single bile duct. So now the other number that was alluded to is graft to spleen volume ratio. We take that into consideration so we can expect a portal flow and so forth. So all this is part of the surgical planning going in. Of course, you're all familiar with the anatomic planning, the portal vein, the artery is fine, and the hepatic veins. This is kind of a long, skinny graft. It's not super ideal, except that the confluence is a single nice hepatic vein for the whole left lobe. So going back, based on Roberto's work in the Etoile study, which is old now, but we did a multi-center trial in the US to investigate the impact of portal modulation. So we studied 274 live donor transplants, in which case it's mostly right lobes. A couple of the teams, ourselves and UCSF, were doing left lobes, and 58 or 52 of the subjects had smaller grafts and ended up getting modulations. Now, this is one of the problems of this field. The measurements, we were not using the newer equipment is Medistim, which is very wonderful machines that reliably provide great flow measurements. The older systems had a lot more errors, but if we had, so 25 modulations here from several teams, not everybody believed in the measurements. And so there's a lot of behavioral variations here, but nonetheless, the arterial flow actually went down in some of those cases, which would not be predicted by the arterial pressure principle. The portal flows decreased in the majority of patients, and this has certainly been our consistent experience, primarily with splenic artery ligations, and the portal pressure goes down almost all the time. So portal pressure is pretty consistent in that experience. The impact of modulations permitted us to have an above 90% long-term graft survival in actually the modulated group, which is interesting because these were all mostly right lobes. The modulated small grafts actually did better in that cohort, but that was whatever it was. So our intraoperative management, we are very much believing that the modulation should be data-driven. And the literature is very confusing because a lot of teams do preemptive splenectomy or preemptive this or preemptive that. They don't even measure anything. So we don't know what the baseline state was. Preemptive shunt. Now, the reason people do preemptive interventions is because they're afraid that even 30 minutes of hyperflow will destroy the graft. I don't buy that. I think we should do data. I would advocate for data-driven modulation. We primarily do the flows, but the pressures are also very important. This is a wonderful anecdote, but a great example of a consistent buffer reaction. So this is the baseline, small-ish graft. The portal flow is 1010, a liter with a resistive index of 0.4, which is no problem. By the way, the living donor fresh liver graft has a very high compliance. So it can tolerate triple the normal portal flow before it starts struggling. And then it's a critical cutoff. So you do have to intervene. But you see, the best sign that the graft is suffering is the artery is not happy. And so here we have a high preservation index. Ideally, it should be under 2 or even 1. And the flow was 92. So we ligate the splenic artery. Portal flow goes down by 30 to a very nice number now. This graft was about 500. So this is normal portal flow, 1 cc per gram per minute. And then look what happens to the artery. Arterial flow triples, well, 2.5 times. The perfusion index improves. So the pulsatility index improves, and we have a very excellent functional result. John Roberts at UCSF did a meta-analysis, and this creates a big mess. Meta-analyses are very complicated because you're looking at a bunch of teams that do everything differently. But nonetheless, they felt that their results suggested that portal pressure was a more reliable measurement. We've actually stopped measuring portal pressure, which is probably a mistake, but we're so convinced about the flows. But the literature is very confusing because it's such a multifactorial problem. Now, this paper, which we were part of with Mohammed Rela and Reddy, it's an international cohort of ultra small grafts. Now, small graft used to be less than 0.8, but now I think there's consensus that 0.6 is the safe limit under a variety of qualifications. So all these grafts were less than 0.6. In fact, the graft recipient weight ratio is 0.51. Interestingly, though, the predicted graft to weight recipient ratio in this study was higher than 0.6. So in the real world practice, nearly all the ultra small grafts are mistakes of measurement or execution. The other thing, so we have evidence of hyperperfusion from portal pressure, portal flow. The final portal pressure is on the high side. The final portal flow, this is what we call borderline. So assume that 100 cc's per 100 milligrams of liver, 100 grams of liver is normal, so 1 cc per gram per minute. 2.5 is probably the cutoff zone where you should worry. But for me, as long as the artery is happy, I'm less worried about the portal flow. This is my thought, but I don't know. Now, so anyway, half of these graphs had evidence of hyperperfusion, and portal flow modulation was done in half. Splenic artery ligation, which is the best and easiest, splenectomies, and partial shunts. So the only other thing to say, this is a series now, 92 small graph. The 90-day mortality, the 1-year graph survival 76, 90-day mortality is 10%. And these are the other complications of patient survival. So this is really below the limit, but this is only like 5% of the total transplants in the cohort, because the reality is around the world, everybody is playing it safe with graft size. Certainly in the US, I showed you this slide in my last talk, 90% of the adults are done with right lobes. People are playing it safe. Our experience in the past year now with nearly 50 transplants, we are using 1/3 of left lobes, but in all these cases are robotic. I think the final summary is this meeting that Roberto alluded to. It was the ILTS consensus conference on small for size in Chennai in 24. And there were 4 nice papers came out of this. And this is one of the schemas from the preventing, but you see the complexity of this equation in real biology with not unlimited numbers, donor selection, recipient selection, portal inflow modulation, and then all the attributes of each of those bubbles. So this is why the literature is not so clear, and we have to make our way with imperfect data. So I would say in conclusion, ultra small grafts were all the result of underestimated graft weight, recipient weight ratios. I think the limit of 6 is safe. I had hoped when I was younger that we could go way below 6, and probably someone in the audience will do that. But I think right now this is where we are. I would please make your modulations data driven. In our experience of the last 100 recipients, we've done 2 splenectomies, 25 splenic artery ligations, and 1 shunt. So I don't think the more extreme modulations are often needed. The actual small for size early allograft dysfunction is less than 10% and rarely contributes graft loss in this context. Thank you.
Okay, so Laurent Coubeau will do the discussion.
Then thank you, Professor Raymond. Thank you, Roberto, for this brilliant presentation. Difficult to discuss that level of expertise. And I think the discussion between small for flow and small for size is not just a semantic discussion. Because if you speak about small for flow, it means that just flow can induce small for size syndrome without liver function amputation. And the answer for this question maybe is coming from HALPS and from RAPID. Because in HALPS and RAPID, you have a complete flow, splenic flow directed to a very small graft. And we saw that even if we use a very, very small graft, meaning that 0.2 graft recipient weight ratio, actually liver flow should go to a plateau. And even if in some situation we had a situation with a flow less below of 250 of related portal flow, we had to modulate the inflow because of the artery. And do you think that finally the objective is maybe in this situation just the artery and not just a cutoff of flow or pressure?
Yeah, I do agree that the artery is the most important result, whatever you do. And we have had a number of cases that had portal flow above 2.5, you know, with excellent arterial flow. We don't intervene in those cases. But you talked about size. There's another way to think about size. If you had a machine like a liver assist machine, and you didn't have any issues of hemodynamics, just liver machine, and then you were deciding how many hepatocytes to put in the machine. If we had that situation, then maybe we could know what is the minimum number of hepatocytes that the patient needs. But the flow and the size are inextricably mixed, in my opinion. So whether you call it semantics or not, it's, in fact, you even used the word size in your, you said if the flow is too high, you'll have small for size syndrome. So the expression is very seductive.
Okay. Yes, because last question, when you see the case of the first day of this Congress from Peru, a complete ligation of the right portal vein with all the fluid directed to a very small segment 1. And actually, even in this case, there was no modulation, there is no measurement, and there is no hyperflow that induce small foci syndrome. That I'm not convinced that just the flow can induce, just the shearing of the endothelial cells can induce a small foci syndrome. I think it's just because you do not have enough liver volume.
That might be, but that segment 1 was very small. That segment, and we have no measurements to know the hemodynamics.
Yeah.
But the other thing is, the non-cirrhotic patient does not have excess portal flow. So that's another variable.
Yes. Wow. Thank you. You have Pietro and then Professor Bismuth and then Hugo. In fact, it's Ben who was asked me to ask, why don't you do a distal splenorenal shunt in these cases?
Yeah, no, that's a good suggestion. Olivier Boileau actually published this many years ago using mesocable shunts to mitigate small for size. Making shunts is not automatic. Remember the most portocave calibré. If you're making a portocable shunt, you have to be really careful not to have a steel syndrome and measure both sides so you get it just right.
That's probably why he wants a distal.
No, this is good.
It's not automatic at all, I think, in these patients.
Yeah,
we did one publish a new course on the patient.
and it was good, right?
Thank you, Surendra.
Thank you. The first small foci that I did, the recipient was 80 kilo and the donor 15. You remember what I did? I did heterotopic liver transplant.
Oh, that was the hepatitis B recipient.
Exactly.
Yeah.
And the patient survived.
He got cancer.
1 minute. You know, if the patient survived, but at that time, the heterotopic liver transplantation was performed by putting the liver, the small liver, on the left hypochondria. The spleen was removed and the liver not working at all. And I put the small liver below the liver of the patient. On the right side, it was important for the liver was near the vena cava and not far. It was. you know, the patient survived. He died 10 years after, for he left his own liver with hepatitis B. The own liver disappeared for the small graft. Mitochondrium, and the own liver disappeared, except 10 years after, there was a tumor. I thought it was a tumor of the liver, almost all the hypochondrium. Indeed, it was a hepatocellular carcinoma arising in the remnant liver. Hepatitis B.
Well, that was a fantastic case.
I think it works.
Yeah, no, it works. So
it could be, I don't know, I never we do this.
But we are frequently offered, not frequent, we are sometimes offered pediatric livers for adult recipients. And I think as long as you're use the graft weight, recipient weight.
What do you do?
Huh?
When it is very small.
Well, long as you're 0.3, you're okay with those livers.
Below?
No, yeah, one graft weight, body weight. So, you know, 30 kilogram kid, 100 kilogram recipient, that should be okay. Because the livers are very good, they regenerate beautifully. So you have more, actually better results than with living donors.
We have one more. Hugo, do you want to ask? Yeah.
Oh, very nice, Sean, as always. My question was about this ratio, the graft to recipient weight ratio. You were saying that 0.6 is safe. Is this for adults? Because, for example, I know that Arvin, for example, I think avoids using less than 0.8.
Yeah. So 0.8 was, I think, well established by the Japanese results and others many years ago. Toronto wrote a very nice paper showing you could go down to 0.6. That was maybe 8 or 9 years ago. And I think most people are comfortable with going down to 0.6. But again, we cheat a little bit. Younger donor, less portal hypertension in the recipient, lower MELD. You know, the patient selection is complex and multivariable.
We have a quick question from Daniel.
A few years ago, we published with Roberto, still here, a series of left-sided grafts in adults, and we found 3 factors that were associated with 100% working success. Number 1, graft to recipient body weight above 0.6, as you said. Number 2, donor age less than 45. Number 3, recipient MELD less than 14. So both basically hepatocellular carcinoma. So I think these 3 things are very important in terms of selection. It's not only the graft size; it's also the donor age and the recipient status.
Yeah. See, if you have those favorable conditions, and
Go ahead, small graft.
no, but if you're looking at 2 potential lobes on the donor, and the right lobe has 3, 4 hepatic veins and so forth, you would prefer to go to the left under those conditions.
But you pick a lead to the left, right?
Yeah. We're in the minority now. Yeah.
Thank you very much, Mario. Okay, we'll switch here a little bit. I'll call upon Ibrahim Astiasioglu, and he's going to speak to us on pediatric liver transplantation. Ibrahim, please.
Dear Chairman and dear companion, I will present our result of pediatric liver transplantation in which performed in Memorial Bachelor. Liver transplantation is a life-saving treatment for pediatric patients with acute and end-stage chronic liver failure, and we aim at present the prognostic factors affecting the survival of pediatric liver transplant performed in our center between August 16 and 24. Some findings. Between September 11 and 24, we performed almost 1,900 liver transplantation, and 94% of these transplantation are from living donor. And in the past 2 years, this ratio is increasing up to 98%. So 319 pediatric liver transplantation with 15 retransplantation were reviewed, and our ratio to pediatric liver transplant to adult liver transplantation is 21%, and national ratio is 10 or 11%. So we perform the double pediatric transplant concerning the national ratio. 9 patients were from cadaveric grafts with 4 split and 3 domino LDLT, 1 full and 2 split. 4 cases transplanted by paired exchange LDLT. Average age was 60 months and weight 90.4 kilogram. PET score were 27. Demographic characteristics of previous operations, biliovascular complications, morbidity, mortality, and survival rates were evaluated, and we divided in 2 groups the patients. The first group between 16 January to 22 February with 191 patients with 15 retransplantation, and the second group between 20 March to 24 August, 113 patients with 4 retransplantation. 3 of those 4 retransplantation, first transplantation were performed in another center. And the extension of the pediatric liver transplantation during the years from the 16 to 23, the number is increased from 30 to 52, and this year performed 48 liver transplantation. 34 was until August. And some knowledge about patients. Age, mean age 60 months, and mean weight is 19.4. The smallest recipient were 4.5 kilogram, and PET score were 27. And general diagnosis of all the group, you see the diagrams. The first, the 4 first indication were biliary atresia, 69, PFIC 53, acute liver failure 26, and glycogen storage 22. And in the first group, the first 3 indications were biliary atresia, PFIC, and acute liver failure. And in the second group, the glycogen storage disease were the second most indication of this group, with biliary atresia always the first indication. And concerning the metabolic indication in the 2 groups, there were much Wilson disease in the first group, but in the second group, the glycogen storage, the number of this glycogen storage patients were increased. Some intraoperative findings. The smallest graft that we obtained were 85 grams, and the mean graft weight were 324 grams, and the graft to recipient weight ratio were 2.24 mean. We have no large for size graft, and operating time 500 minutes, blood loss 255 milliliter, hospital stay 36 days, and ICU stay 7 days. And the postoperative mortality, morbidity, the most morbidity were biliary complication with biliary fistula and stricture with a rate of 11.2% with fistula and stricture. The second were small bowel perforation, spontaneous small bowel perforation. We see as not frequently, but we see in the pediatric patients, and vein thrombosis, mainly in the first group, were mortality and etiology correlation were seen here. The mortality of the first group were we had 37 mortality in this group, 19%, and the most of this were in the biliary atresia cases, and the second in the PFIC patients. Metabolic disease, 5 mortality. In the second group, the mortality has decreased until to 8 and 7%. In the biliary atresia group, we had only 2 mortalities, and one in other etiology. Here we see overall pediatric patient survival. So with a year survival overall, the two groups between together, 3-year survival for 84%, and the same in the 5-year survival. Graft survival were 80%, and in overall group, the graft survival were 80%. So in the first group, the 3 to 5 years patient survival were 81%, and graft survival were 76% and 75% in 5 years. But in the second group, you see the patient survival for 1 to 3 years were 91.3%, and graft survival, we had just one retransplantation in this group, and in the graft survival were 90%. There is a statistical difference between the two groups. For graft survival, you see the significance is strong, and for patients also, the significance is strong. And the comparison between two groups, in group 2, between the patient less than 10 kilo versus more than 10 kilo, there is no statistical difference concerning survival. The P is over 0.7. And in the first group, the mortality comparison between biliary atresia and versus metabolic disease in the first group were worse in the area atresia group, and the significance were just limit 0.05. But in the second group, this difference disappear. In the first group, the group with the hepatic arterial thrombosis versus no hepatic arterial thrombosis, there is a significant difference concerning survival between two groups. No hepatic artery thrombosis are better. And in the first group, perforation versus no perforation, between the two groups, there is a significant difference concerning survival. In the perforation, the survival is bad in the perforation group. And the retransplantation in the group in the first group, we had 15 retransplantation with a 3-year survival, approximately 60%, and in the second, just one mortality, but the number of retransplantation were reduced to 4, and we in this group we lost 1 retransplantation. And as conclusion, we can say with our pediatric transplant rate reaching 25% in the last 30 months, our center has become a reference for pediatric transplantation. In group 2, only 1 person portal vein thrombosis. The same case, we had a portal vein thrombosis and hepatic arterial thrombosis. We had a spontaneous perforation in the same patient, and this patient were retransplanted and survived after retransplantation. In group 2, there were no statistical significance between metabolic disease and biliary atresia survival. So we reduced the mortality in the biliary atresia group in the second group. And in the second group, the mortality rate decreased from 19% to 7%, related to the first group. In the first group, the mortality were 19%, and in the second, it decreased up to 7%. And we believe that these developments are related to improvements in surgical technique. Mainly, the portal anastomosis configuration shortened the length of the recipient and graft remains so that they would meet at a direct angle during the anastomosis. And it's important, pediatric intensive care performance. We charged a pediatrics intensive care unit, intensive care pediatrics in the last 3 years. Okay. For reduced left lateral section, so to reduce to less than 4%, the graft to recipient weight ratio. The plane of the reduction is here, plane A, horizontally, and plane B, vertically. So we can reduce as we want, and the weight, the left lateral section. It's okay.
Professor Ivan, congratulations on this very nice series. A lot of cases from more than 50 liver pediatric transplants per year. Only 2 considerations. One regarding the indication.
indication?
The indication. FIC, I was um, not expecting that FIC were the second leading cause to liver transplantation at this stage. In our series, we have, of course, the biliary atresia as the main cause, and then the metabolic ones on the second cause. Here, the FIC has, I think, 30% of indication of liver transplant. And the second question was, what did you found in your series that could explain a reduction in the mortality? As we know, the patients in the liver, in the pediatric population, after the first year, 97% of the transplanted patients are alive at 5 years. So mainly importance for the survival is what happens in the first year regarding the complications. And between those two periods, 2022 and 2024, what was the main difference to explain the difference between mortality of 19% and 7%? I think the group made an analysis and corrected something to have that huge difference, and congratulations.
I think that in the this one. In the first group, we had many portal vein thrombosis, and before we shortened the length of the portal vein of the recipient, but we continue to get portal vein thrombosis even after this precaution. And we began to reduce the length of the graft portal vein, left portal vein. So even with the little tense, we performed the portal anastomosis between recipient and graft portal vein, and we dropped dramatically the rate of the portal vein thrombosis. We had no problem with hepatic arterial thrombosis, but I think that, and which is important, pediatric specialists of intensive care were the principal reducing factor of the mortality, and we hadn't selected patient, more easy patient to reduce the mortality. Donc, the flow of the patient were similar into two groups. Okay.
Thank you. Regarding the venous anastomosis, because sometimes the problems you get in the inflow comes from the outflow. In these two periods, didn't change the technique of the implant of the hepatic vein.
Hepatic vein. The hepatic vein, we applied a classical triangulation system technique from Bernard Ott. There is many years. And with the triangulation technique, we had no outflow syndrome.
Thank you for the outstanding. Thank you.
Have any questions, or Ibrahim, maybe I can ask you something. That the vast majority is living live donors.
Living?
Yes, it's not for the pediatric, it's LDLT, basically. Yeah. So you had acute liver failure patients also. And are you able to turn around donor workup very quickly in order to be able to get a live donor in acute liver failure?
Live donor we can find yet. There's no.
And you can work them up quickly enough.
We can
to do the testing.
The testing.
Yes, and the workup for the live donor.
For the live donor.
Yeah.
Can prepare a live donor in 1 day. We performed
almost 200 liver transplantation per year, and only 2 or 3 of these were cadaveric donors. So the preparation of a donor, maximum 2 days.
And your hepatoblastoma pathway, the hepatoblastoma pathway, you did some hepatoblastomas. Not much. You give chemotherapy. Do you have a donor on standby as you try to resect, or a priori you just go for transplant?
In this series, there is no one or two cases of hepatoblastoma. So after the pediatric oncologists decide of this,
right?
The neoadjuvant chemotherapy, and after the follow of this patient with alpha fetoprotein, you know.
Yeah. And when they're ready, you will have the live donor. You go straight.
Yeah.
Okay, thanks. We're right on time. If there are no other questions, thank you, Ibrahim. Okay, so we have Jose Oberhofer. Jose Oberholzer, I'm sorry. And yes, robotic. Yes, SBK. Yeah, thank you very much.
Good. Monsieur le professeur Bismuth, Pietro, merci beaucoup pour l'invitation. I had the privilege to work for 6 years at the University of Geneva, Manta and Pietro Maino and Christian Poso, and even lived for several months in the home of Pietro when I was an orphan. And that really have very, very good memories from that time. Now, Pietro gave me a huge challenge to give a talk about a very esoteric topic for this illustrious society. I don't know, is anybody in the room actually doing pancreas transplant? Yes, thank you very much. So for the others, oh yes, sorry, yes. So for the others, just enjoy. None of those organs makes any bile, like Pietro had to realize when he came to a kidney transplant, where he said, well, it's a beautiful operation, but I'm a little bit disappointed that there is no bile. Yeah. And so maybe this computer is not set up for presentation. So So for those who are not that familiar with pancreas transplantation, there are many ways of skinning a cat, and there are many ways of doing a pancreas transplant, which means there is no perfect one to do this. So essentially, we distinguish between doing an enteric drainage or a bladder drainage, and then we distinguish between systemic drainage into the systemic circulation or into the mesenteric circulation. And the bottom line is all of them are good. All of them have some problems. And the current indications for pancreas transplantation are mostly patients with end-stage renal disease. So those patients who also will need a kidney transplant at the same time. Nonetheless, there are still some indications for patients who, for whatever reason, only received a kidney transplant despite the presence of juvenile diabetes or so-called burned out type 2 diabetes. So those type 2 diabetic patients who do not make any more their own insulin. And then we have very, very rare occasions, almost never happens anymore nowadays with modern insulin therapy, are the patients who will receive a pancreas transplant alone for unstable type 1 diabetes. And then the last indication that also is very rare, patients who had a total pancreatectomy, who otherwise are really well, and just don't want to deal with all the hassles of unstable diabetes and exocrine insufficiency. So now this is a complicated process. We all know how humbling pancreatitis can be when we do a Whipple or even a distal pancreatectomy. We can render a previously healthy patient a very sick patient. Now imagine doing all this with steroids and immunosuppression, and you can imagine this faster. So it's a major surgery. The pancreas is a very angry organ, and we can have enterocolitis, we can have a graft thrombosis, and of course, the most feared complication is patients who develop a mycotic aneurysm under arterial anastomosis. Of course, this is all not so great. I mean, just imagine we are doing a anastomosis, and at some point there is like small bowel juice flowing over the entire thing when we are not careful when we do the duodenal anastomosis. And then the other question is, are we not coming too late? Now, for as trivial as this question is, for many, many years, it was actually not clear whether it confers an overall survival benefit. And this is a very old paper. I apologize for the quality of the scan. I only had a paper version of this thing. And this was a kind of a natural experiment. For those who have done work in public health know that a real world experiment can see when two different regions handle the same patient population differently. And so I think we have somebody from the Netherlands or a couple of people from the Netherlands here. And in the Leiden area, essentially patients who had type 1 diabetes and end-stage renal disease would routinely get a kidney pancreas transplant, and the patients outside of the Leiden area would not get that. And then they had the idea just to follow those patients and compare, and it was very quickly apparent that the patients in the Leiden area had a far superior long-term survival, indicating, not proving, but indicating that possibly a pancreas transplant could confer an overall survival benefit in those patients. Now and then came along an endocrinologist. So this is an NIH investigator, Harlan, who had the idea just to look at the registry in the US. He was an endocrinologist, and he felt this pancreas transplant, that's really stupid, it cannot be any good. And he looked at all the registry data. So looked at the wait-listed patients and then looked at those after transplantation. And essentially, there was maybe a slight survival advantage for the patients who had a simultaneous pancreas kidney transplant, because those patients, they were actually dying on the wait list. And so the transplant surgeons were scratching their head and said, well, that doesn't really correspond to what we experienced. And then asked to review the data, which, I mean, it was published in JAMA. That's not like some Wild West journal. It's a pretty good journal. And then they realized that the investigators, because they were not transplant surgeons, didn't understand that patients are listed in multiple OPO areas. And when they get transplanted, they don't necessarily call the OPO and say, hey, I don't need any more an organ, and they remain on the wait list. The system was not set up at the time to remove them from the wait list. So there were many, many patients, especially here, who had already received a transplant and increased the wait list survival. And so they did, again, an analysis and reviewed all this and published this a few later. And it became apparent that probably in most categories, pancreas transplantation confers an overall benefit. So the take-home message about, well, is a pancreas still meaningful today? Clear indication for SPK, so when we do it in patients with end-stage renal disease who also need a kidney transplant. And then I would humbly leave it a little bit more open for the pancreas alone and pancreas of the kidney, but probably choose those patients wisely. And we have really good surgical results, then probably they will also benefit them. So where comes robotics into all this? Well, it's a little bit by coincidence that I ended up in 2003 at the University of Illinois. I went there for a completely different reason. They wanted me to build up an islet cell transplant program. And well, it turned out they had a robot there, and they had a few surgeons who were really good at it. And I had this huge opportunity to learn all this from, really the funders of all of those approaches. And then so in that hospital, routinely donor nephrectomies and hepatectomies, the first worldwide donor hepatectomy was done. We did total pancreatectomies and all the rest. We happened to do also their first robotic kidney transplant in the world. And then later on, not the first robotic pancreas transplant, but one of the first. And so what was the rationale? Why would we do this? Why would we do keyhole surgery in transplantation? And so the problem we were addressing, and I understand that's mainly a US problem, but it's an enormous US problem, is that we had this huge population of really big patients in whom doing a kidney transplant was not a trivial thing. Actually, the complication rate after kidney transplantation is so high that most centers would deny those patients access to transplantation because the wound infection in those patients has a very deleterious impact on the kidney transplant survival and on the survival of the patient. And so essentially what we were doing is we were telling those patients, please go home, lose weight, and then when you have lost weight, we will activate you. Well, that happened in maybe 5% of the patients. The rest were actually condemned to die on the wait list. And so the difference between dialysis and kidney transplantation, most of you know, it's enormous. Kidney dialysis survival in the US is 25% for all comers. So that's like worse than having colorectal cancer with colorectal liver metastasis. It's a better survival. And so in some ways, we were really not serving those patients. And so we thought, well, why not see if we did a minimal invasive approach, avoid the incision, patients at the belly button, avoid lots of infections. What if we used an incision that was proven in bariatric surgery to be really safe? In bariatric surgery, the wound infection rate at that time was below 2%. In kidney transplantation in obese patients, 30 to 40%. And so then we published a few years after having done the first patient, 2008, the first patient, we published this series, which we had a really hard time to get accepted in the American Journal of Transplantation because the editors felt we are offending our colleagues by saying that they are denying patients access. And I had actually to provide the referral letters, of course, blacked out with the names, of showing that other transplant centers were sending us the patients because otherwise they would not transplant. And the results were incredibly good. I mean, I almost couldn't believe why, and I couldn't understand why would those patients do so well. They had so many comorbidities. But the fact that they didn't have wound infections and had very, very few surgical complications, in particular, no or very few wound complications. They actually had no wound infection. And then in our first 200 patients, we had exactly 2 wound infections. So it was very important for the long-term survival. Now, this is not a kidney talk, but I can tell you we have now way over 10 years experience and follow up on those patients. And they have an outcome indistinguishable from a lean population. So my boss at the time, Enrico Benedetti, he wouldn't stop coming to my office and he would say, Jose, you have to do the pancreas. Somebody else is going to do it. We need to do it first. And I looked at him and said, well, Enrico, I mean, this is the audited data by the Scientific Registry for Transplant Recipients, SRTR. And that's our survival in kidney pancreas transplant. So the red line is what we observed. So we had 100% kidney survival. And below the lines are the national average and then what we were expected to have based on the population. So we had a very high risk population. And the pancreas, you know, this was the same. We had year after year. It translates it into Italian. Interesting. How is it possible? Never seen that. So in pancreas was the same. We just didn't have graft loss. And we were doing 20 to 35 transplants a year. Not a huge volume, but also not a very small number. And we hadn't lost a patient in many years. And so I told my boss, well, I can't do better than 100%. Why would I do this robotically? And it wasn't until you know, Ugo Bocci from Pisa, he visited and he saw the kidney transplant, he went back, and then very quickly did a small number of pancreas transplants in kind of a hybrid procedure. And I contacted Ugo and I said, well, listen, my boss is terrorizing me with pancreas, what is it? And he said, well, if you have really good coronary arteries, go ahead and do it. But my health is more important than doing this operation. I'm not going to do this anymore. This is a crazy operation. You need to do the procurement, you need the backbench. You know, you are there like for 15, 16 hours if you include everything. And I have other things to do. But go ahead and do it, but you need to commit to it. And so in my head, I had gone through the process, but just never dared to do it until one day a patient came in whom we had done a robotic kidney transplant. So he was pretty obese. And when I explained to him that I'm going to do a big cut to do the pancreas transplant, he said, no, absolutely not. You're going to do this the same way you did the kidney transplant. And so we had a big discussion, and then finally we went ahead and did it, and it went extremely well. And what I realized is, well, this is not any more difficult than doing a kidney. Under the condition, we are not going to have bleeding after reperfusion. So we were doing the backbench like maniacs, using methylene blue perfusion to really look at any leak that we could have on the pancreas. And so the approach was very similar to what we have described in the kidney transplant. So we did, these were, again, obese patients. We did an epigastric incision and the trocar placements. And we did the pancreas transplants on the left side because I didn't want to deal with a hands-on enteric anastomosis. So I wanted to use the jejunum of the donor and pull it and leave it really long in the donor, pull it through the epigastric incision, that I could insert an EEA stapler and then simply do the anastomosis in like 5 minutes with the EEA stapler and not to have in doing the anastomosis. And that went actually really well. And so we then, I have here a little video if time allows for, where this is still with the old XI system, so we could not meet the bed during the procedure. That's because yeah, so we had to hand just to pull the bowels away. Yeah, I apologize. See here the dissection of the, so we put it on the external iliac artery and external iliac vein, and then do the whole process pretty much the same. We would do open, except that we would not use open. And we use Gore-Tex sutures, as most of you use now on vascular anastomosis. And we can do this in a very, very controlled way. And it's a reasonable ischemic time. Of course, the reperfusion, the first time we were like holding our breath. You see the vascular reconstruction, Y graft for the SMA and the splenic artery. And then once we do the reperfusion, we have to ensure, of course, perfect hemostasis, which essentially has to be done on the backbench. And then, as I said, we use an EA stapler to do, this is the head, and then you insert this through the jejunum, that is by the incision and anastomosis. I will spare the kidney, since there is no bile coming out, no interest. Here, the first 5 patients that I did before I left the University of Illinois. And you can see that despite this being a novel procedure, the warmest time is quite acceptable. Honestly, when we do this open in obese patients, we are not any faster than that. It's really not that easy to do the anastomosis in an obese patient in an open. You also see that despite those patients having significant BMIs, the hemoglobin A1C were very reasonable. And I was lucky enough not to have any enteric anastomosis, no graft thrombosis, and all the grafts were. I then left the University of Illinois to take over the institute, Transplant Institute at the University of Virginia. Then my colleagues at the University of Illinois in Chicago continued to add some more patients, and more recently published this paper. And I'm just putting in the conclusion to give you the mindset that we had at that time. Essentially, this increases access to patients who are obese. And so our whole focus in Chicago was always this, marginalized group of patients who are obese. Now, when I arrived in Virginia, it was a very different patient population. In Virginia, there is not that much obesity as in Chicago. And I did, the first few transplants only in obese patients until I had lean patients asking, well, why are the obese patients getting small cuts? And I'm having like this huge cut. Should it not be the other way around? And so then I thought about how could I do this in a lean patient, and then changed the process and essentially used a funnel steel incision to insert organs. And now with the new system where we could flip and work with different angles, I also didn't have to use that many trocars anymore. So just 2 trocars for the robot here, then 1 robot trocar would go through a gel port, and this was the assistant trocar, which we could use for each side. And so we place the pancreas now to the right side with the tail down, and then I could pull the jejunum through the incision to insert the EA stapler, and that made the operation really much, much easier and shortened significantly the operative time. And so here again, the placement, how we did the operation. And here is the series. So did a total of 21 of those pancreas transplants. Most were simultaneous pancreas kidney transplant. And now this is just a personal story for those who are younger and may start new positions. So until that day, I had never lost a pancreas transplant since my first one at the University of Geneva. And in some ways, I lost my virginity in Virginia because the very first patient I did, everything went super well. I thought, wow, this is great. I'm so happy. And 10 days later, she called. She was at home already. Huge abdominal pain. She came and she had thrombosis of pancreas. And so I went through the videos, I analyzed everything, and I couldn't understand why did I have that. Well, it turned out that my protocols that I had not been implemented, and the patient was discharged without aspirin, without heparin, without dipyridamole, which I gave routinely to our patients. And so if you start somewhere new, do not do any operation until you're absolutely sure that all the protocols are in place. Because the devil is in the detail. It was my personal failure that I had not recognized that the details were not in place. Later on, I had another graft loss. This was in a very patient with terrible brittle diabetes, very obese. And she had no panel reactive antibodies mentioned, so less than 20% PRA. But it turned out she had actually 2 alloantibodies, and 1 was a donor-specific antibody, very high. And we had not recognized that. And so that patient had an acute mediated rejection, and then in that context, a graft. But otherwise, we had graft function. Again, I was lucky. I didn't have enteric leaks. I didn't have operation that, if chosen well, can be done very precisely, and I think this results. So the take-home message is, yes, we can minimize the trauma. You know, the median laparoscopy of those patients is not that trivial. Again, these are patients who will be on steroids, immunosuppression, and so on. And I think my students and the students of my students may do this one day routinely, but I cannot emphasize enough how important it is that this is not an operation to start without having significant experience in robotics. And so I think you have to have at least 5, 6, 700 robotics other before you address it. Now, the other thing is also, you cannot do like that alone. And that's why I think you have a formidable society here with the companies, because you give knowledge from one generation to the other. And I could not have done any of this with Benedetti and Piero Giulianotti. Many, many, many young people who were part of this. Pietro, you're nodding. You were also going through there, and so it was an amazing atmosphere there that we were able to do, you know, a little bit out of the box things in an environment where we constantly brainstorm, constantly ask how better. And so hopefully we'll be able to pass this on to the next. So thank you very much.
We have
Thank you. Very nice talk, and the results are very good, because when you perform pancreatic transplantation with that, there is a difficult surgery, and even if surgery is made easily, the result is not always good after. I have a question about the indication for this patients with obese patients, because when you deal with these patients, we perform bariatric surgery or to decrease the BMI before the treatment, because it's not only to give the operation easy, but after the transplantation, the patient still increase the weight. And so it's also a point to have no excellent results after renal and pancreatic surgery. So, and nowadays, there are also the use of agonists of GLP-1 that can improve the loss of the weight in these patients. So what is your position for these two solutions before the transplantation?
So I can answer the question in two ways. Maybe I start with the anecdote. So when we started doing this, we were invited by the American Nephrology Association to talk about this. And then I realized going to the meeting that it was actually a debate. And it was a debate in plenary session, so 5,000 people in the room. And then I saw that there was a bariatric surgeon and a nutritionist and so on. I said, oh my God, they are going to eat me alive. Because I thought they're going to say exactly the same thing you're saying. Well, it turned out totally different, because the problem with bariatric surgery on dialysis is the sarcopenia. So you actually increase mortality on dialysis by significant weight loss. And the problem is that those patients don't just lose fat, they lose huge amounts of muscle mass. And then they become more prone to infections. And nephrologists in general don't like to do bariatric surgery while on dialysis. Now, they are doing it, and now with the GLP-2 analogs, we will have to learn a whole lot, but it's the same. With GLP-2 analogs, you get sarcopenia. And that's the first point. And the second point is that, at least in the United States, the so-called drop-dead rate on dialysis is 10 to 15% per year. So if you start at a BMI of, let's say, 50, it will take you about 2 years to get to the weight range that most centers would accept for transplantation. So in that period, you will lose probably 1 out of 5 patients already on dialysis while they are waiting to get there. Now, in Europe, it's different. In Switzerland, mortality rate on dialysis is extremely low. But for the US, it didn't make sense, especially for the patients who have a living donor and for the patients who will get a pancreas. They have a relatively short wait time. And so for those patients, when we calculated, you can do simulation, what would happen is bariatric, wait 1 to 2 years, and so on. It was very clear that doing an immediate transplant and then addressing the overweight would confer probably a benefit. And so you have maybe seen the papers from Illinois about weight loss after transplantation for liver, kidney, and pancreas patients. So you cannot leave those patients just alone. You have to deal with them afterwards. And so our approach was, most of them, if they didn't lose weight in the following 6 months, then we would bring them to bariatric surgery. At that moment, non-diabetic and not in uremia.
My second comment is about the moment who these patients are addressed to transplantation, renal and pancreatic transplantation. In which moment? Because you try to address this patient to the surgeon before the dialysis, because it's decrease the morbidity and the mortality. So in this case, you have time to perform bariatric surgery before the hemodialysis and to reduce the period in the dialysis for this patient with a lot of complications due to diabetes.
So I right that Europe, where access to healthcare is pretty good. In the United States, 30 to 40% of patients start their first dialysis as emergency dialysis. So they don't even know that they have kidney failure. And so that's a whole different situation. And that's one of the reasons mortality is so high on dialysis. So none of those patients would get preemptive transplants. That was exceedingly rare. Yeah.
Okay, thank you.
Yeah, you go. Christian and then.
Okay, very short. Two things, very interesting experience. First of all, you started robotic pancreatic transplantation in obese patients because you thought they were the ones that were benefiting most. So you are starting in probably the most difficult patients because even with a robotic approach, it's more difficult. So one comment on that. Second thing is, what about the results and I'm a proponent also of robotic transplantation in, for example, liver. But when you started doing lean patients, what you thought, in your experience, were the advantages of this approach?
So the first one, for us, it was really important to use robotic with a rationale. So we didn't want to do robotic just to do robotic. And so since in lean patients, we really didn't have a problem that the robot would solve, we were reluctant to do it. Now, of course, I'm a surgeon. For the patient's different. Having a cut like this may be an issue, if you can avoid it. But we really wanted to solve a problem, and the obese patients had a problem with wound infections and the subsequent consequences of it. Well, technically, honestly, it's not that huge of a difference. At the end of the day, it's the same operation if somebody's obese or not. The second question, why lean patients? So I was very reluctant to do it on lean patients. The first patients that asked, I said, no way, there's no rationality. But now, of course, that I see, a young woman coming and having a bikini cut and actually not having scar outside, but why not? And if I can do it with the same quality and the same safety, we have the same operative time in robotic kidneys as open because we don't have to open and close, such a big wound. So maybe I'm getting older and more relaxed. I don't know, but I think if patients ask for it, then I do offer it. Good. Okay, sorry for that.
So thank you for the first 5 pancreas transplants you showed. 3 had a bladder drainage. I showed an enteric drainage. So why 3 with the bladder drainage, and how did you manage the anastomosis?
So the anastomosis was managed the same, and the reason was I could not change the table. It was too steep in Trendelenburg. I would have to undock everything, dock back, and I couldn't reach the small bowel. I was too steep.
Yeah. And we have Tom, last one. Thank you.
Great presentation. So you said that you have reluctance in doing pancreas alone for the type 1 diabetes. I think we've heard that many, many times from Diabetic Society. That's not really indicated. But there's a big difference in quality of life of the insulin versus the pancreas transplant. And you showed that the hemoglobin A1C is in 5s. This is so not easy to achieve in the type 1 diabetes in long term. So if you are able to reduce the surgical comorbidity in partly maybe small scar or minimally invasive approach, would you really like to revisit the use of pancreas alone for type 1 diabetes in earlier in their life?
Yes, that's my approach to pursue it.
That's brilliant. Thank you very much. Next speaker, Adrigetti, who's, no, who's going to?
Change again in the next project. Okay. I've been updated.
Okay. First of all, as usual, I like to pay a tribute to our late companion, Miguel Ciardulo from Argentina, Lorenzo Sotti from Italy, Gilles Manta from Switzerland, Jean Nakash from Israel, and Francisco Castro de Souza from Portugal, from Coimbra. It's up to us to keep their memory alive as they all brought extreme and a large tribute to the liver surgery. Having said that, and thank you for the invitation, I'm going to speak about something which is happening, the future of clinical research, specifically and dedicated for the surgeon and for us as a scientist and surgeon. And what's happening now about what I would call the in silico trial and the impact and input of digital twin in virtual twin in surgery. But first of all, I have no conflict of interest. I am not a mathematician. I am not anything or computer or data manager. So to make it simple, I'll try to be very easy to understand. So liver surgery, of course, the 20th century started with all the human creation with Quinault, Starzl, Professor Bismuth, Lotta Jacob. They taught us how to go inside the liver, how to transplant the liver, how to improve. And I told it in my previous talk, previous years, about the human era. 21st century, though, we went from a technology era, digital era, and now we are with the AI era. Providing that you have a good Wi-Fi, good electric energy, hopefully you will have no problem with your patients. So the improvement, I would say it's less than 10 years. It started with the machine learning, to AI, and I'm not going to go in details about the diagram of Venn. The principle is just to mimic the brain with deep learning, machine learning, and artificial intelligence, which are computer programs to decide, to depict, to make easier the decision, the strategic decision, clinical decision, therapeutic decision, and even possibly prognosis. So at the same time, that is an impact in our clinical practice. What you need to understand is that we started to do science. If we work in the surgery and we have an interest in scientific evidence, we went from evidence-based surgery and we started to prove that what we are doing is correct. Are we doing, is it an improvement? Are we operating? Do we have a clinical value? And for a long time, we just mimic, it started with the medical, the physician profession, and then us as a surgeon, we try to do exactly and starting to produce paper with evidence-based clinical trial, randomized clinical trial, to produce clinical guidelines, and to have some sort of evidence easy for us to even to establish some benchmarking in some therapeutic decisions. So we even possibly now start to even assess scientific innovation, and we have a lot of tests for that. Having said that, past 3-4 years, we started to criticize this evidence base with the clinical trial battle. People started to say, well, your cohort study, you don't have many patients. It's an ultra-selected population. This is not happening in real life. You have limited follow-up. And it's true, some of the clinical trial, randomized clinical trial, you have a lot of dropouts. So it's very difficult to say if it's good or not. And then more and more people say, we need to have real world data. This is the whole fight about the real world data. Real world data is not a bad name. And in fact, if you look at history, this is an example of real world data. If I take this paper about liver resection versus transplantation for hepatocellular carcinoma in cirrhotic patient, this is a paper published in 1993, Olbro's team with Professor Bismuth, that was real world data. And then you have the evidence-based published by Vincent Mazzaverro, and that's the evidence-based. So if you look at that, I don't know if the profession in clinical practice who won is people has been convinced by the paper of Professor Bismuth or by the paper by Vincent Mazzaverro. Up to today, I don't know who's going to win the Champions League. That I leave it to you. We'll see if it's Milan or Paris. So when we said big data, real world data, I have to say that that was pushed very hard by all these big three. I put aside maybe Bill Gates, mainly by these three, and with Sam Altman, who decide with all the generative AI. And of course, it is an improvement in technology. It is an improvement to assess the data, but they are relying on a massive, massive database to assess the results, and it's completely automatic. So that's the era of generative AI. At the same time, it started to produce and to see the effect of the hospital, the healthcare digitalization, changing the nature of work, changing the nature of the society. And how are we forecasting? We started to say, is this an innovation in surgery? Is it an innovation in technology? What about the surgeon scientists? How are we going to assess all the data that but the performance, all that is because the AI is judging the performance by massive a lot of database need the standardization, need to have an open access, and we need to share these data. Today, it's not yet happening. And all that it's done by generative AI, and it's an algorithm based, it's not a decision strategy. It is an encoding the thinking. How are you thinking? If it's number one, it's okay. Number zero, it's not. So we don't know. And more, we don't know how to value that in scientific. And I have to say, in my opinion, randomized clinical trial, statistical value is dead. That's not how we're going to assess the paper. We're going to rely more and more on big data, produce benchmarking rather than proper comparative trial, because we are limited by the population, and we are limited also if it's reproducible all over the world. And that is an effect which started already. And we need to be aware of that because we are in the, I would say, it's a simultaneous assessment. Basically, you have a lot of innovation coming up. We need to assess. We don't have yet the time to assess properly if it's good or not. And then all of the sudden, another new thing coming. So it's very difficult to see what's the outcome of that. However, we try to adapt. We even published some sort of AI extension to use to assess the validation of all these paper with some AI-based medical device or AI-based trials done for different clinical assessment. This is an example of two papers which are well known. AI for prevention of and clinical management for HCC, AI machine learning, deep learning, and liver transplantation. I probably missed a lot, but they are really, really a massive production of these papers. At the same time, we started to see the hallucination rates. And then that was, I would say, the negative value of these paper and these scientific production made by AI. Do you think that's a problem? No. Same guys reduce the problem. So today, we're not in generative AI, we are in the agentic AI, which means multiple agents. So forget about ChatGPT, we are already in mini ChatGPT, ChatGPT 5.0, ChatGPT 4.0, and each of these models are adapted for the specific question that you're going to ask yourself. If, for example, you're going to need massive population, don't use mini chat. Use the ChatGPT 5. So it's incredible. It's moving fast, and we struggle to follow all these innovation. At the same time, in the FDA, that was a new thing. We started to say that we're going to accept a computational modeling through verification and validation. That has been approved in the process of to be approved by the to open, let's say, the big field of the insulin, basically, and the virtual modeling. So how are you going to assess new molecular therapy, new biomarker, new treatment? because it's true that in real life, you don't have many patients. We know that the clinical trial takes a long time. So the companies are pushing, and the scientists came up with this solution. Why not creating synthetic arms? And it started already. Why? Because you want quick answers to validate some treatment. So here you have algorithms to assess the machine perfusion in organ retrieval. You have an automatic generation of liver virtual models with AI, and you apply that to liver resection and to predict what's the outcome. I left that blank intentionally because I had the choice. Am I going to put all the paper that I've seen already produced? Or do I say, give time, assess this paper? Because what happens now is that we don't have time to assess this paper properly. You have so many coming up that we are barely having time to see what's happening in this. So today, as I said, we were here, okay? We were here, that was the foundation. And I think that probably now, in 1 year, we are already between these two last bits, which is multiple assessment with AI, which don't need any human input. And also at the same time, you have to consider ethical consideration. So digital twins, virtual twins, can we do that with the living organs? Practically, it's already started. I mean, if you have a factory or if you have cars, you can reproduce synthetically a car and then do the crash test on them, see if it works. How can you correct them? Human being, though, it's it's another story because you have to copy the human, copy the organ, copy the cell, copy all the data. Also, you have to put this patient in a specific environment. Is it the same patient in USA, the patient in Africa, patient in Europe? So you don't know. So there are multiple parameters to assess. So this is what I said earlier, generative AI, agent AI. Agent AI is just to say that you have multiple agents, with each agent is going to answer one item. One is for the radiology data, the other one can be for the pathology data, the other one will be maybe for his clinical habits. And then you can interconnect all these agents so that you will be able to create a complete virtual person. And then at that time, you can test whatever you want to test. So that's the principle of doing the multi-scale testing. To be fair, this is the basic synthetic control arms. You base your patient with your previous clinical study and your real world data population. You create another control candidate, okay? You match and compute. One, you will keep it as your control group, and the other one, you can test whatever you want on them, okay? So the in silico clinical trial, it's an AI designed virtual twin population to be able to assess medical treatment, to assess the validity of a surgical operation, to assess anything you want, basically. It came, and that's with the Fortescue with Dassault system, and I have to say that they are really in advance. It's all because recently they have celebrated the 10-year. Up to today, there's only one organ which is completely artificial. It's the heart. But the heart, it's a pump. And it took them 10 years to produce an artificial organ completely, and that's the only one. Their aim is to create a complete virtual human being with virtual organs. They even started to think about doing the liver and to do a multi-scale model for the liver to test the hepatotoxicity. So now I have to think about Guido with his quantum effect, because the liver is not like the heart, it's not like the kidney. And when you think about this multiple micro areas in it, each area full of input, output of vessels having more than 2 million cells, I'm not sure that it is able to produce complete artificial liver. And I have to say, I think I will keep the degree of quantum effect. I think that's that word. So most importantly, having said all that about the liver, about the insulin trial, what you need to understand is that whatever you create, you have to keep the ethical issue. And today, even the digital twin, it was a dilemma. How are you going ethically to accept that? Is it fair to keep the data of the patient without their authorization? Is it fair to copy? Because actually, it's like you do a virtual clone of you. Is it ethical or not? In Europe, with the AI Act, they get away with it because they consider that the AI in health is the highest level and need the security. And in the act is going to come into force already in June 2016 and to be in place fully in 2027. Because half of the new medical device that you use, even in a robot, any instrument, any device today includes minimum AI. So you have to see. And as long as we don't have transparency, how you do that, you cannot. For this instance, AI says that you have to sign a consent form. So basically, you have to keep what you do in real life and you apply it in the virtual. I am not against all the AI in clinical trial because I think there is some input in it. And sometimes technology will be always faster than the human way of thinking or working. But as long as we keep a balance between science and ethics, and I call it not the conflict, but the coupling of Descartes and Rabelais, you have to keep the ethic, you have to keep the methodology, you have to keep the thinking. I think science is good, technology is good, but as all this been said, it's not me. Innovation is built on something that already exists, but comes from a different field, which we are doing that. And discovery is not coming from known data and is based on new unexpected facts. This is from Professor Finish. I repeat my slide last year because I like what Da Vinci has said. Nothing can be loved or hated unless it is first. And I hope you understood everything.
Thank you, Gina. Do we have a discussion for the, yeah, but yeah. Great.
Thank you. Thank you, Gina, for explaining us such a complex issue. I have two major concerns on this setting. One is the data, the quality of the data, because we know that to have an in silico trial, we need to have a model, and to train the model, we need to have data. And if we don't have, if I don't trust the data, I will not trust the model. The second concern is about the accuracy of the model, because I will not try a model that it wasn't compared with real world trials and real world models. So what are now the regulatory agencies doing on these major issues?
They are doing. So you have the French Clinical Research Infrastructure Network, which is working with the European Health Authority and Technology Digital Service. They started to actually, and you have a lot of projects going on, which are going to start tomorrow, well funded, to assess the AI-based. First of all, in the regulation, you have the European database. It has to be completely European, not sharing with elsewhere. That's very important. Second, the concept that we are going to use specifically on the rare disease. So they are going to do that for maladie de Charcot, for example. They are going to do that to all the difficult disease where you don't have any answers on that. They are going to create the synthetic arms validated. So it's joint with the European, with industrial companies, of course, funding from the European, and ethical coverage with Ethic AI, which is implemented by the European agency, to assess and to prove. The first thing is to proof of concept. The paper that I showed you are mainly from USA. I have to say, not many produced. You have only one or two paper. I have to say that there's one paper which is interesting, published by Alexandre Loupy, which is going back to what you said, Yann Lerut, about the Banff score, because pathology, you can. It's not a vivid organ. It's just slides. So I think that the AI can depict, and you may have a logic to have a new score on it. So it is already done, and it was done for in the renal transplantation, actually, and it seemed that it's okay, and it has been FDA approved to use this new score based on AI. Okay. The second thing is that data sharing is the main issue. So they created, the health authority is trying to have big Euro data center. So to make sure that all is accurate, but there is still conflict, but I call that political conflict. So once that is issued, then we may see if it works or not, because I'm like you, I don't know. In fact, I don't know. So I'm open-minded, but I don't know what's going to be the answer up to today.
Thank you very much. Yeah, yeah.
Yeah, yeah. It is. Yeah. The organ allocation, I totally agree. It's going to be. Yeah.
Gina, can I challenge you on something? You made a very emphatic statement. You said the RCT is dead. And yet, and yet when you describe the in silico trial, that looks to me very much like a very fancy way of doing an RCT. You know, you're controlling for something else. You have an intervention, and sure, you use algorithms and all that. But the basic thing is, I think the data, when you know the large language models go out and look for data, you are still going to need that very, very important comparison of an intervention against control.
That I agree, especially for medical science, but surgical also. The real world data, it depends how you work, okay? And I think you have all your answers. Comparative, it depends what you're looking for. I didn't say RC are dead. It's true, because you're getting more and more complex. Sometimes, I don't know if you've noticed, you see some comparative trial, randomized comparative trial with a question that honestly depends on the answer. I'm not going to copy it. One of the randomized trial we're going to speak about later with the cholangiocarcinoma that I saw. You know, endoscopic versus percutaneous in cholangiocarcinoma. I don't understand this comparative trial, and already you have dropout in it. Is it going to tell you something? Or the correct question for that type of disease is, do you need to drain or not? When are you going to drain? And when are you going to operate? Whichever type of drainage you do. You see what I mean? It all depends how the question. Well, now in the virtual or digital randomized control trial, we may say it's not a question that you're going to ask, it's a prompt. It's just to be fashionable.
Clean it up a bit. Okay. Well, another thing that worried me was that you might have a digital twin of Guido, and that really. Anyone have any other questions? It's very stimulating and thought-provoking.
Well,
okay, I think that's fine.
Start on time at 4 to 5.
Thank you.
How are you doing? I'm sorry, it's a long trip. I mean,
The Central Valley. The Central Valley, the one.
Yeah.
I've seen. It's incredible. It's
Yeah.
nice. Oh, good to see. We have a lot of faces. So you know when the house when they want to do it.
sorry?
We see when they want to do it.
Oh, no, I didn't ask. They don't know. Huh? I don't know if the program going. The program is.
He said, I came for you. I said, no, no, you came for him. You say you come.
Actually, I was happy you came for me.
He came for you. He did. Flavia, he came for you.
kind of separated the guy of I like the you can select the style, you have a lot of Are you did? Are you ready for this? I'm not sure, but you know, it's difficult to say.
Okay, so I'm very happy to introduce a lecture now that will be recorded for the so-called European School of Surgery. This is this platform for the European Surgical Association, where we have some special lecture, not many. This is a school, so usually our format course given by resident and discuss afterward, but we have a special lecture. We have Robert, special lecture on the skeletal robot, Murray Brennan, who gives us about 4 or 5. And what the advantage today is with the next presentation with that for everybody on the European School of Surgery. So we do a bit the format that match this European School of Surgery in the platform. So I will start to introduce, so it's my pleasure to introduce Professor Luca Aldrighetti. He is the head of surgery at HPB Surgery Transplantation at San Raffaele in Milano. I think he's known for everyone who works in this field. He's a leader in minimally invasive surgery, complex surgery, ALPS, robotic. And 2 years ago, we were very interested, as many, in perialar cholangiocarcinoma, realized the many gaps in this field, and we decided to organize a consensus conference which took place in Milano, not a long time ago, and it was just, in fact, 2 days ago now accepted for publication in the Annals of Surgery. So I would like to invite Professor Aldrighetti to deliver this lecture.
Thank you for your presentation. So I want to give an overview on the consensus. If for reasons of time, we will not have the chance to go through all the topics. The background is pretty obvious. There are tons of papers and there is a growing body of literature on perialar cholangio, but actually there is no consensus about that. There are many differences in treating this disease among centers in the same country, among different countries, and among different continents. The other crucial point is that is a disease where we need really a multidisciplinary approach. It's not just a surgical disease, and so definitely many different colleagues need to be involved to understand how is the best treatment for this disease. And finally, you all know that there are new advances in the treatment of this disease, oncological treatments, and the transplant program. So based on this, we wanted to understand if these numbers can be changed with a consensus, because numbers are still dramatic. Resectability rate is low. Morbidity is up to 70% in benchmark cases. Mortality can reach 13%. also in benchmark cases, so in the best cases, we have a pretty high rate of R1 resection, 25 to 30%, and this is the overall survival. So based on this, I mean, Professor Claven and myself, with the great help of Jordi Brie, had the idea to set up a consensus not only among surgeons, trying to avoid the risk to do a consensus only among the surgeons and within the surgical community, but trying to put together surgeons with the other specialties like hepatologists, gastroenterologists, oncologists, and you will see that interventional radiologists, and you will see that this will be well represented in all working groups. Obviously, the aims are these: increase the treatment of this disease, create credible guidelines for this disease, and above all, create a consensus that is unbiased. And that's why you will see we chose the Zurich-Danish model for this consensus. I will not go through the format of Danish model because you can find that in the literature. But as you can see, basically, is based on different phases. And I would say that the crucial point is the initiation of the preparation phase with a strong literature review, with a large selection of experts. And after the consensus, the other crucial point is the jury that actually is the crucial role in define the final statements. 73 experts were selected, 17 colleagues were I would say obliged to review the literature. 3 databases have been analyzed. More than 4,500 records have been screened, and almost 600 articles at the end have been included in the review. This is the steering committee. I will not go through that because actually some of you were included in that. The organizers committee set up 47 clinical questions that were then analyzed by the steering committee and then sent back to the organizers committee. And finally, 8 panels analyzed these clinical questions. The literature working group probably is the group who did actually the large work for preparing the consensus. And these are the panels, 8 panels: definitions, diagnosis, preoperative planning, preoperative optimization, surgery, morbidity, mortality, oncological treatment, transplantation, and expected outcomes. What I want you to notice that these panels were chaired not only by surgeons, but also by hepatologists, oncologists, and this is one of the key points of our consensus. This is just some pictures of the meeting. The jury who did a very important work in giving the final statements. You see only colleagues unbiased because not directly involving in the treatment of this disease. This is a manuscript that has been just accepted by Anna's surgery, so I think it will be accessible in a few weeks. So I hope all of you will find it interesting reading it. And I said 8 panels. We don't have time to go through all the statements, so just a selection. This is a surgical community, so I will just go through the surgical part. So the panel 1 worked on definition diagnosis, and I will not discuss that. The panel 2 addressed the point of resectability, and I think this is a very crucial point were not only surgeons, and this is probably one of the important messages of the business. You see, resectability is not only a technical issue and is a combination of considerations, biological consideration, and the patient situation. And in each of these three topics, we have different items to be considered. Each of them can give a green light or a yellow light or a red light in proceeding with the resection. So I think this is a good example to express the point of resectability going out from just the point of technical resectability, which may be a problem not only for perihilar cholangio, but also for colorectal mets and other diseases. The panel 3 was working on preoperative optimization, which I will not go through because of the problem of time. Please, Laurent, don't be upset with me. And surgery has been addressed by these colleagues. These are the main recommendations coming out. Obviously, major hepatectomy and resection with segment 1 is the standard treatment for surgical treatment for this kind of disease. I want you to look to this statement. Left side hepatectomy should be considered when possible due to the high risk nature of right side hepatectomy. And I think this is an important point. It is a strong recommendation and is something that can be considered when facing this time of disease. Hepatectomy should include always a segment 1 in bismuth type 3 and 4, and this is something that we already know, but probably can be interesting to notice that in type 1 and 2, probably resection of segment 1 may be not so crucial. Lymphadenectomy is a strong prognostic factor, and this has to be considered as probably a red light for going for resection. Vascular resection is not recommended as a standard, so a routine no-touch technique is not recommended. This is another important point that is coming out from the consensus. And for the first time, we have a role for the minimal invasive surgery that even for the Klatskin tumor is suggested not only feasible, but also not inferior to the open approach. Panel 5 was talking about, was discussing morbidity and mortality, which is something that is out of this presentation too, as well as obviously perioperative oncological treatment. I want to stress the point of transplantation. So finally, transplant oncology is reaching also the topic of perihilar cholangiocarcinoma. You see, patients with perihilar should be considered for liver transplantation. In the presence of these characters, obviously any contraindication to transplantation, presence of unresectable tumor based on what we said before, a tumor that should be located above the cystic duct, size that should be not superior to 3 centimeters in maximal radial diameter, obviously no evidence of nodal or distance metastasis. This is an important point. If the patient can be a candidate for transplantation, it should be avoid any surgical procedure before that to avoid the increase of violation of the tumor plan and some cyst in the peritoneum. this is a crucial point. Liver transplantation can be considered also, instead of resection, for resectal perihilar cholangiocarcinoma, if there is a question about the possibility to reach a complete removal of the disease by a standard surgical resection. So another statement that can open a new way for transplant in such a disease. Panel 8 was discussing about the expected outcomes, but this is out of this presentation. So my conclusion basically is that this kind of consensus was, I think, a unique event, putting together a multidisciplinary expert, an impartial jury, a dedicated audience, and so is probably a unique experience in defining the treatment of the disease, not only among surgeons. Obviously, there are many challenges that need to be faced yet, but I think we opened the way. Thank you very much.
Thank you, Professor Andrighetti. You can see this is take 2 years to do this kind of conference. At the end, some we think it's pretty obvious, but it's not the case. It's not by an independent jury, as was highlighted. And another very important point is research. Where do we go? So every panel at the end has to do what is missing. What's the next? So this should be also useful. Maybe I want just to comment on a few things on this. And the next point, the work's been done, and the two are here, Matthias Pister and Francesca Ratti. They did really most of the work. We guide them, or we try, but when this conference is so much work that is done, that it is, you need to have really committed people. And in addition, at the end, when you do that, there is friendship among the people. We know each other. We change. That's a very special exercise that we like to do. Maybe one question, two small questions, Luca. One is, and I know it's a challenging question, how do we can evaluate the impact of such conference, right? It's published, okay, it's good, people are happy, discussion for 3 days. How do you see an impact? How do we know in 3 or 4 years whether this conference has been useful or not? And the next question is, how long is valid? How long is that? Now you have a conference, today is state of the art of the literature, what's published. When should we do that? Because things are changing and many papers are published now on this topic, which may challenge, in fact, some of the recommendation. I don't know if you want to comment.
Starting from the last, I think this is a really an evolving topic. Oncology, transplantation are really major changes. So I think maybe in 2 or 3 years from now, that consensus will need to be reviewed. And the way to see the impact, there are new messages. As you saw, role transplantation is a very new message. Some indication how choosing the type of resection. So we will see what is coming out in the literature in the next years, how centers will change the experience, and obviously how morbidity, mortality, R1 resection will change, because you exactly know which is a benchmark rate of morbidity and mortality. So we will compare future result with that.
Any questions or comments?
Thank you for the presentation. Just one question regarding transplant. So there was a group working on it, and you just explained some of the results. Did you also define the pre-transplant strategy and requirements, and what are they?
Well, this has been addressed by that group and by the oncology group, because obviously there is a lot going on in terms of pre-transplant oncological treatment. And if you mean the type of drainage, well, there are statements on that too.
I was thinking also Radiation therapy, chemotherapy?
Chemotherapy.
Is there a minimum required? What type?
Well,
Immunotherapy?
well, this has been addressed by the oncological group, and obviously this need to be applied in all candidates for surgery. Chemo, immunotherapy. This is the standard treatment before considering the patient for transplantation, and you can find a statement for that too.
The treatment.
Professor Bismuth, thank you.
So, yes, the treatment of the disease is one of the most difficult surgical treatment for liver resection. And I think that the patient must arrive directly to an expert center for HPB surgery. My question, is it the case today? Some years ago, the majority of the patients referred to me was already stented and arrived to the surgeon, unfortunately, after failure of the stent with infection of the biliary tract. And this is a worse situation to treat the patient. So my question is, today, patient arrive untouched to the surgeon, frequency, half of the patient, 1/3 of the patient. What do you know about that?
Well, I mean, rate is still low. As you saw, is almost 30% of the patient can arrive directly to an expert center. One goal of this consensus was to put together surgeons with gastroenterologists, with oncologists, with interventional radiologists, to give this message and to arrive to a pre-operative treatment that in a way is shared to avoid what you said, that the patient is treated because is considered unresectable, because is considered without any chance of treatment, because this was the main reason for receiving with already complicated treatment with stents.
Thank you.
Professor Hemon from Columbia, New York.
Yes, thank you. This is very great work. And of course, Pierre has probably done more of these than anyone. I'm always uncomfortable with in consensus meetings around surgical diseases, particularly rare surgical diseases. The evidence level is usually 3 or less, right? It's so let's say 3, 4, even 5. And there's no level 1 or 2. And so the danger that I see is two-part. One is if you have too many recommendations, each one might have very weak evidence behind it, and it's just mostly opinion. And then there's no concordance between the level of evidence and the strength of the recommendation. How do you reconcile those questions?
Well, that's a very important question. Thank you. You know, if we have level 1, you don't need a consensus conference. I mean, if you have very high level of evidence, you don't need, and if you have no data, you don't need. So everything that is in between, and that's you have the recommendation by the expert, and if you see the name, you have most of the expert were in Milano, including the Nagoya group, etc. So they were the expert. So they are here to give their opinion, indeed, based on data or opinion, and the jury make the recommendation. So the recommendation is basically strong or weak based on an opinion, if you want, that's an opinion of the consensus conference, over the data that's come. And then beside that, you have the level of evidence. So you could have, and that would be, you could have a very low level of evidence, but a very strong recommendation to go in that direction, for example. And There is no other methodology. I mean, maybe there is no other methodology I can address that. And what we've done compared on previous concepts, we end up with questions. So what is missing? What do we need? That could help people to design the randomized control trial, etc. This is not a guideline when you follow everything what you have. A big topic here was this, like pancreas, resectable, borderline resectable, non-resectable. And that was difficult to do that for Perry Eiler. And at the end, it is this drawing that was questions, how we can go for that. And that's more proposition with something in the literature that may be taken or modified. And I think only a consensus conference with experts speaking together can achieve this kind of, so I think it's a high value, but I agree, we need to look at that with some distance.
Yeah, thank you very much. I think we are grateful for this work and we move on. Thank you, Luca. Thank you, Pierre. Now for then the place of laparoscopic liver resection in the robotic era.
I will go. I have a second title. This is my second title is this. The Swan Song. You know what it means? The Swan Song is the last work of performance of a poet or an artist before death or retirement. So that's over. All right, so agenda. What are the current methods? What's the evolution of laparoscopy? What are my remaining indications for open? The minimally invasive donor appendectomy, the Paul Bruce Da Vinci robot, which is now in place, and an international survey that I did to address this question. And I'm going to show you part results of it. Okay, you all know that. This is the evolution. At the beginning, it was amusement, then there was skepticism, there was acceptance, global diffusion, and now we're at the turning point, which is the result of the robotic explosion. And basically, the challenge is what's between MIS and open, what's between lab and robot, and what about extreme surgery? So what we know about minimally invasive surgery, which includes laparoscopy and robotic, and I insist on the fact that robotic surgery is laparoscopic surgery, or at least minimal, it's the same thing. Small holes, video, no hands inside. So that's the point, that's the reality. So it's a laparoscopic tool. So it improves early outcomes, pain, bleeding, morbidity, hospital stay, does not compromise long-term outcomes and oncologic outcomes, and it may improve them if you get access early access to adjuvant therapy. This is true, but only in selected patients. This is not for all patients. And all MIS is still today, in my opinion, neither possible nor desirable. And this is not only my opinion, this is what the evidence shows. So what are the current methods? There are two methods, the gold standards. The pure laparoscopic, which remains the most employed for just logistic reasons, and the robotic assisted, growing numbers, limited data, but I think the data are I should change this slide because the data are not so limited anymore. So our choice over the past 10 years has been these kind of things, with a very nice setting and large screening, etc., etc. Robotics, this is Giulianotti saying in 2011, seems to overcome the limitations of laparoscopy, and I totally agree. It doesn't replace laparoscopy, it overcomes some of its limitations. So what's the pro for robotics? It expands the role of MIS, because you have suturing reconstruction, quality and stability of the 3D vision, digital platform, built-in ICG camera, and a shorter learning curve than laparoscopy problems. We see that in the survey. Cons, unproven benefit for resection alone. In my opinion, when you do resection alone, which is 95% or 90% of our operation, which is removing a piece of the liver without any reconstruction, there's no evidence whatsoever at the moment that it's better laparoscopy. It's mostly surgeon's preference. It's huge. It's possible mechanical failure, although it's very common. Longer instrument change, need for a second surgery on patient side, maybe some, which I think is important, and cost. None of these things is important. I really agree that it addresses the limitations of laparoscopy, especially reconstruction, that it has a shorter learning curve, probably,
and it increases access to minimally invasive surgery to patients that were, to more patients and more surgeons, especially operations that were not or are not feasible by laparoscopy. So it's a great improvement. So there should be a need for well-designed studies comparing lap and robot for resection alone. It will not happen. Will not happen because it's all about surgeon's preference. When you start robotic, you love it, and when you have a robot, you want to use it because you need to use it. So what happens is that you don't do laparoscopy. What's the evolution of laparoscopic approach? I'm going to show you my evolution and the learning curve of laparoscopic surgery. So this is the learning curve. This is the infancy, the beginning, and you suffer, and then you master and you're joyful. So this is exactly the chopstick surgery. So I started with that, and this is the first, actually the first series that was ever published on laparoscopic surgery. It was easy segments. It was in 2000, and I had to face at the ESA, because it was a European surgical paper, the anger of most of the audience. So, and this is my first case, laparoscopic adenoma and left lateral became routine. And then we started to do hepatocellular carcinoma, and we published on that. And we were the first to show that when you do laparoscopy or versus open, we have less postoperative decompensation, especially ascites. It's now accepted and being demonstrated. For colorectal metastases, we limited ourselves to oligometastatic disease, less than 3 or less metastases. Major hepatectomy was the next practice when 2009, so 9 years, about 10 years later, and we were able to do a major hepatectomy. Then we went to more complex cases, which is not major hepatectomy, but difficult operation and parenchymal sparing, which are segmentectomies or sectorectomies, whatever you call it. And this is an example here of a Glisonian approach to the posterior sector and the posterior sectionectomy anatomical by laparoscopy, which is a difficult operation. I'll show you another example here. This is the HCC segment 8, daughter nodules. I'm going to skip the 3D reconstruction and show you, if I can, that we can do the Glisonian approach, clamp the anterior port, let it go through the laparoscopic approach, then we can get the ischemic margin, then we inject ICG, and you can do a perfect anatomical resection. This is laparoscopic surgery. I'm sure you can do that as well with laparoscopic robot, but you need a way. By the way, if you inject the ICG 1 week before, you get the tumor ICG, and if you inject the negative staining, this is during surgery. So this is also something that doesn't require robot, but you can. And this is the operation, anterior section. This is the result with the little hepatic vein here on the right hand. One thing that the robot is not as good as laparoscopy is cutting the liver because there's no CUSA. And the liver cutting is really something with low volume anesthesia, intermittent pringle and CUSA. This is what you get. And I'm very frustrated when I see a robotic resection that this is not as nice as we can do here. This is, of course, fast forward, quick, but not that quick. The robot is not that quick either. And then this is under clamping, intermittent clamping. And then we unclamp. This is what happens. Then you reclamp. And this is segment 7 resection. This is the right hepatic vein, which is exposed. This would be not as easy using laparoscopy. So I think this is the main limitation, in my opinion, of the robot is the lack of CUSA. It probably will happen soon. But what are my remaining indications for open surgery? Intrahepatic cholangiocarcinoma, because we need to do a very extensive resection for a very large tumor. Perihilar cholangiocarcinoma, this is where I'm going to get busted in the head by my colleagues and friends, because this is a resection. This is margin is paramount. You need to do biliary reconstruction. Sometimes, like here, you need to do full resection. And the robot definitely makes a difference here because this will never be done with. I strongly recommend them to do that laparoscopically. So this is where the robot makes it. Whether it's better than open, I cannot say. Bilobar complex colorectal metastases, stage hepatectomies, whether it's out or whatever, is still an open case. Huge tumors, tumors more than 5 or 8 centimeters or wrongly located, is still no open case to be. And extreme liver surgery, obviously, replacement of the IVC is still for open surgery. Whether the robot will get there, we'll see. Then the other part, and we addressed that ourselves, is the living donor hepatectomy. We did the first living donor hepatectomy with Olivier Souban in 2002. And this was a left lateral for a child. This is the child, this is the mother. And then it took 10 years to go to the full left, full right. We did the full left when I was in New York with Jean and Ben. And actually, I must say that Olivier, which I don't know if he's here, was the first to do the pure laparoscopic donor right hepatectomy. However, everything was developed in Asia, especially in Korea, where they were able to publish 500 cases. And now comes our friend the robot, because Dieter Breuing published 500 cases of robotic donor. So this is 2002, 2020, 2021, and this is what I call the robotic storm. Donor hepatectomy, high local angiocarcinoma, liver transplantation, and more to come. So everybody at Paul Bruce said, we need a robot. Because what we had at Paul Bruce was a robot once every 2 weeks, so we couldn't get proficient at robotics. So the administration of the hospital says, if you can find half of the money of a robot, we will get it for you. They never thought I would get it. I found it. And we have the robot now, and nobody wants to do laparoscopy anymore. And you know what I did? This is what I did. So now I'm going to show you the result of the survey that I did. I had to go to another presentation because these two slides don't match. So this is the survey. So we'll see. So the name is current. So Mohamed Galam is one of our chef de clinique, and he did all of the work. We worked together doing the questions and everything, but he worked very hard for them, and he made the slides. The current use of laparoscopic and robotic surgery in minimally invasive liver surgery, a global assessment of surgical practice and trends. I reached the International Laparoscopic Liver Society, which is our society, the IHPBA, and also the Society of Robotic Surgery. The latter, Breuing, who is the chief, said okay, but he never sent the survey. We have IHPBA and we have else who have responded. And here are the results. We got 250 replies, but it's still going on. So this is the repartition. Europe was the most, 55%, Asia 18%, North America 15%, South America 7%. This is the repartition. How is the robot present in these? The bias is that those who responded probably have a robot. But the robot is fully operational in 42% of those institutions. Limited access, like 6%. Plans in place. They want to have the plan to have it. No plans and unknown. So basically, you have only 42% who have full access to robotic surgery or HPB surgery in this survey. Age, over 40 years old, 41%. The 50 to 59, 26%, and the older like me, not much robotic, but probably it's changing. I'm sorry, but about diversity, 88% male surgeons. Sorry, but ladies, you need to come out with us. This is just a snapshot of what's the reality. Professional, mostly staff surgeons replied to the survey, and academic university hospitals in 75%. Although you have private hospitals and other type of institutions, I'm going to skip that and I'm going to skip that. The training. Most of the laparoscopic surgeons, those who do laparoscopic, had the self-taught. They learn themselves. But still, 40% of the robotic surgeons are self-taught. You have industry-sponsored training, which is about 25% in both. Formal training, which is a specific fellowship, the formal training. 40% for laparoscopy, 10% for robotics. Mentorship. This is a heat, I don't know, he told me the name, a heat graph or whatever. This is the difficulty of transition from one technique to the other. So open to, the red, orange, etc. is hot, that means that it's difficult. Blue is easy. So moving from open to laparoscopy was difficult more than half of the respondents. Open to robotic was over 50% easy, and laparoscopic to robotic was very easy. So having experience with laparoscopic surgery probably helps transitioning from laparoscopic to robotic. This I'm going to skip because I don't even understand the slide. So now we asked, there are many things that hopefully we'll publish that with all the details and supplementary in the interest of time. So we asked to them, for the following operation, what do you want to what do you choose, open, lap, or robotic? And we asked those who don't do robotic not to respond. So non-anatomical favorable in the easy anterior segment, no open, post laparoscopy, some, but robotic is here, and this is what we can see. Non-anatomical difficult segment, many remain open. Some remain laparoscopy, and this is where robotic starts to come up. Anatomical favorable segment 5, segment 3, segmentectomy, anatomical. Robotic laparoscopy stays in good shape, but robotic is coming up. Of course, it's a moving field. Anatomical difficult segments, many remain in the open surgery. 26% laparoscopic, and this is again where robotic. There's a feeling that everybody believes that when the more difficult it is, probably more robotic will help. I'm personally not convinced about it. But I'm, as I said, this is the swan song. Left lateral sectionectomy, left lobectomy should be smooth. This is the way people understand it. So the left lobectomy for the French or left lateral for the rest of the world is 60% laparoscopic, but robotic comes up again. Anterior sectionectomy, H58, robotic comes up, but laparoscopy keeps. You can see here that this is the phenotype of the surgeons. This is the probably older surgeons. This is the middle-aged surgeons, although I'm in the older surgeons. And this is the younger surgeons. Posterior sectionectomy, the same repartition. Right hepatectomy, about 1/3 each. Left hepatectomy, more minimally invasive surgery with an equality of laparoscopy and robotic. Extended right hepatectomy, now we go back to which extended left, open. Biliary reconstruction, 73% open, but robotic is coming up. 5% laparoscopic. Personally, I definitely do not recommend to do a Klatskin tumor by laparoscopy or robotic. It's been demonstrated that it can happen. Extended right hepatectomy. This was right hepatectomy biliary reconstruction, the same for extended. Left hepatectomy biliary, again, open. Extended left hepatectomy biliary reconstruction, open. And vascular resection, 90% open. One resection during operation. Same for hepatic artery, the same for hepatic vein. But now we have the transplant surgeons who do robotic transplantation. So, in your experience, how do laparoscopy and robotic liver resection compare in terms of the following factors? Cost effectiveness. Laparoscopy much better. It's the only thing that is much better. So laparoscopy is blue. This is a heat graph again. So in terms of cost effectiveness, the robot is not so good, but this is challenged now because probably it's because of its efficiency. Shorter, you can do better operations. So probably morbidity may be lower. So maybe it's going to change in the future. This is just a current dimension. Ease of scheduling. It's difficult because it's more difficult to schedule a patient because there's competition between specialties among every hospital. Except in America, where in Colombia, how many robots do you have in your hospital? Two for you, just for you. And for the hospital? For you. 6 or 8, you don't even know. When I worked in New York, it was 10 years ago, 12 years ago, there were 8 at Cornell where I worked and 8 at Memorial Sloan Kettering across the street. I think this number has probably doubled. Memorial, they have robot addiction. So it depends on where you live, but basically ease of scheduling remains in the most part of the world a difficult. Surgeon ergonomics, the surgeons love that. They don't have to scrub. They can go in their slippers. They can and they sit and they're very comfortable. So in terms of ergonomics, it's much better for the robot. Patient outcomes, no difference for 64% of the respondents. So in my opinion, this is just minimally invasive surgery, just with another tool. Learning curve, more difficult laparoscopic than robotic, and this is something which is not true. Although the bias here is that these people went from open to laparoscopic, and these people went from laparoscopic to robotic, so they had already the learning curve. Will robotic surgery become dominant approach for minimally invasive liver resection? Within 10 years, 36%. Within 5 years, 43%. 5% believe that laparoscopy will improve. Will laparoscopic surgery continue to have a significant role in centers with robotic access? 50-50. In your opinion, what are the primary advantages, if any, of continuing laparoscopic surgery in a robotic-enabled center? Cost effectiveness is the main reason to stick to laparoscopy, to keep a laparoscopic program. Do you think robotic assisted surgery will completely replace laparoscopic liver resection? 54% say yes. And okay, I think the rest will be in the literature. Thank you very much for your question.
Est-ce qu'on a des questions, j'imagine?
Why me to comment this? I never did a laparoscopic. I never did a laparoscopic liver resection, and I never did a robotic liver resection. And I am comment on. So I have no. Yeah, I know, but it was a very fantastic question, and you ask the questions and you give the answers, so everything is there. But okay, 2 minutes to explain. I am going to comment my life in that aspect. 30 years ago, when began laparoscopic, my boss at the time didn't agree with laparoscopic. I was also didn't agree. I committed a big error. I didn't want to do laparoscopic gallbladder surgery. I opened. After 2 years, I regret my error. So what happened? 30 years after, when I finished my career as a surgeon, I need to let that say, look, I can't commit the same error. I am going to give to a better surgeon than me, a fantastic, clever, and intelligent. Here present is my friend Hugo Pinto Marcos, and I need to have the first robot in Portugal in a public hospital. I was terrified that the horrible private surgery in Portugal, horrible private surgery in Portugal, they have robots to show to everybody, and the hospital, public hospitals have no robot. So I said, what I'm going to do 3 years before I leave, I am going not to commit the same error. I am going to find, Daniel said that he find the money, and I find the donor. I don't explain how I find the donor, but I was very proud not to commit the same error. Without doing any laparoscopic section, I know that the robot was not for me, was for my team, was for Hugo. And look, I am very proud because I give him the present. I think is playing with a lot, with the president, perhaps a little bit too much. But I was very proud. We learn with errors. And 40 years after, I didn't make the same error. And now we have two robots in our unity. To finish my comment, Hugo, when they asked me to see, we're going to see a robotic resection of a casket, I was horrified. The man became crazy. And he invited me to go. I was very nervous, more nervous than him. And I tell you, this is for the young people. I have seen, I teach him to do this by open surgery, you know. I'm very proud to do this, the same first classes. And I have seen, I tell you, I have told you a lot of times, I have seen just one Klatskin to a robot. And my comment was, I think there is no better way to do that operation. Okay, the select patient is better than open. I have seen things that with open surgery I never saw in my life in that type of tumor. So I'm an experienced surgeon in laparoscopic, in robotic. My comment is don't forget the future and give to the people who come after you the conditions to progress and to be modern in surgery. Thank you very much.
Thank you very much. To be a closing remark for the talk, but any burning questions for that? Yes.
Danielle, thank you very much for your talk. And I have to start by saying we owe you and a lot of surgeons in this room and who are not in this room a debt of gratitude for all the work that you've done in pioneering MIS hepatectomy and giving the rest of us the wisdom and the bravery to tackle this problem on. You addressed the two challenges with robotic that you've identified. One, the lack of a CUSA, and two, the cost effectiveness issue. Number one, we know the CUSA, as you said, will be implemented in the near future or something similar to that. And the other thing is that new robotic systems are coming on board, Hinotori in Japan and other systems. So as the cost efficiency issue goes away, do you see any reason, or especially for training purposes, to continue training young generations in laparoscopy? Or should we focus and divert our energies when there is access to the robot to robotic training?
Among 250 responses, it was 249 Da Vinci and 1 Inotori. So for the moment, they are 25 years ahead of everyone, Da Vinci. So we're not, and they have like a monopoly. So it's I'm concerned about losing laparoscopic experience because it's not only liver, but will you do a robotic appendectomy? Will you do a robotic cholecystectomy? Will you do a robotic hernia repair? And will you do all your cyst fenestrations with a robot? Will you do all your wedge resections with a robot and everything? So my take on it is that it would be a real pain. It would be a mistake to not to get completely away from laparoscopy. But maybe I'm wrong. I'm not sure. I don't know. So I think that, and the difference between my generation and this generation is that this generation is all MIS. When I started, there was no MIS. So it's a big difference. So I think that the transition to laparoscopy nowadays is much easier than it was when we started as self-taught surgeons.
Yes, just a comment. I don't think at all that we should consider laparoscopy dead. Might be somewhat anachronic, but we have to think the lack of CUSA is one thing, of course, but especially for the cost issue, I really don't believe that the lowering of the costs of robotics is going to happen so fast. On the other hand, even in developed countries that are going to have more and more robots, in fact, in smaller hospitals that need to do laparoscopy, even liver laparoscopy of the liver. This won't happen so fast. And we have a lot of other countries where this is maybe not going to happen at all. So this is something that we have to consider. And this is something that we have to keep teaching other people. And
Thank you for having me. This is the good reply.
Just one short comment, question. You mentioned it already. Intuitive, monopoly. They do everything, they do whatever they want. What do we think about that? But the prices are high, and exactly as you said, they will stay high. They're the only one. So that's
And there's so much in advance. There's also have so much, they're so much ahead of everyone. But they were smart enough to invest at the beginning when nobody would laugh at the beginning. So I think they're just collecting the investment that they have done over the years. Now, the problem of their marketing, where they want to control everything, all the data and everything, is an issue because this is not something that this is a monopoly. It's you have MAGA, which is all the Apple, Google, etc. And now you have Intuitive. Okay, so they're in the monopoly. By the way, they're all American companies. So we're going to have tariffs on that.
Thank you.
Thank
you.
Yes, difficult to speak after such a wonderful talk, Daniel. And I know you are all tired, but I would want to share with you some thoughts about our morbidity. Why? Because surgical morbidity is a key indicator in surgical performance and quality of care, and it's a major concern for each of us, every surgeon, every patient, every institution, and for every surgery. And it is really a big concern because morbidity can lead, of course, to early or delayed mortality. Morbidity has a negative impact on oncological outcomes. Morbidity alters the quality of life, and it has multiple consequences on healthcare system and on economy. Our evolution of HPB surgery, there are two trends, but one goal is to improve the care. It's in one hand, increasing resectability, pushing the technical limits, and we have seen that today a lot. Complex appendectomy, advanced pancreatic surgery, using neoadjuvant treatment, new neoadjuvant treatment to reverse resectability. And on the other hand, we try to improve the safety by selection of patient. We saw that and we discussed that a lot, preoperative preparation, rehabilitation, technical improvements, and all that is to diminish, to reduce operative mobility and increase the cure. So what is exactly the surgical morbidity? The definition is complication or adverse outcome related to a surgical procedure, either during or after surgery, including minor and major events, with different implications in the postoperative course and in the long term. But by the way, what are complication and adverse outcome? How to assess their severity, their real consequences? Did you see this film? This film is The Advantage Point. This is an American film. The scenario is not very original. The president of the United States has been shot, and nobody knows exactly who did that. And the scenario is not so stupid because, in fact, they took in the audience 8 different persons, 8 point of views, to find the real truth. And it's exactly what I'm going to do. In fact, if you talk about morbidity, you have to do some different point of view. The surgeon, the surgical community, the patient, and also the lawyer and the economist. And let's see that. Beginning by surgical community, morbidity is, you agree with me, the best indicator for the short-term result of our surgical procedure. That's what we call surgeon's reported outcome. And of course, you all agree that our major goal is to reduce this morbidity. Reporting and measuring morbidity has been an objective uniform way. And of course, if you can't measure it, you can't improve it. So there is a lot here before a proposed classification. This is the first article to try to set this morbidity, and it was really a big step. And this, some years after, we had this article, which was really the one of the major publication over the years. It was the classification of surgical complication from a simple operation with a cholecystectomy. And you see, not only it proposed the classification, but it validate with a lot, like you see, different countries, different surgeons. So the impossible mission to assess morbidity was possible now with this Clavian-Dindo classification, and it has been from HPB surgery and then for all specialties. And from good to better, it was the comprehensive complication index. It was a numerological scale from 0 to 100. 0 is the death, 100 is the death. And in fact, each complication had a score, grade and 30 points, etc. A very complicated final formula, but a very simple number. And it was a uniform objective classification integrating all the complication for one patient, and it was very useful for evaluation, comparison, and ranking. But of course, this is not perfect. This is not perfect because we have the major limit is the database, and it is very important because we are always referring to very large amount of studies, even in prospective, and we know, and this is again, and he is here, one of the best evaluation of these surgical outcome reporting, and showing that finally, even in randomized trial, there is not enough items, only, like you can see here, 57% less than half of the item that should have been recorded. So this is the first and the major issue. The other issues is the type of indication, because as you imagine, there is different weight of a morbidity depending of what we are talking about. For example, for hepatectomy, the morbidity is different if you talk about hepatectomy for a living donor and hepatectomy for a malignant one. The time also, because you report the morbidity after your operation, your biliary repair, but you can have delayed complication. And the patient also, and it is the basis of the benchmark. You have the perfect patient, but you have also the frail diabetic, obese, and this is different morbidity. And also the institution is important. This is a very interesting article about the pancreatic surgery outcomes. And as you see, they not only compare the mortality rate depending on the Human Development Index group, very high, and low, middle, as you see. And you see that in low and middle group, low and middle institution, you see that the complexity score is decreasing and the failure to rescue rate is up, increasing. So the selection of patient is important, and the institution itself, it's important. And this is very important in morbidity to see what are the teams involved. So now this is the surgical community. Let us see the patient. Let us see the first example, 2 grade 3 complication, but those grade 3 complications are not equal. Let us say the same procedure. Patient 1 has a mesenteric hematoma, not hepatoma, excuse me, requiring surgery at day 2. This is a grade 3 because surgery was required. This patient discharged at day 9. The second patient had a pancreatic fistula requiring percutaneous drainage during 2 weeks, feeling difficulties. Is grade 3A, no surgery, no general anesthesia, and discharge long after. What is exactly the most important morbidity here? Another example, this is the patient 1, diabetic, Wilber procedure, morbidity, fistula, pseudoaneurysm, radiological drainage. This is a mess, and this is Clavin class 4. And for the surgeon, it's a very, very bad outcome. The other is diabetic type 2, Whipple procedure, IPNM, morbidity, not a lot. But he required insulin therapy, and he can be discharged at day 10. This is a success for the surgeon. But what about 4 weeks later when you see this patient in consultation? The first one had good recovery. He eats well, and the patient is very grateful because he saved his life and is optimistic, and he has no problem with diabetes because he was diabetic before. But the other one is still losing weight because he has this gastroparesia, he has a diarrhea, and no social life, is not comfortable with this new insulin, and is depressed because, well, he has to be on chemotherapy, and for the patient, it's very bad. So you see the difference, and this is why it's important to have the patient-related outcome, and this is the limit, because we need that PROMS and PREMS. This is the patient perception of its own situation and impact of surgery in his own life, and the PREMS is the perception of the service. But let us focus on PROMS. This is questionnaire, it's questioned either generic or condition specific, that, and it is fulfilled on paper, smartphone, but this is very important. And why is it important? Because surgical mortality is decreasing and survival is improving. We saw that, leading a focus on another point is the quality of life. And this is really the basis of the minimal invasive surgery we talk about, and assessing the quality of life in patient presenting an hepatobiliary surgery is really paramount. The second reason is because hospital stays tend to be shorter with more home cares, and this is the value of enhanced recovery after surgery. This is the increase of the outpatient surgery and the telesurveillance program. So this is very important to have those PROMs. And because alternative and competitive treatment to surgery become more and more popular, making it necessary, because we have to compare surgery, surgical procedure, but also compare and evaluate different options. So those PREMs are very important, and we have to try to use them. That's the surgeon. The surgeon before, well, a lot of things had changed. Before, the surgeon were the king. And when they happen a complication, deny, minimize, speak of fatality, shift the blame on another, even an assistant or a medic or a doctor. And now this is completely different. The personality have changed. And today, morbidity is less acceptable in our mind, in the mind of the patients. Morbidity can badly affect also the surgeon. And even if it's not a technical fault, and this is different, there's a therapeutic hazard, and it can induce sadness, anger, anxiety, because our job is about empathy. It is a guilt feeling that we failed the patient who trusted in you, self-doubt, loss of self-confidence, the fear of making other error or to experience another complication short after, the shame if surgical error, of course, if there's a technical fault, of course, and being judged by the peers, the colleague, the nurse, all the staff, and fear of course, prosecution and lawsuits. And this medical error has been called the second victim syndrome. And the second syndrome is a real syndrome with psychological symptoms, anxiety, insomnia, depression, or physical even. And this can lead to giving up the career. I saw that in my team, burnout, addiction, and even suicide, and you know that. And of course, there were a lot of paper dealing with that. And they even try to identify risk factors of the development. It is resident, physician already burned out, female surgeons, less experienced surgeon, and finally, those who have problem at home also. So now let us see about the lawyer. The lawyer rapidly, and bile duct injury is the perfect example because you know this is the third. As you see here, I'm sorry it's not very good, but you see that cholecystectomy is one of the major operation that lead to litigation. And in a case of cholecystectomy, the litigation rate in case of complication is 37%. So this is quite important to focus. I try to find some other details, other explanation about the malpractice litigation in HPB surgery. I found 2 articles in pancreatic surgery. And as you see, very few cases, in fact, 34 and 30 cases. It is Whipple procedure, and the main litigation was about not the surgery, but the diagnosis, the complication, and particularly the fact that there was a futile surgery. Now let us see the next point, the economist. The economist point of view, of course, morbidity is also an economic problem because it induces hospital stay, readmission, and the treatment required to those complications are cost effective. And of course, it is also the problem of the work stoppage. So morbidity has a very high cost considering the healthcare issues. So morbidity has to be anticipated, well measured, and also handled. And this is the step I always give to my young surgeons, because this is very important to prepare our surgeon, our students, our residents to face to this very difficult matter. First, you have to avoid. This is to follow the guidelines, follow the recommendations. Then anticipate and mitigate, minimize the severity of an expected complication. And we know that about pancreatic surgery. Detect is not easy, and we have to diagnose early. And very often the litigation comes from not detecting the right morbidity. Accept is quite difficult. Accept because you have to put your ego aside, and exactly the problem of the airplane accident. You have a lot of alarms, but you don't rely on those alarms. Understand in the major step, because to cure, you have to understand the cause, the mechanism, and after you can manage without delay, choose the best treatment, and avoid the major point in morbidity is the failure to rescue. Then, and this is the 7th point, very important, to communicate with the patient and the family. And the best succeed is when your patient said, don't be sorry, I'm okay. So communicate is important. Do not hesitate to ask for help. It is important for the patient, but it is important also for the surgeon. Share with your team. Take a break with friends and families, because this is very important to avoid the second victim. This is quite important too. And Professor Barroso said to exactly the same: learn from your error. Experience is simply the name that we give to our mistakes, and this is a quote of Oscar Wilde. And to finish, yes. Some quotes: success does not consist in never making mistakes, but in never making the same mistake a second time. The second thing, I don't know why it's not. Computer is very tired to whatever. It's what I said that my last quote is a surgeon without morbidity is a liar. With high morbidity is either up. So thank you. Okay. Thank you very much. I don't know. Yes, it's good. A surgeon with no morbidity is a liar. A surgeon with very low morbidity is either excellent or fearful. A surgeon with high morbidity is either bad or very, very progressive. But to finish, the surgeon burden is that it is for me, with experience, our morbidity decreases, but not its acceptance. Thank you very much.
Open for discussion. Discussion.
Professor Tit, wonderful presentation, like usually. And all we know, the good performance associate normally high volume center. And my question is, in your experience, what is your advice, your practical strategy in a low volume center implement to improve the morbidity rate? In the answer, what I say that because in my country we have a few low volume center. That is the only chance for the patient to receive treatment. So, what is your?
Well, I should say, first know your limits, because I think that if you don't know how to do the operation and manage the patient, you have to refer or try to have somebody to help you. This is possible, to call somebody who help you even in a low volume center. And the second point is come here, share with a colleague and try to improve your management. And I think that the most important is to be stick to the patients and to mitigate. I give you the 10 step. If you follow it, even if you don't do the procedure a lot of time, if you follow the steps, well, you will succeed. But I think that well, we know that it has been proved that the morbidity decrease with the volume, of course. You can do what you
I
can
have
do.
a comment. Your 10 steps are excellent, by the way. And, you know, for those of us that live in a very high litigation environment in the United States, I say this all the time, especially to the young surgeons. And unfortunately, my other comment is if you don't follow that, you haven't been sued enough, because it really, you know, tightens your sphincter. And every time you have a problem, you kind of, you know, unfortunately learn from these bad situations where somebody has come after you. But if you can learn those 10 steps before the litigation starts, it will at least decrease your exposure. And excellent. Thank you.
Thank you very much. I think that the major for the young people really is to communicate. When you have a morbidity, go to the patient, go to the family, and sometime, well, when you sometime when you succeed, it's true because I experienced it. The family will say, "Don't worry, we understand. You do the best." If you are really because our ego, when we have a morbidity, is to flew, to avoid. And this is the worst attitude to have. Don't run, don't hide, and just go. And well, it will be better for the patient and for you also.
Lawrence, thank you. Thank you very much.
Sorry, the moderator just gives the order, otherwise you won't see the people.
Okay.
Yeah. And Monsieur Bismuth.
I think I have should be a final remark. Laurence, what you said is really excellent.
Thank
you. Not, I say, but difficult to apply. If all you apply this and you are an excellent surgeon, how you stop?
Wait, say that.
It's really very.
We saw ex vivo surgery.
Oxygen. It is oxygen.
No, it's not. Morbidity is difficult to bear, I think.
All your recommendations, I think you increase the responsibility of the surgeon. I like this. I think responsibility of the surgeon.
I wonder why I say that.
The most important. The responsibility is the most important. And this is exactly an application of all the diktat of the responsibility.
May I now?
Yeah, you
Or-
can.
Thanks. No, I want to congratulate you because you made a great span of and advices for all of us. And I want to stress the M&M meetings in order to understand what happened in each complications. And what do you think about the morbid mortality meetings in order to analyze our
Yes, I had a slide on that, but I don't want to be too long, but it's paramount to do that with your team and to analyze the mobility in order to improve. You have to talk with your team and try to explain the mechanism of the morbidity. So this staff morbid mortality should be friendly, and it's healing process, to my opinion. It's a healing process, and it's the best way to identify if there is a technical fault for something linked to the institution, and you have then to try to find some better system or better management. And this is very helpful. You're completely right. Morbid mortality stand.
I have a question and I have a comment.
So thank you, Laurence. Very nice lecture. So in order to go over these complications and be able to still manage, we probably need to have some specific personality traits. Maybe that's maybe the first question. Do you think that we need specific personality traits in order to go over the complications that we can face? Des caractères particuliers, des spécificités de personnalité qui permettent de passer au-delà de complications qu'on peut avoir. And if yes, do we need to select our future residents according to these personality traits?
It's very difficult to understand it in English and either in French. Well, I think that there is a surgeon personality. This is a surgeon personality, and we are not prepared always to face morbidity. And this is I think this is the basis of the compagnonnage. And when you have a resident, you have to explain that this is a very bad thing that happens to the patient, but we have to manage it. So it's very difficult, but it's really something that you don't learn in the book, in the benchmarks, in the you learn it at the patients with your pair and the peers. And I think that we have a lot of different personalities, But I don't think that any surgeon is not affected by morbidity, because it's our soul to take care of patient. So patient gave truth in us, and I think that every surgeon should be affected by the morbidity in order to improve himself.
I want your talk, and you'll be called to give it to our residents. There are a couple of things that I would add as emphasis on your decalogue, which is recognize you will not be forgiven if you don't listen to families that tell you the patient is going worse. That is really do not. If the family tells you it's getting worse, you say, no, 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 don't worry. And the patient gets worse and is worse, then that will not be forgiven to you. And the other thing is availability. Remained extremely available when the complication. And the last one, sorry, for the both, it's a great occasion to assert leadership. If you shoulder your team who has a complication and bear it together, it's a splendid occasion to be a good boss.
Yes, you're completely right. I have to insist on the concept of the team. In front of morbidity, the team is important, and we have to discuss. And very frequently, when one of us have a very severe complication, you have a colleague saying, "But you can't do either. It's you did good." But what happens, and let us see together. And we have to talk with our colleague, because sometimes it gives you an explanation, or sometimes it opens your eyes, because sometimes the most difficult is to accept it.
Yes.
So share is very important step to face morbidity. Thank you very much.
Well, Laurent, I spend a lot of time indeed to look at complication, etc. But I think we can learn now from success. In other words, you have a patient with high risk, you think will bleed a lot, and everything goes extremely well. So a unexpected success. And we add that to morbidity and mortality conference because you can learn why it went so well in a case when you were expecting problems, and not just the opposite to try to understand the complication.
I'm not. That's interesting. That's an interesting point, because sometimes I say that we don't remember our success. We remember more our failure. That's the point. But maybe we could. But some surgeons do that very well.
Yes. So, being a wonderful session, and we hope to close it just the same way. So, Bo will come to us about robotic liver transplantation.
Guys, so thank you very much. Again, one last effort. We are going to talk about minimally invasive transplantation. And, this is a paper on the first laparoscopic living donor transplantation done by the Seoul National University team. And this was a patient that had 84 minutes of warm ischemic time, a portal vein clamping of 212 minutes. I didn't understand this very well, in fact, even in the paper. But in fact, what we all understood was the editorial by Daniel that showed, in fact, he was very critic about this type of approach. And he finished with this sentence: "For the moment, it is an operation for very few patients and even fewer surgeons." So it was, I would say, not very well accepted.
Still the case.
It's still the case. Not very well accepted by the critics and by the public in general. Then you see the first laparoscopic living donor resection with robotic implantation. And if you look at the image, I think I can 9 trocars or 10, I'm not sure. And also the incision for the gel ports, and also another incision for the chipwood clamp. This patient was at the operation at 12 hours, warm ischemia time of 83 minutes, 10 units of red blood cells. I think this was in fact not a very good first case. They improved with time, but in fact, perhaps the greatest breakthrough was our friend Dieter Boering in Riyadh. He did the first full robotic donor and recipient living donor liver transplantation. With good results, he continues to expand his experience. You can see here the first 10 patients matched with open right graft recipients, and you can see warm ischemia time is the same, hospital stay is better, and in fact, the preliminary results in terms of readmissions, hospital mortality, etc., are pretty good. And in fact, the next publications show that in fact these patients appear to do better than the open ones. For whole liver, robotic liver transplantation, the first one was done in St. Louis in May 2023. The group of Washington University School of Medicine. And this group showed a 62-year-old man with hepatitis C cirrhosis and hepatocellular carcinoma with a MELD score of 10. They used veno-venous bypass, external clamping of the IVC, total consult time of 8 hours. The hepatectomy took 3 hours and 30 minutes, warm ischemia time of 77 minutes, and still the patient did very well. He was discharged at VOD 12 with no problems. We show a little bit of our experience. This is our experience in liver transplantation. Last year, 115 patients. This is our experience in liver and complex hepatobiliary surgery. You can see here that thanks to Eduardo in 2019, we were offered the first robotic platform, and this experience began to grow. Last year, we did 153 robotic resections out of 445. So it's still 35%. It's not all the cases, but we have many cases where we're doing the robotic approach. And up until December 2024, we had 500 robotic HPB resections, of which 455 hepatobiliary or mainly liver complex resections. These are some examples. Until now, repair of bile duct injuries, surgical treatment of platform tumors, more than 30 now, portal vein thrombectomies, IVC thrombectomies done with urology, living donor, living transplantation, the donor operation. At this time, we have 5. And at this time, we have 17 whole liver, robotic whole graft liver transplantation. So with all the experience that we have, experience in complex robotic surgery, including Klatskin tumors, and the experience in robotic biliary and vascular reconstruction, and also extensive experience in liver transplantation. We have now more than 2,800 patients. We considered to begin robotic liver transplantation. And I can tell you our experience. We prepared with adequate material. We trained with discarded grafts for venous and arterial reconstructions. And we selected patients for liver transplantation done robotically, fully robotic. We had 6 patients selected with low MELD HCC in cirrhotic liver and 1 patient with liver metastasis. But in fact, we prepared for a long time, and still those patients were quite far in the waiting lists. And so our first patient was 51 years old patient with ethanolic and HCV cirrhosis with refractory ascites, with a previous episode of spontaneous bacterial peritonitis, and with an umbilical hernia that was leaking ascites. So it was not at all the good patient, and this patient had a surprisingly good outcome after liver transplantation, living at day 11. We published our first experience together with a group of Modena. So three patients in Portugal, 3 patients in Italy. We gathered the whole experience. We published this in January this year in the Annals of Surgery. Again, we have a very critic editorial by our friend Danielle, but at this point I felt, maybe this was just my feeling, I felt it was a little less critic than the previous editorial for laparoscopic. Was I think so? It was friendly. So these are the first patients. You can see we used hypothermic oxygenated perfusion in all patients. During the back table, we are doing this now in the back table. Surgery duration was evidently long. Major morbidity was low. Hospital stay, you can see here that, for example, when you have HCC patients, some patients went home at day 4 or 5 from Modena with this with the fast track problem that they have. But even the patients with more complex disease and more advanced disease also did good, leaving home at day 10 or 11. These are some examples. This is not the most important, but these are some examples of patients that did this approach. This is our setting. We have always two bedside surgeons next to the patient and the surgeon console. This is the way that we do this type of approach. We start with the camera here. The assistant port is located on the left of the camera, and you can see we started using a second assistant port, and we started using an incision first per umbilical. Now we move to removing the second assistant port, and the last patients are being done with the fan and seal incision. We had some problems that I'm going to show you because this is important. This is the fifth patient. We were having more confidence, and we decided first we changed a little bit the team. We changed who did the apatectomy and who did the implantation, and we had an outflow obstruction because we placed the stapler too much inside the IVC, and this patient had to be retransplanted because of this. We had to do a laparostomy that was later closed. The patient is fine now, but in fact, he had a retransplant because of a technical issue related to this approach. This is another patient that we found an unexpected portal vein thrombosis. In fact, we tried to do a thrombectomy and we succeeded, but then the flow was pretty bad, and we implanted the portal vein here in a varicose vein here, and it worked just fine. But this patient was the one that we had to convert due to a small hole in the IVC, and we had to convert the patient because of that, with the portal almost doing perfectly fine. This is another patient. This is just to show you our typical approach. So apatectomy, and you can see here one of the situations where this is actually pretty good. This approach is for segment 1. Now we are in the artery. We can have a very good visualization and magnification that allows us to slowly isolate the hilar structures. You can see the portal vein here. You can see then the bile duct being cut. We try to mimic what we do in open, try not to change most of the approach. Portal vein here. Then you can see the segment 1 approach. You can see the IVC closed. You can see the Arantius ligaments being cut. We are using this bipolar energy device, advanced bipolar, a lot, this type of approach. We go to the right. This is then mainly from left to right, but we have to finish with a right approach. And then we cut the right portal vein, we cut the right hepatic vein, the right portal vein, and the common trunk of the middle and left hepatic vein. And this is already the implantation with 2 bulldog clamps in the IVC, and we actually do clamping of the IVC in those patients to do a lateral anastomosis. See the interior part of the anastomosis. You finish the IVC anastomosis, and we go to the portal vein. We are using Gore-Tex 50. So this is the posterior parts of the portal vein anastomosis. This is the interior parts. There are many small technical details that are improving with time. And if I compare this with the last patients, for example, many small things and small details have changed. This is after perfusion. You can see the artery. And in the artery, I think it's a real advantage. You can actually perform an anastomosis with a much better magnification. Again, we changed some things, inclusively the instruments. We are using different now, and I'm going to show you another example. So it's difficult even to use the 5-hole loop. You can see here. You can see much better. So this is reperfusion. And then we go, for example, in this situation, we know clamp, tie later. There are small things that we are going to change with the video. But in fact, and you can see that for bile duct anastomosis again, you do it pretty much the same way. We are doing interrupted sutures and the anterior part of the bile duct. And that's it. Just to show you one more case, this is one of the last cases. This is the setting. This is again the hepatectomy. And although this hepatectomy looked very nice, this patient has a very serious problem. And this is also important to show here. So hepatectomy was uneventful. Again, the portal vein looks pretty much like the last case. Because again, mobilization of segment 1 from right to left, from left to right. In this video, you can see the extraction also. So mobilization of the right liver, right hepatic vein. Steps in the right hepatic vein. Now we're doing this later after the left one and the portal vein. So total hepatectomy. And after proper mobilization and using clamps, you clamp the IVC, you test the IVC. And you remove the specimen. In this case, it was by a small midline incision. You put it with gently. In fact, we put it as gently as we can, of course. And this is the IVC anastomosis. And in this patient particularly, we didn't cut the IVC of the recipient in an oval-shaped way that I think it's very important to do. And although this anastomosis looked to have no problem, in fact, this was the source of a problem that I will tell you right after this. So we continue IVC anastomosis using Gore-Tex 5-0. We finish the IVC, go to the portal vein. It's sometimes difficult to calculate the right length of the portal vein. It has to do also with the size of the liver. So we continue the portal vein anastomosis. We leave a small growth factor. We reperfuse. Then we go to the artery. And again, in the artery, you can see the advantage now of using a different type of material that is more adequate for this. Different needle holder, needle forceps, different forceps, the micro forceps. And this, in fact, helps a lot. And then again, reperfusion of the artery. And going to the vein. So in this patient, you might see in the ultrasound that although the drainage is good, the portal vein on the right is good, the flow on the left portal vein doesn't look so good. And in fact, this is the bile duct. And in fact, this patient had to be reoperated because of an outflow problem, because in fact, the IVC folded in itself and allowed for difficulty in the outflow. So, in regards to our experience, it's our first 14 patients. We have 17. Some of them were done last weekend with our friend Compagnon Juan Pecol, that is They are pretty uneventful, but you can see here, for example, that we had two patients that were retransplanted, those two that I showed you, and we had two patients, they had to be converted. One because of bleeding, that I've shown, and one because of intolerance of IVC. And in fact, the patient tolerated the clamping, but we had no space to do this sort of well. All the other ones had this is example of the last patient where you can see that the IVC is totally encircled here by the caudate lobe, and still we had no problems in the upper. It was easier than anticipated. So worldwide current status, in Lisbon we had 17 patients done, Modena in Italy 14 patients, St. Louis had 6, Riyadh has done 2 patients, full liver, and in France at least 2 patients were done until now. It's still not an easy procedure. We have to compare this result and the experience with the results that we have open, but I can tell you that it needs some experience, extensive experience in liver transplantation and also in robotic liver surgery. So to finish, we have several caveats to overcome. We have to reserve this for centers that combine high expertise in both transplantation and robotic surgery. Patient and donor selection are critical, but we are in fact becoming less restrictive. Current experience, as you see, is still scarce, and we have to see the benefits of this approach. We have to understand that it's still under evaluation.
Thank you very much, Hugo. It's really a technical challenge, and I'm most admired for this. Now, I don't have any particular comments. We need pioneers for this. And I thought I would. Yes. I thought I would.
It's Pietro.
Yes. So for me, thank you for opening this field. We don't know whether this is we need somebody to explore new grounds, maybe to tell us that there is nothing interesting there and come back. I don't know whether it will be the case. Time will tell. Comments from everyone. Yes. Yeah.
So great presentation. Thank you very much for sharing with us. I think though there are maybe more benefit of use this technique in living donor transplant because the graft size is small. We can also take advantage of being able to do transplant in an early stage of cirrhosis, so the dissection could be easier. Would you really not interested in starting to do these cases with a living donor? And when are you going to do if you're interested?
Well, I think this is an interesting field, and I think that this is another step. In our center, we don't do a lot of living donors, but I think this is a logical step. Living donor is a good step for this. I know Dieter has now at least 80 patients done by this approach, and with good results compared to open, better results compared to open. What we see in full grafts is that at least during the hepatectomy, hemodynamic tolerance seems to be better. And technically, we can see that, for example, for arterial reconstruction, we feel much more at ease. And as we gain experience, we feel even more. We have some problems, for example, with the warm ischemic time. But for example, last patients we had, the 2 last patients were 46 and 49 minutes of ischemia time. And this combined with the hypothermic oxygenated perfusion does nothing to the liver. One of them had a transaminase peak of 400 and the other close to that. So we are overcoming some technical difficulties of this. I believe we may have some advantages. It's still too early to know, but in fact, I think with the experience, we may be able to prove that in some patients, there are advantages compared to open, in some patients.
John?
I greatly admire your
greatly admire this work and your courage in undertaking it. But I would like to challenge that, in the ethical analysis of innovation, you have to define an ethical imperative to create the innovation. This was the principles in the living donor, in the early living donor. Your challenge here, you have 14 cases that you showed. You have 2 retransplants. These are patients who conventionally would have had 98% graft survival, I would think. And so you have a really high burden of proof that that the patient will be better off having this way of working. In contrast to the donor hepatectomy, which is perfect, no brainer. This is a high burden of proof to show this is worth doing.
No, you're right. I think for the ethical standpoint, we have to prove that this is in fact better. And you are comparing, in fact, a situation where you have a lot of experience in open with a situation where you have 100 cases done robotically worldwide. So this is, even in this, from this standpoint, is not a fair comparison, because the experience that you have in open, it's much, much better. I'm pretty sure with the same type of experience, this type of approach would be better. But at this point, in fact, we have to be honest. We encountered some difficulties in the first cases that we were not. And of course, out of 17 cases, to have 2 patients that we had to retransplant is not usual. Our results in open are not like that. But I think, particularly in this phase, it's very important to report them. But I agree with you. It's
Maybe
non-inferiority might be the first step. Right now, you haven't met that.
Yes.
I have a comment and also a remark. I completely agree with Tom. The real benefit will be living donor liver transplantation, that's for sure. But I think when we speak about ethics and these things, the judge is the patient, the recipient, not we. And I know from Breuring, I went there so many times for other reasons. If you ask the patients, the decision is right. And in relation to ethics, I'm a little bit older. I want to make a comment. When Daniel published this paper, the first paper in the Lancet, about the left lobectomy laparoscopically in pediatric transplantation, of course, the ethical judgment came to Professor Ott. I worked with him 20 years. And he made remarks and said that this is unethically acceptable. We do it today, every day in the world. So the evolution is so rapidly. And to give an example, I was in contact with Dieter yesterday. They the same already in children, and they develop now the instrumentation to even do it almost in newborn people. So the limits of this evolution, there will be no limits. And when you start a new method, in the beginning was it laparoscopy was a scandal because a patient died after hysterectomy or because we had 50 burns of the choledocus. But now there are 10,000s of people who benefited from laparoscopic cholecystectomy. My daughter had some weeks ago for a severe cholecystitis, repetitive cholecystitis, she went to the hospital in the morning and at the evening she was eating at my home. So ethics for me, we have not to decide about ethics, the patients will make the choice. And you have shown an article from Maren Schulz. I was really involved in this thing. The last sentence of this article says, in the future, the recipient of a liver transplant and the donor of a liver transplant, he will go on the website. He will look where is a good surgeon who does robotic transplantation, and he will go there. And economically, it will be much less expensive. Because the price is not a problem. There are so many companies. If you go to China, there are 15 companies who make robots. So the prices will go down, so it will change completely.
No. Well. Yes. These are just keep just 1 second for keeping announcements.
Only to say at the end that, you know, the duty of our group is to discuss. We have to improve what we are doing and to do new things. We cannot accept those closed door. If there is a door closed, we need open and see what is outside. This is innovation. Discovery is more difficult. Discovery is break the wall when there is no door. But we must discuss normal that we innovate. It is normal by innovation, of course, in the empty space. So about the last communication, I approve what you do. We are at the beginning, of course. The remark of Jean is correct. You have two reoperation, two retransplantation. This is heavy burden. But you said the technique is beginning. You have to improve it, do new tools perhaps. So I think we need to discuss that. And this is our duty. Okay. And this is, may I say, my final.
Thank you for your remarks. Now, for the gala dinner tonight, the restaurant is expecting us at 20:00 Swiss time seated. So you can come earlier. Please do not. 8 o'clock p.m. We sit at the table. So try to come a little bit earlier. There is no drinks and stuff before. So the idea is that we get there and we stay together until 8 o'clock. Yes. We arrived at 7:30. Thank you very much.